Technology is increasingly present in our lives, shortening distances, bringing faster solutions, and with more practical ways of living day by day. We believe that for all of this to make sense, every solution needs a reason to exist. So, why not focus on using this technology to solve real problems in our society? At a time when neonatology had an important reduction in mortality, and today it has the challenge of preserving the quality of life of patients and their families, in a scenario where the number of children with disabling diseases is very large, representing a hard socioeconomic burden in Brazil and in the world. In a country of continental proportions where the heterogeneity of resources, protocols, and conducts represents a harsh reality. PBSF, Protecting Brains and Saving Futures, was born with the motto of bringing accessible technology and intelligence to prevent neurological sequelae, as with the objective of promoting initial and longitudinal education and training, and also facilitating the implementation of methodologies and tools for early diagnosis and neuroprotection on a large scale. And for this, we created the CSI, a central of surveillance and intelligence where we use an advanced telemedicine system to break borders and shorten distances. In this scenario, we've already monitored more than 4,000 children in more than 270,000 hours of monitoring, distributed in more than 30 hospitals, located in all 5 regions of the country. In addition, we're extremely pleased to work with international partnerships with a focus on education, research, and technological development. But we want to go further, generating homogeneity of protocols and conducts between distant centers and with different resources. With intelligent monitoring, longitudinal education, and capacity building, we can better serve high-risk babies. Together, we can make a difference in the lives of each of these little patients. We believe in the fundamental importance of each of these children being able to read, learn, and believe in tomorrow. Only in this way can we build a country and a better future. PBSF. Learn more at pbsf.com.br. Technology is increasingly present in our lives, shortening distances, bringing faster solutions, and with more practical ways of living day by day. We believe that for all of this to make sense, every solution needs a reason to exist. So, why not focus on using this technology to solve real problems in our society? At a time when neonatology had an important reduction in mortality, and today it has the challenge of preserving the quality of life of patients and their families, in a scenario where the number of children with disabling diseases is very large, representing a hard socioeconomic burden in Brazil and in the world. In a country of continental proportions where the heterogeneity of resources, protocols, and conducts represents a harsh reality. PBSF, Protecting Brains and Saving Futures, was born with the motto of bringing accessible technology and intelligence to prevent neurological sequelae, as with the objective of promoting initial and longitudinal education and training, and also facilitating the implementation of methodologies and tools for early diagnosis and neuroprotection on a large scale. And for this, we created the CSI, a central of surveillance and intelligence where we use an advanced telemedicine system to break borders and shorten distances. In this scenario, we've already monitored more than 4,000 children in more than 270,000 hours of monitoring, distributed in more than 30 hospitals located in all 5 regions of the country. In addition, we're extremely pleased to work with international partnerships with a focus on education, research, and technological development. But we want to go further, generating homogeneity of protocols and conducts between distant centers and with different resources. With intelligent monitoring, longitudinal education, and capacity building, we can better serve high-risk babies. Together, we can make a difference in the lives of each of these little patients. We believe in the fundamental importance of each of these children being able to read, learn, and believe in tomorrow. Only in this way can we build a country and a better future. PBSF. Learn more at pbsf.com.br.
Alors, bonjour à tous et bienvenue à la 11e conférence néonatale de l'Université McGill. Mon nom est Richard Gosselin, je suis le directeur du service de néonatologie du CUSUM à Montréal. Alors, c'est effectivement notre 11e conférence, la deuxième en mode virtuel, et on souhaite ardemment que ce soit la dernière pour qu'on puisse se retrouver en personne l'an prochain. Donc, un thème sur les pathologies et les conditions cardiaques cette année qui devrait intéresser beaucoup de gens. Un sujet très pertinent pour la plupart d'entre nous en clinique. On a un programme très riche aujourd'hui. Plusieurs conférenciers d'un peu partout à travers l'Amérique, en fait. Donc, cette année, autour de 300 participants virtuels. Alors, bienvenue à tous. Some housekeeping requests. So, this is a streaming event, but we're still asking you to keep your microphones on mute. In order to get your questions, we're going to ask you to use the chat on the YouTube channel. And in order to do this, you are asked to log in to YouTube and submit your questions online. The coordinator will then select the questions for the Q&A period. We're also asking you to fill out the evaluations. This is a requirement for CME and as well as very useful for the organization committee. La plupart des présentations de ce matin ont été préenregistrées. Certaines seront données en live, mais tous les présentateurs seront disponibles pour les périodes de questions qui seront bilingues. Donc, on vous invite à soumettre vos questions dans la langue de votre choix, en français ou en anglais. Et les conférenciers pourront répondre à vos questions en direct. J'aimerais remercier nos commanditaires, Mead Johnson, Fisher Paykel, Medtronic, Mallinckrodt. J'aimerais aussi souligner le support que nous recevons de PBSF qui nous permet pour une deuxième année de tenir cette conférence en mode virtuel. Merci beaucoup. Obrigado. Et également la Fondation Anchor qui nous a apporté un soutien particulier qui est très apprécié. Alors, merci beaucoup. Vous pourrez visiter les commanditaires durant les périodes de pause sur la page web de la conférence. I'd also like to mention that most of the presentations are available in PDF format on our website. If you click on other links or other topics, you're going to find a presentation segment where you can access to the presentations. Alors, je pense que le moment est venu de débuter la conférence. Un grand merci au comité organisateur et à nos secrétaires de la division de néonatologie qui nous soutiennent année après année. Merci au directeur scientifique, Dr. Santana, et au co-directeur scientifique, Dr. Alti. Et bienvenue à tous et bonne conférence. Enjoy.
Hello, everyone. Welcome all to this conference. Bienvenue à tous à cette conférence. Alors, we will start very soon. I want to thank again what my colleague and division director, Dr. Gosselin, mentioned, which is to thank all our partners as well as the special help of PBSF and the help of our secretaries. And I welcome you all to this great conference today. Thanks to all the speakers who took some time to really prepare a wonderful conference. And I know that we've been learning a lot, that we will be learning a lot. So on this note, we will start the conference. And our first speaker is Dr. Tsiskar Cavaillé, who is a fetal cardiologist and pediatric cardiologist at the Montreal Children's Hospital. She will be talking to us about some of the practical aspects regarding fetal cardiological evaluation, She is one of the leaders in the fetal treatment and diagnostic group at the McGill University Health Center, which is a comprehensive, multidisciplinary team caring for complex condition during fetal life, and is leading the way into the fetal cardiology program, as well as she is the program director of the training program in pediatric cardiology at McGill University. So on this note, I really want to have a warm thanks for Dr. Tiskar Cavalle, who will be teaching us today on the practical aspect of fetal cardiology.
Bonjour, good morning, everyone. First of all, I would like to thank the organizing committee for inviting me to participate in this conference, along with such a distinguished group of speakers. So thank you very much. It's my honor to be here today. And my talk is on prenatal diagnosis of congenital heart disease and why it matters. I have no conflict of interest. So our objectives are to review the differential diagnosis of critical congenital heart disease based on fetal echocardiographic findings, to demonstrate the advantages of prenatal diagnosis of critical congenital heart disease, and to describe some of the factors that affect the current detection rates of congenital heart disease prenatally. Why do we care about diagnosing congenital heart disease? So as you know, heart disease is the most common birth defect, affecting almost 1% of all live newborns. 15% of those are critical malformations, and alone they're responsible for almost a third of the total neonatal mortality caused by a malformation. So therefore, they have a huge impact on perinatal mortality and morbidity. Congenital heart disease can be accurately diagnosed during fetal life with fetal echocardiography. This is usually performed in the second trimester of pregnancy because at this time the heart is large enough, but the bones have not yet mineralized. So we have almost unlimited acoustic windows. It can also be done in the first trimester of pregnancy to detect severe abnormalities in select cases in which early termination of pregnancy may be indicated. There is a very long list of indications for a fetal echocardiogram, including familial, maternal, and fetal risk factors. However, we must remember that most critical congenital heart disease occurs in low-risk pregnancies. The indication that most often leads to a diagnosis of congenital heart disease is the finding of an abnormal heart on routine obstetrical ultrasound. And this is why we depend on our obstetrical colleagues to optimize the prenatal detection rates of these defects. So the fetal ultrasound in the second trimester is a detailed scan of the fetal anatomy, as you know, obviously including the fetal heart. It is performed by obstetrical sonographers and obstetricians. And the current guidelines recommend that the scanning of the fetal heart includes all transverse views. So the 4-chamber view, the outflow views, and the 3-vessel view. The goal is to recognize normal from abnormal so that the patient may be referred to a fetal cardiologist for a more comprehensive scanning. The fetal echocardiogram itself is a much more complex scan of the fetal heart that includes transverse, sagittal, and short axis views. It's performed by a fetal cardiologist, and the goal in this case is to make a precise diagnosis and make a management plan. The first step when performing a fetal echocardiogram is to identify the right and the left side of the fetus so we can determine the position of the heart and whether the situs is abnormal or not, since, as we know, abnormalities of situs are frequently associated with congenital heart defects. Then we proceed with the transverse views. So here you have the 4-chamber view, the outflow views, and the 3-vessel view. And here are the planes where these images are obtained. So here we have the 4-chamber view. So this is the spine of the fetus, so posterior, anterior, right, and left. So we have on top of the spine to the left the descending aorta. Immediately anterior to this, the left atrium with the pulmonary veins, the interatrial septum with the flap of the foramen ovale bulging from the right to the left, the right atrium, the AV valves with the tricuspid valve inserted more apically, and then we have the left ventricle, the right ventricle with the moderator band, and the interventricular septum. Tilting the probe more cephalad, we obtain the outflow views. The first outflow that we see while we tilt the probe towards the head of the baby is the left outflow, so the aortic outflow, and moving the probe a little bit more cephalad again, we see the pulmonary outflow. If you pay attention to the orientation of the outflows, they're not parallel, they're actually crossing each other. And if they don't, then we suspect an abnormality of the great vessels, most commonly a transposition of the great arteries. And this is a 3-vessel view, which is the most cephalad view of all. So again, posterior, anterior, right, and left. And we should be able to see these 3 vessels, which are oriented in line from posterior and right to anterior and left, and from small to big, and are the superior vena cava, the aorta with the aortic arch, and the pulmonary artery with the ductal arch connecting to the descending aorta. Again, these views are supposed to be obtained in all obstetrical ultrasounds as per current guidelines. These are the sagittal views that are used in fetal echocardiography and that are obtained in this plane. So from right to left, we have the bicaval view, the aortic arch view, and the ductal arch view. The bicaval view includes the inferior vena cava and the superior vena cava draining to the right atrium. The aortic arch view shows the aortic arch that has a candy cane shape. So ascending aorta, transverse arch, descending aorta with the head and neck vessels. And the ductal arch view that has a hockey stick kind of shape, has the pulmonary artery, ductus arteriosus, and the descending aorta. And finally, the short axis views, with the short axis view of the great vessels shown here. So aorta and cross section, and surrounded by the right atrium, right ventricle, and pulmonary artery with branches wrapping around. The low short axis view is actually a view of the ventricles, with the posterior ventricle here, which is the left ventricle, papillary muscles, and the right ventricle here, a little bit larger, anterior, with an interventricular septum that is flat in fetal life because the pressure in both ventricles is equal in the fetus. So critical congenital heart disease can be diagnosed by fetal echocardiography by obtaining the planes that I just described to you, and can be classified in 3 main categories: lesions with duct-dependent systemic circulation, lesions with duct-dependent pulmonary circulation, and finally, mixing lesions, which includes transposition of the great arteries. So I'm going to show you an example of each. This is an example of hypoplastic left heart syndrome. So lesion where the systemic circulation depends on the patency of the duct. And here we have a full chamber view that you will appreciate better when I put the clip into motion, but this is the spine, so the back, the front, the left, and the right, and you can see that the right heart is much larger than the left, which is hypoplastic. So we have here a small left atrium and a small mitral valve and a small left ventricle, and you can see here the clip, again, very small left heart. We could even question whether the mitral valve opens. So here we go with color that demonstrates the blood flow, and we can see the actual mitral valve is patent, there's flow through it. So this is not a case of mitral atresia, it's a case of hypoplastic left heart syndrome with mitral hypoplasia. The other finding here that is important is that, as you can see, there's flow going from the left atrium to the right atrium across the foramen ovale, and this is because of the hypoplasia of the left ventricle that is unable to accommodate all the cardiac output that comes from the pulmonary veins into the left atrium. This is a 3-vessel view in 2D. So again, posterior, anterior, right, and left. We have 3 vessels from posterior to right, from posterior and right to anterior and left, superior vena cava, aortic arch, and ductal arch. So the 3 of them are there, as you can see, the abnormality is that the aortic arch is much smaller than normal because it's hypoplastic. You can appreciate that in motion as well. Very, very small aortic arch that is hard to see even with very small motion on the probe. We actually lose it. And then when we put color, this is what we can see here. So we can see this is the superior vena cava. This is the aortic arch with the trachea here is a left aortic arch, and this is the ductal arch, and you will see it better, as I said, when I put it into motion. But the key here to see is that in the ductal arch, there's normal forward flow. It's going blue flow, that is flow from the pulmonary artery, ductus arteriosus, into the descending aorta. In contrast to the flow in the aortic arch that you can see here in red in the opposite direction. So from the descending aorta up the transverse arch towards the ascending aorta. This is because the ascending aorta doesn't have enough blood flow coming from the left ventricle because it's too small. And so the transverse arch is being fed from the descending aorta, from that blood flow that is coming from the duct. So the ductus, part of the ductus arteriosus flow is going to go backwards into the transverse arch to feed the head and neck vessels and the coronary arteries. So this is what we call a systemic circulation dependent on the patency of the ductus arteriosus. And you will see this better as I put it into play. You can see forward flow in the ductal arch, retrograde flow in the aortic arch, because the aortic arch is being fed from the duct. This is an example of pulmonary atresia VSD, so an extreme case of tetralogy of Fallot where the pulmonary artery, the pulmonary valve is atretic, so a case of pulmonary circulation dependent on the patency of the ductal structure. So here, again, we have a 4-chamber view. We'll see it better in motion, but you'll see that there's 2 ventricles that are of normal size. If this was just a 4-chamber view, it would be hard to diagnose fetal congenital heart disease because the 2 ventricles are normal. But as we tilt a little bit more cephalad, we start seeing that there's a large VSD here, and that there's a large outlet, in this case the aorta, that is overriding this VSD. You will also see that when we tilt a little bit more cephalad, we don't see a clear main pulmonary artery, but there is 2 structures that correspond to the pulmonary branches, the right and the left, and I'm going to put that into play. So you can see 2 normal ventricles, and you only see the VSD when you tilt a little bit more anterior cephalad here, and the big outflow, the aorta here, and then these little pulmonary branches. So you can see this even better with color. So we can see this large outflow and then the 2 little pulmonary branches, but we don't see really a clear main pulmonary artery. So where is the flow from the pulmonary arteries coming from? So here, this is a sagittal view. You will see we have a normal aortic arch. And then here you're going to see that there is another structure, which is the ductal arch, that in this pathology is usually quite small, and it carries retrograde flow. So the blood gets pumped from the ascending aorta, aortic arch, arrives to the duct, and it goes retrograde into the branches of the pulmonary artery. So here you can see red, which is forward flow, in this case, because the transducer is here, so red flow goes towards the transducer, and then blue flow going away from the transducer in the duct to feed the pulmonary artery. So as you know, in the normal fetal heart, the ductus arteriosus is shunting blood from the pulmonary artery into the descending aorta, and in this case, it's the opposite. It's going from the descending aorta through the duct to the pulmonary branches. So again, an example of a lesion with ductal-dependent pulmonary circulation. Next, I'm going to show you an example of a transposition of great artery, so a mixing lesion. So in this view, you have the 2 ventricles and 2 outflows that are parallel. You'll again see it better when I put it into play, but this on itself is a red flag for transposition. So the question is which outflow is which, and You will see it later in another view. So here we have two ventricles of normal size with two outflows that we see at the same level and they're parallel. Again, this is abnormal. If this patient had had just a 4-chamber view, it would have been normal and the diagnosis of transposition would have been missed. So here we can see in this view that in fact the outflow that is coming from this left ventricle is a pulmonary artery because this artery is bifurcating in two branches, the left and the right, and you can see this better in color. So left ventricle, pulmonary artery, the pulmonary branches. We also have a little bit of pulmonary insufficiency here. And finally, I will show you the 3-vessel view for this particular patient. So before I put it into play, this is posterior, this is anterior, this is right, and this is left. As you can see, when I put it into play, that we have a superior vena cava in the normal position. However, there is then another artery adjacent to the superior vena cava, which is not the aorta, it's actually the pulmonary artery, more posterior than normal and bifurcating. And instead of having another vessel here in the normal alignment, we have a vessel just in front of the pulmonary artery in an AP orientation, which is the aorta. So very abnormal 3-vessel view. You can see this better as I put it into place: superior vena cava, pulmonary artery and branches, and an anterior aorta. So as we know, the majority of critical cardiac malformations are well tolerated in fetal life because of the presence of the ductus venosus, foramen ovale, and ductus arteriosus that allow for redistribution of flow within the fetal heart in order to maintain a normal cardiac output. But we know that when the babies are born, if the baby has a lesion that detects on the duct, once the duct is closed, the baby is going to become very sick very quickly. And the same for babies that have mixing lesions that depend on the presence of a foramen ovale of normal size. If the foramen ovale is too small, the babies will be also getting very sick very quickly in these lesions with transposition physiology. So, in fact, several studies have attempted to identify predictive factors for the need of a balloon atrial septostomy in such patients. You can see here a few of those studies that essentially look at the characteristics of the atrial septum and the flow pattern in the ductus arteriosus in these cases. So far, these parameters are quite specific, but not sensitive enough. So most recently, there have been other studies looking at changes in the pulmonary flow pattern in response to maternal hyperoxygenation in both patients with transposition and hypoplastic left heart syndrome with quite promising results. So once the diagnosis of critical congenital heart disease has been made, the management of the fetus requires a multidisciplinary approach, as you can see here. Not only we need high-risk obstetrics, genetics, neonatology, but also interventional cardiology, cardiovascular surgery, and definitely psychology or social work to provide support to these families after receiving such a serious and overwhelming diagnosis. At the Children's, we have a very busy fetal cardiology program with more than 1,000 fetal echocardiograms done every year. So once the pregnant ladies are identified as carrying a fetus with congenital heart disease, the multidisciplinary team takes care of the management with involvement of genetics, fetal maternal medicine, and neonatology. Our cases are presented at our weekly multidisciplinary meetings of the McGill Fetal Diagnosis and Treatment Group, which is comprised of multiple specialists from our network hospitals, including the Montreal Children's Hospital, the Royal Victoria Hospital, the Jewish General Hospital, and also St. Mary's Hospital. So depending on the diagnosis, the multidisciplinary care team agrees on a prenatal management plan for the baby, and recommendations are made regarding where the baby should be delivered, the mode of delivery, the timing of delivery, in which specialists should be present at birth, which is important, particularly if we need an interventional cardiologist to do a neonatal septostomy, or whether a surgeon needs to be present for an urgent surgery or even initiation of ECMO. So we're able to diagnose critical congenital heart disease prenatally and make a perinatal management plan. But the question is, does all this affect the prognosis of these babies? So in the next few slides, I hope to show you how prenatal diagnosis improves preoperative mortality, reduces early neurological complications, and also improves long-term neurological prognosis. So first, I want to show you this population-based study that used the Texas Congenital Malformation Registry data. And during an 8-year period, accumulating more than 3 million births, identified over 400 children born with hypoplastic left heart syndrome. So in this study, the authors looked at the influence on perioperative mortality of factors such as the place of birth of the babies, the location of the surgical center where the surgeries were done, and the travel time from birth center to surgical center. The authors found that the mortality of babies with hypoplastic left heart syndrome was higher the further away they were born from the surgical center where the operation was done. And most of the deaths actually were pre-operatively. So they hypothesized that this was due to more hemodynamic instability in these babies born further away from a surgical center where they receive specialized pre-operative care before their surgery. And they suggest that prenatal diagnosis of congenital heart disease would allow to plan a delivery near the surgical center and mitigate some of these problems, such as instability of hemodynamics and preoperative death. So next, I want to show you a meta-analysis that showed that prenatal diagnosis of critical congenital heart disease actually reduces pre-operative mortality in this population. So before this meta-analysis, there were a number of papers that tried to show an advantage of prenatal diagnosis. However, there were relatively small studies that did not have enough power to show an impact. So in this systematic review from 2015, essentially including all published series up to the date of the publication, they found 300 cases altogether of prenatal diagnosis of congenital heart disease compared to more than 1,000 of cases with a postnatal diagnosis. So essentially, this is the prenatal diagnosis group. This is the postnatal diagnosis group. You can see that we started with 297 patients versus 1,076 in the postnatal group. In both cases, high-risk patients or patients in which the parents had chosen comfort care, therefore not an active surgical treatment. Those cases were excluded, and all of them died in the neonatal period. So we're looking then at congenital heart defects with standard risk in patients in which the parents have chosen actively surgical treatment. And essentially, these were 269 in the prenatal group and a little bit over 1,000 in the postnatal group. So if we look at survival to cardiac surgery, so actual post-op survival, we can see that is very similar in both groups. However, when we look at preoperative mortality, we can appreciate that the group of patients diagnosed prenatally have a much lower statistically significant rate of deaths than the babies in the postnatal diagnosis group. In this table, I list all the studies, including this meta-analysis, and show the odds ratio advantage of favoring prenatal diagnosis in terms of pre-op survival. So essentially, in patients with comparable anatomy, standard risk, with parents opting for active surgical treatments, the prenatal diagnosis was associated to a significantly lower pre-op mortality. And this was the first study to show this. So, okay, so the babies have a lower mortality rate before surgery when the diagnosis is done prenatally. But how about neurological outcomes? Because as you can see, the survival after the surgery is quite high because surgical techniques are advancing every day and are perfecting their outcomes. So this article, published in 2016, studied 153 patients with transposition and with hypoplastic left heart syndrome. They looked at pre and post operative brain magnetic resonance imaging to determine severity of brain damage and degree of brain microstructural development. So here I'm showing the results for the TGA group, but the hypoplastic left heart syndrome group was very similar. And essentially, here we have the post-natal diagnosis group. This is the prenatal group. And these are pre-op MRIs. Here's the percentage of patients, and here is the degree of brain severity. So in the postnatal group, we can see that 50% of patients had no brain injury on MRI compared to 70% in the prenatal group. But furthermore, when we look at the degree of injury in patients that actually did have injury, the severity was higher in the postnatal group than in the prenatal group. In addition, the authors showed that the microstructural development of the brain was more robust in the patients that have had a prenatal diagnosis versus postnatal. And they hypothesized that this is probably related, again, to more stable hemodynamics in babies with a prenatal diagnosis, and therefore preserve normal perfusion to the fetal and neonatal brain. So far, we've seen that prenatal diagnosis allows patients with critical congenital heart disease to maintain greater hemodynamic stability with a lower pre-op mortality, as well as a lower incidence of brain damage on preoperative MRI. But the question is whether these findings translate into a favorable long-term neurological prognosis in the prenatal group compared to the postnatal group. So in this prospective work, the authors investigated the impact of prenatal diagnosis of a number of neurocognitive variables. So they included 45 children between 4 and 6 years of age that had been diagnosed with TGA and had surgery during the neonatal period. And of those, 29 had had a prenatal diagnosis. The authors looked at intelligence, language, memory, and advanced cognitive skills, including social cognition and executive functioning. And they correlated those findings with perioperative factors and the time to diagnosis since birth. So here in this table, we can see the cognitive domains studied, the test used for their evaluation, and then the scores. This is the total group of patients with transposition of the great arteries. This is the control group of normal children. And here we have the TGA group split in two, those with prenatal and those with postnatal diagnosis. So if you look at the scores, in fact, all patients and normal children had similar scores. So everybody had normal IQ, normal language, and normal working verbal memory. But when we look at more sophisticated analysis of executive functioning and social cognition, we can see that as a whole, the group with transposition had much lower scores than the normal children. But when we split the groups into prenatal and postnatal diagnosis, we can see that in fact the babies that had children that had had a prenatal diagnosis actually have normal scores compared to the postnatal diagnosis group, which had lower scores, significantly lower than the control group. So essentially, the postnatal diagnosis group had worse long-term neurocognitive outcomes. And again, this was correlated in this study with a higher incidence of pre-op metabolic acidosis and longer time from birth to the surgery. So these results again suggest that more stable hemodynamics and better brain perfusion and shorter time to surgery in the prenatal diagnosis group resulted in a better long-term executive functioning. So Finally, a word about prenatal diagnosis rates. So I want to show you this study that interrogated the database of the United States Society of Thoracic and Congenital Heart Surgeons and look at factors affecting prenatal detection rates of congenital heart disease across the United States. So more than 30,000 patients that had surgery for critical congenital heart disease before 6 months of age were included in the study, and they were divided according to whether the surgery was done in the neonatal period or in infancy, but outside of the neonatal period. So the neonatal surgery group is in white and the rest is in black here. So you can see that both for congenital heart lesions requiring a neonatal surgery or requiring surgery during infancy, the detection rates went up over time. But in the last year of this study, the detection rates were only 50%, so meaning that only half of the patients with congenital heart disease in the United States had actually a prenatal diagnosis. Here in this graph, what we can see is detection rates depending on whether the defect would have been visible or not in the four-chamber view. So we can see that defects that are visible in the four-chamber view were more frequently diagnosed in this study than defects that are not visible in four-chamber view. So essentially the single ventricle lesions that have very small ventricles, this is very easy to detect in four-chamber view, and that were the ones that were detected with more frequently. Unfortunately, the tetralogy of Fallot and transposition of the great artery, which are the most common forms of cyanotic congenital heart disease, were very infrequently diagnosed because these lesions are not picked up if one only does a four-chamber view, because the four-chamber view is normal. So again, very important to emphasize that fetal ultrasound should include not just the four-chamber view, but also the outflows and the three-vessel view. The fetal heart is a very small structure, very complex structure, and it's not easy to learn to recognize abnormalities. So in order to improve detection rates, it is very important to offer ongoing education to obstetrical sonographers and physicians. And in fact, recently there's been work showing that artificial intelligence and the addition of machine learning algorithms to routine scanning may also help to improve detection rates. So finally, where are we in Quebec with all of this? So in 2019, Dr. Frédéric Dallaire, who is our next speaker, launched the frequency study, which is a Quebec-wide registry to study the epidemiology of congenital heart disease diagnosed prenatally in order to improve the utilization of fetal cardiology resources. So he will share his findings with us today. So in conclusion, I hope I have shown that fetal echo can accurately identify critical congenital heart disease before birth, and that the advantages of prenatal diagnosis are many. It improves perinatal care. It offers less hemodynamic instability and less metabolic acidosis to those babies diagnosed prenatally. It lowers pre-op mortality, and it leads to long-term improved neurological prognosis. I have also shown you that the prenatal detection rates are going up, but are still low. And Dr. Dallaire will talk more about this. But I would like to emphasize how important it is to collaborate with our obstetrical colleagues to encourage adherence to fetal screening guidelines, and also how important it is to develop training opportunities for physicians, for sonographers that perform fetal ultrasound with perhaps the incorporation of artificial intelligence algorithms to improve prenatal detection rates and therefore the prognosis of babies with these defects. Merci beaucoup pour votre attention. Thank you very much.
Merci beaucoup, Dr. Cavaillé. Thank you so much, Dr. Cavaillé, for this great presentation. Our next speaker will be Dr. Frédéric Dallaire. He's a pediatric cardiologist at Centre Hospitalier Universitaire de Sherbrooke, a researcher clinician, and the associate professor at the Faculty of Medicine at Université de Sherbrooke. He is the director of the Mother-Child Research Axis of the CHU Research Center and the founder of the Canadian Neonatal for Research in Congenital Pediatric Cardiology program. I want to thank Dr. Dallaire for taking the time to present today. Just a little word before he starts. If you want to ask any questions, please use the chat option on the YouTube. You just need to log in with your account. And if you're using iPhone or tablet or a smartphone, you need to go through the application of YouTube on your phone or your tablet. So on this note, thank you, Dr. Dallaire, and we will go on to the next speaker.
Bonjour, je m'appelle Frédéric Dallaire, je suis cardiologue pédiatre au CIUS de l'Estrie-CHUS. Je suis aussi un chercheur clinicien au centre de recherche du CHUS et un professeur titulaire à l'Université de Sherbrooke. Merci beaucoup de l'invitation. Le docteur Cavaillé vient de vous présenter sur l'échographie cardiaque fœtale, puis ses capacités diagnostiques, puis la prise en charge qui entoure le dépistage prénatal lorsqu'il y a vraiment une malformation cardiaque qui est détectée. Moi, je vais faire un petit pas de recul puis je vais vous parler du système de dépistage prénatal des malformations de cœur au Québec. Donc, comment on en vient à dépister le fœtus puis à faire un diagnostic par la suite. Je vais commencer par vous décrire de quelle manière on aborde le dépistage prénatal des malformations de cœur. Ensuite, on va nommer les forces et les faiblesses de notre système de dépistage qu'on a au Québec puis au Canada. Je vais vous présenter les résultats de quelques études qu'on a faites sur la performance du dépistage prénatal au Québec, puis de comment on peut mieux utiliser les ressources judicieusement. Puis finalement, on va essayer de regarder un petit peu qu'est-ce qu'on peut faire pour s'améliorer. Des grands principes, dans le fond, qu'il faut connaître lorsqu'on parle de dépistage prénatal des malformations cardiaques sont les suivants. Le premier défi, c'est que le fœtus, il se cache dans le ventre de sa mère, donc il est difficile d'accès, il est difficile à examiner, puis il ne peut pas nous montrer des signes de détresse facilement. Le deuxième défi, c'est que la circulation fœtale est assez particulière, puis il peut manquer la moitié du cœur, il peut avoir des morceaux qui ne sont pas du tout en place, des vaisseaux qui ne sont pas branchés au bon endroit, mais la circulation fœtale va faire que la circulation va quand même très bien fonctionner puis que le fœtus va se développer quasi normalement. C'est après la naissance qu'il va y avoir des problèmes qui peuvent se déclarer. Puis c'est vrai dans la majorité des malformations sévères et critiques. Un troisième défi, c'est qu'il y a certaines malformations qui vont donner des vues cardiaques qui sont pratiquement normales. Donc, il faut vraiment intégrer plusieurs vues cardiaques pour être capable de les dépister. Il ne faut pas s'attendre qu'une malformation sévère va donner toutes les vues cardiaques qui seraient anormales. Il peut y avoir des vues cardiaques qui sont complètement normales. Un des défis significatifs, selon moi, c'est que la majorité des malformations cardiaques critiques va se présenter chez des grossesses qui sont par ailleurs tout à fait normales. Donc, il n'y a rien de remarquable dans la grossesse, il n'y a pas de facteur de risque particulier, la femme est en bonne santé, il n'y a pas d'antécédents familiaux, mais il y a quand même une malformation cardiaque sévère chez le fœtus. Ça les rend encore plus difficiles à détecter. Malgré ça, c'est important de faire du dépistage prénatal parce que ça réduit la mortalité, ça réduit la morbidité, ça réduit le recours au transport néonatal qui pourraient être urgents, puis ça diminue aussi les coûts. Ça permet aux familles de se préparer et dans certains cas de malformations plus sévères, ça permet aux couples de reconsidérer l'avenir de la grossesse si c'est leur choix. Alors, je vais vous parler un petit peu de comment fonctionne le dépistage prénatal en général pour ceux qui ne sont pas tout à fait au courant. Dans le fond, si on regarde un graphique de la conception vers la naissance, on va avoir en général dans un suivi de grossesse standard une échodatation au premier trimestre où on va regarder la clarté nucléaire, on va regarder on va préciser dans le fond l'âge gestationnel et il va y avoir une échographie morphologique qui en général fait autour de la 20e semaine au deuxième trimestre et c'est lors de cette échographie morphologique-là que la majorité des malformations cardiaques vont être détectées. Cette échographie-là, c'est celle qui sert à regarder toute l'anatomie du fœtus, le sexe du fœtus, entre autres, mais on va quand même regarder bien le fœtus. Et c'est, dans certaines grossesses, les seuls examens que la femme va avoir, les seuls examens d'imagerie que la femme va avoir, et dans le cas de l'échographie morphologique, la seule occasion qu'on va avoir de dépister une malformation de cœur. Ce que je vous montre ici, dans le fond, c'est le taux de détection et transposition des gros vaisseaux en Alberta selon les années. Puis vous allez voir que entre 2003 et 2010, on avait des taux de détection qui étaient absolument terribles, autour de 20 et ça a graduellement augmenté jusqu'à presque 80 Puis là, vous voyez, ce qui est marqué CAR 2010, puis ISUOG 2013, ce sont des recommandations des radiologistes et des obstétriciens d'intégrer des nouvelles vues, ou en tout cas d'intégrer les gros vaisseaux dans les vues cardiaques qui étaient faites systématiquement pour chaque fœtus. Et le fait d'intégrer ça, ça a beaucoup augmenté le taux de détection des malformations cardiaques qui étaient, qu'on dit, conotroncales, donc où la vue des 4 chambres est normale, mais la vue des gros vaisseaux, où les gros vaisseaux ne sont pas placés au bon endroit. Ça fait quand même une très, très grosse différence pour ce type de malformation-là. Docteur Cavaillé en a parlé un petit peu, mais dans le fond, la vue des 4 chambres qu'on est capable de voir assez facilement chez le fœtus au 2e trimestre peut être tout à fait normale, comme on voit là, mais les gros vaisseaux eux-mêmes peuvent être anormaux et ça a poussé, dans le fond, ces organismes-là à dire qu'il faut vraiment intégrer des vues des gros vaisseaux pour s'assurer que tout est normal. Je vous montre ici les vues des gros vaisseaux, la vue des 3 vaisseaux, puis la vue de la voie de chasse, de la voie de chasse droite avec le canal artériel, où on va être capable de dire, OK, les vaisseaux sont placés au bon endroit, leur relation l'un par rapport à l'autre est normale, leur taille aussi est normale, et ça va permettre d'aller dépister beaucoup de malformations cardiaques fœtales qui ne sont pas facilement dépistées avec la vue des 4 chambres. Il y a une autre chose aussi qui est faite dans certaines provinces canadiennes, mais pas dans toutes, c'est que pendant toute la grossesse, on va évaluer s'il n'y a pas des facteurs maternels ou des facteurs fœtaux qui peuvent augmenter le risque d'avoir une malformation cardiaque. Donc, si on n'a rien détecté à l'échographie morphologique, si l'obstétricien ou le radiologiste se dit « j'ai vu les vues cardiaques, elles me semblent normales », mais quand je regarde les facteurs maternels et les facteurs fœtaux, il y a un risque augmenté de malformation cardiaque. Eh bien, dans ces cas-là, il y a une recommandation actuelle de tout de même référer la femme pour une échographie cardiaque fœtale. Ce principe-là a été amené il y a plusieurs années, quand les gens reconnaissaient que le taux de dépistage des malformations cardiaques fœtales était pas très bon. Alors, on s'est dit, est-ce qu'on pourrait faire quelque chose de plus? Peut-être que l'échographie cardiaque fœtale serait un ajout intéressant pour augmenter le taux de dépistage, mais comme on ne peut pas le faire à toutes les femmes, on va d'abord cibler les femmes qui ont des facteurs de risque, ce qui semble être une excellente idée au départ, mais qui n'était peut-être pas une si bonne idée finalement, mais en tout cas, c'est quand même quelque chose qui a été adopté de manière assez répandue en Amérique du Nord. Dans ses dernières recommandations, l'American Heart Association va dire que si le risque d'avoir une malformation de cœur est autour de 2 à 3 il faudrait faire des tests additionnels. Ça, dans le fond, un test additionnel, ça veut essentiellement dire probablement une échographie cardiaque fœtale ou dans certains cas de référer en médecine fœto-maternelle. Et si le risque excède 3 il faudrait faire une échographie cardiaque fœtale. Et c'est quelque chose qui a été suivi dans plusieurs provinces. Et ces indications-là de risque augmenté, disons, la quantité d'indications a beaucoup augmenté dans les dernières années, ce qui fait que la quantité d'échographie cardiaque fœtale qu'on fait a énormément augmenté aussi. Je ne vous demande pas de les lire, je voulais juste vous montrer une liste assez exhaustive de toutes les indications de faire une échographie cardiaque fœtale, même si l'obstétricien ou le radiologiste n'a vu absolument rien d'anormal avec le cœur de l'enfant. Mais qu'est-ce qui se passe dans le reste du Canada? Dans le fond, au Québec, puis en Ontario et dans certaines parties de l'Alberta, c'est ce qu'on fait. On va faire une échographie cardiaque fœtale lorsque la femme présente des facteurs de risque, en l'absence d'une suspicion de malformation cardiaque fœtale à l'échographie morphologique. Mais ce n'est pas le cas dans les autres provinces, dans toutes les autres provinces. Je vous montre les résultats d'une étude. Ça, c'est au Manitoba. Ça a été fait il y a quelques années. Eux, dans le fond, avaient trouvé que leur taux de dépistage n'était pas champion et voulaient trouver une manière de mieux dépister ça, puis ils ont mis en place plusieurs programmes de formation qui étaient dirigés à ceux qui faisaient des échographies morphologiques. Et en mettant en place ça, ils ont beaucoup augmenté le taux de détection des malformations de cœur. Donc, avant le programme, c'était 30 de détection. Après le programme, c'était 88 de détection, avec plusieurs années où on avait des taux de détection en haut de 90. Et ça, c'était sans faire des échographies cardiaques fœtales, c'était plus en faisant de la formation, en s'assurant que les gens faisaient bien les vues cardiaques, puis il y avait un processus clair lorsque ces vues cardiaques-là n'étaient pas facilement visibles, puis qu'est-ce qu'il fallait faire avec ça. Il y a une étude assez récente en Ontario qui s'intéressait aux transpositions des gros vaisseaux, au taux de détection prénatale et transposition des gros vaisseaux, qui a montré que, dans les faits, c'était à peu près 50 de détection qu'on avait en Ontario. Ça, c'est dans les dernières années. Donc, quand même, il y a de la place pour l'amélioration. Mais ce qui était intéressant dans cette étude-là, c'était la variabilité régionale qu'on retrouvait. Donc, dans le Toronto métropolitain, c'était 72 de taux de détection, alors que dans le reste de la province, c'était entre 43 et 50 avec certaines parties de la province, surtout les régions qui étaient plus éloignées, avec des taux qui n'étaient pas très bons, 14 Il n'y avait pas beaucoup de monde, il y avait eu juste 7 transpositions des gros vaisseaux, mais de ces 7-là, une seule avait été détectée. Qu'est-ce qu'on devrait faire pour augmenter le taux de détection? Puis est-ce que c'est une bonne idée de faire des échographies cardiaques fœtales aux grossesses à haut risque? C'est pas extrêmement clair. On l'a fait, mais ça avait jamais été démontré si c'était relativement efficace. Ce que je vous montre sur le graphique ici, c'est si on prend toutes les grossesses à bas risque, il y en a environ disons 92 c'est un chiffre qui est difficile à calculer parce que ça a changé dans les années. Mais on se retrouve avec des grossesses à haut risque qui représentent 5-6 des grossesses. Même si 5 à 6 c'est pas un si gros chiffre, ça représente quand même beaucoup de monde. Il y a 100 000 grossesses environ par année dans la province de Québec. Donc, si on prend 5 de 100 000, ça fait quand même pas mal de monde. Puis si on réfère toutes ces grossesses-là dans des ressources spécialisées, ça consomme énormément de ressources. Vous voyez sur mon graphique, il y a une toute petite pointe. Dans le fond, cette petite pointe-là, ce sont les malformations cardiaques sévères. Les malformations cardiaques sévères, celles qui demandent une prise en charge immédiate après la naissance, ou en tout cas une prise en charge spécialisée dans les premiers mois de vie, c'est entre 2 et 5 pour 1000. Donc, c'est pas tant que ça. Puis si on va zoomer sur cette partie-là, on se retrouve avec les malformations cardiaques sévères, mais celles qui sont dans une grossesse à bas risque, donc sans autre particularité à part la malformation, et celles qui sont pour des grossesses qui sont à haut risque. Puis on vous a dit tantôt, c'est environ 85-95 des grossesses qui vont être à bas risque malgré le fait qu'il y a une malformation cardiaque. Si on considère que le taux de détection actuel à l'échographie morphologique obstétricale, c'est entre 65-75 mais il y a toute une partie de ces malformations-là qui ont été détectées déjà à l'échographie au deuxième trimestre. Et ce qui nous reste dans la petite partie grise pâle, ce sont les grossesses à haut risque chez qui la malformation cardiaque sévère n'aurait pas été détectée. Donc, en faisant des échographies cardiaques fœtales à toutes les grossesses à haut risque, le gain qu'on est en droit d'espérer, il est relativement faible par rapport à la quantité absolue de malformations cardiaques fœtales. En fait, ça, c'était en théorie. C'est le calcul qu'on avait fait en se disant, il me semble qu'on fait beaucoup d'échographies cardiaques fœtales, mais qu'on ne trouve pas tant que ça de malformations sévères chez ces grossesses-là. Une des premières, en fait, on a mis en place, lorsqu'on a constaté ça, l'étude de frequency. En fait, ça prend toujours un bon acronyme pour faire une étude, puis il a fallu travailler fort pour cet acronyme-là, mais toutes les lettres s'y retrouvent. Donc, maintenant, on l'appelle l'étude frequency, puis on essaye d'oublier d'où on a pris les lettres, mais ça vous prend un bon acronyme, c'est absolument nécessaire. Ce qu'on a fait, c'est qu'on a jumelé des données administratives du système de santé avec des données cliniques qui venaient des 4 centres qui font des échographies cardiaques fœtales, donc le CHUS à Sherbrooke, le CHUL à Québec, le CHU Sainte-Justine et l'hôpital de Montréal pour enfants. On a regardé ça de 2007 à 2015 en suivant les enfants jusqu'à 2017. Dans ces années-là, on a identifié 693 000 grossesses qui étaient des grossesses avec un seul fœtus. On a dû exclure tout ce qui était grossesse gémellaire. Les femmes qui avaient eu au moins une échographie obstétricale. Donc, on exclut les grossesses qui n'étaient pas suivies de manière régulière. De ça, on a pris toutes les données d'échographie cardiaque fétale. On a identifié 34 000 grossesses qui avaient eu au moins une échographie cardiaque fétale pendant ces années-là. Je vous disais que ça faisait quand même un bon nombre. Puis on a lié ça avec les données de grossesse. On est allé chercher les données des enfants de ces grossesses-là, 690 000 enfants. Puis on est allé identifier lesquels avaient des malformations cardiaques significatives. Donc, les malformations qui demandent une prise en charge à la naissance ou celles qui ont eu besoin d'une intervention dans le premier mois de vie ou encore celles qui ont causé une mortalité dans les 6 premiers mois de vie. On est aussi allé regarder tous les certificats de décès et les certificats de morte-naissance pour s'assurer qu'on n'avait pas échappé certaines malformations critiques qui auraient pu naître dans un centre périphérique sans qu'ils se rendent dans un centre spécialisé où on aurait pu pas les identifier. Donc, on est allé fouiller là-dedans aussi. Il y avait environ 7000 décès pendant toutes ces années-là. On a regardé seulement les décès qui étaient dus à des malformations cardiaques significatives. Pour inclure 688 000 grossesses dans notre étude. On vient tout juste de publier l'article, donc c'est tout chaud sorti des presses. Donc, de ces 688 000 grossesses-là, on a identifié 1564 malformations cardiaques sévères. Ça fait 2 pour 1000 à peu près. Puis c'est à peu près ce qu'on retrouve dans la littérature si on regarde ce type de malformation. De ces 1564-là, il y en a 65,4% qu'on a détecté à l'échographie morphologique. Donc, avant même de se rendre à l'échographie fétale, elles avaient été identifiées par l'obstétricien ou par le radiologiste à l'échographie régulière du deuxième trimestre. Ensuite, on a regardé des grossesses qui n'avaient pas été détectées, combien ont eu d'échographie cardiaque fétale pour un facteur de risque. Donc, pas parce qu'il y avait une suspicion de malformation cardiaque, mais parce qu'il y avait un facteur de risque et ça représentait 12 000 grossesses. Donc, il y avait presque la moitié des échographies cardiaques fétales qui étaient faites pour un facteur de risque sans aucune autre suspicion de malformation de cœur. Donc, une consommation quand même assez significative des ressources. Et ce qu'on a trouvé finalement, c'est que une fois qu'on avait fait ça, on a augmenté le taux de dépistage de 3 points de pourcentage. On est passé de 65% à 68%. Puis on a calculé que ça nous prenait 250 échographies cardiaques fétales pour détecter une malformation cardiaque supplémentaire. Maintenant, on peut se poser la question, est-ce que ça, c'est acceptable? Est-ce que ça, c'est suffisant? Est-ce que c'est une bonne utilisation des ressources? Le débat est ouvert. Notre étude, ce qu'elle servait, c'était de dire, si vous utilisez l'échographie cardiaque fétale pour faire du dépistage, pour aller identifier des malformations cardiaques supplémentaires, voici le gain que vous pouvez espérer en faisant ça, donc 3,1%. On peut aussi regarder les 31% qui ont quand même été manqués malgré tout ce système-là. Donc, on a quand même de la place pour l'amélioration en masse. Si on regarde les données de la même étude, on va voir que dans le temps, l'augmentation qu'on avait eue, là, ça c'est les données pour toutes les années, mais l'augmentation du taux de dépistage se fait graduellement dans le temps. Si on part de 2007 à 2015, il y a quand même eu des gains. Donc, à toutes les 3 années, on s'améliore. Si on regarde la ligne jaune, ça, c'est l'échographie obstétricale. Donc, on s'améliore. À chaque année, on augmente un petit peu le taux de malformation cardiaque, ce qui est une bonne chose. Les prochaines étapes, dans le fond, c'est de se dire, mais qu'est-ce qu'on peut faire pour augmenter ça? Si l'échographie cardiaque fétale, c'est pas une méthode très, très efficace pour augmenter le taux de détection, comment on pourrait faire? Ça, c'est des données préliminaires qu'on a obtenues, puis ça montre le taux de détection selon le centre. Puis ça, c'est à l'échographie obstétricale. Donc, on a pris tous les centres qui ont fait des échographies obstétricales, que ce soit par des radiologistes ou des obstétriciens, puis on a regardé leur taux de détection, Les nombres étaient relativement petits, fait que c'est des données vraiment préliminaires, puis on est en train de bâtir une étude pour augmenter ce nombre-là. Mais, pour regarder la ligne rouge, ça, c'est la moyenne québécoise qu'on a trouvée. On a des sites qui sont à 80 et plus, on a même des sites qui sont supérieurs à 90 mais il y a certains sites qui sont en bas de 50 certains en bas de 40 Donc, à mon avis, s'il y a des gains à faire, ce n'est pas en faisant des examens spécialisés, c'est en allant voir ou en allant identifier quels sont les facteurs qui font que certains sites performent moins que d'autres. Puis en sachant que certains sites sont très, très bons, ça veut dire que c'est possible d'être très, très bon, qu'est-ce qu'on pourrait faire pour ramener les sites qui sont moins performants à la moyenne nationale ou même, si possible, autour des sites qui performent très bien. Moi, je pense que la solution se retrouve vraiment à cet endroit-là. Donc, nos take-home points par rapport à ce que je viens de vous dire, c'est on ne va pas se rendre à 100 de taux de détection. Il y a toujours des malformations cardiaques qui vont être très difficiles à détecter, notamment la coarctation de l'aorte, mais il y a vraiment franchement de la place pour l'amélioration. L'échographie cardiaque fétale, c'est un super outil de diagnostic. C'est possiblement pas un très bon outil de dépistage à cause de l'épidémiologie des malformations de cœur, puis à cause que la majorité des malformations sévères se cachent chez des grossesses qui n'ont aucun facteur de risque. Donc, il faudrait faire des échographies cardiaques fétales à tout le monde, puis ça, c'est certain que ce n'est pas possible. À mon avis, on devrait réserver l'échographie cardiaque fétale aux femmes qui ont une suspicion de malformation cardiaque. Ça devrait servir d'outil diagnostic, mais le débat est encore ouvert, puis on va voir où est-ce que les gens vont se positionner par rapport à ça. La consultation en cardiologie fétale, je pense qu'elle est très, très importante. Puis dans certains cas, possiblement qu'on devrait l'offrir sans nécessairement faire l'échographie qui vient avec, mais ça aussi, c'est encore matière à débat. Et quand on regarde nos données préliminaires, il y a une grande variabilité qu'on retrouve au Québec. Il y a une grande variabilité dans d'autres sites, dans d'autres provinces, puis il y a plusieurs études qui l'ont montré. Donc, je pense que le gain, il est à faire là. Pourquoi il y a de la variabilité? Est-ce que ce sont les individus qui créent cette variabilité-là ou est-ce que c'est la culture institutionnelle? À l'identifier ces facteurs-là, ça va nous aider à faire des gains significatifs. Et si on libère les ressources d'échographie cardiaque fétale en utilisant plus judicieusement les ressources, selon moi, cette libération-là de ressources va pouvoir servir pour aller trouver une manière d'améliorer ça, faire du feedback, faire la formation, trouver en tout cas des solutions pour augmenter le taux de dépistage. Je manque de temps, alors je m'arrête ici. Je voudrais remercier toute mon équipe, particulièrement Michael Paul Cardinal, qui est un étudiant à la maîtrise qui a fait la majorité des analyses de l'étude de Frequency, puis Virginie Carrier, qui est la professionnelle de recherche dans mon laboratoire, mais aussi tout le monde qui a participé à cette étude-là, les cardiologues qui ont accepté de partager leurs données et tous les étudiants qui nous ont aidés à relever les données puis à trier tout ça, puis finalement les organismes subventionnaires. Merci beaucoup.
Thank you so much, Dr. Dallaire, for this wonderful presentation. Our next speaker will be Dr. Edgar Yegi from SickKids at the University of Toronto. Dr. Yegi is one of the pediatric cardiologists with fetal cardiology expertise and the current director of the fetal cardiac program at the Hospital for Sick Children. He is expert in fetal cardiology as well as electrophysiology. He joined the clinical staff of the University Hospital of Geneva and returned in 40 years later to SickKids. And his research and clinical practice focused mostly on prenatal treatment and management, on fetal cardiac anomalies, and in particular arrhythmias. He has authored more than 170 peer-reviewed papers and 25 book chapters in the field of fetal diagnosis and therapy. And we are very privileged to have him speak today on fetal cardiac interventions. Are we there yet? So on this note, I will let Dr. Yegi take the next turn.
I would like to thank the organizer for the really kind invitation to speak at your meeting. I would love to be in Montreal right now, but I hope we can catch up another time. So my topic is treating cardiac conditions before birth. Where are we? The rationale to consider prenatal treatment includes to improve the chances of perinatal survival for conditions with a substantial risk of death, or if death is not imminent, to at least modify the outcome sufficiently to justify the potential risk of the treatment. Now, the treatment by itself should be efficient and safe, including for the co-treated mother. Conditions that were first considered to be amenable to in utero treatment include fetal arrhythmias, most importantly SVT and atrial flutter. I will focus on the former. But, if you analyze the conditions that are frequently associated with fetal heart failure and hydrops, arrhythmias account for about a third of the cardiac causes, a little bit less than the cardiac malformations, but more than anything else together. As soon as fetal imaging became available in the late 70s, early 80s, people started to use transplacental treatment, first with digoxin, followed by flecainide, amiodarone, sotalol, to control fetal tachyarrhythmias. Direct treatment was also considered a management option, which means injecting the medication directly into the fetus or the umbilical cord, but it's commonly reserved now for fetuses that are at imminent threat of in utero demise. Fetal hydrops associated with SVT carries up to 20% of in utero demise risk, while without hydrops, the risk of demise is less than 5%. There's no consensus, however, what drug should be used and which way we should actually start the treatment. Digoxin is for many the first-line management, but some centers will use treatment orally, others will give it IV. SVT with hydrops, which is a group of patients with the highest risk of in utero demise, people will rarely use combination treatment as first-line meds, but start also with a similar treatment, even if this takes longer to cardiovert. Here is an example of a fetus we saw at 27 weeks with persistent SVT. As you can even see, without being a cardiologist, this ventricle is not squeezing well, and there is significant regurgitation through the AV valves. The fetus itself is hydropic. There is ascites, this is the liver and the intestines, and you see there is 2-on forward flow into ductus venosus due to poor filling of the left ventricle, of the ventricles in the setting of a fast heart rate with atriums that contract immediately after the ventricle. At day 16 on the highest medication with sotalol and flecainide that we are allowed to give, so 480 milligram of sotalol, 400 milligram flecainide, the baby finally converted to a normal rhythm about an hour before we had planned to treat directly this baby. The fetal movements started normalizing rapidly. The systolic function became normal within a day of treatment, and the hydrops, however, resolved in only about 5 weeks because there was significant capillary leak into the abdominal and thoracic spaces in this situation. One thing you need to understand if we talk about prenatal treatment, what are the likelihood to cardiovert a baby to a normal rhythm? What's the time frame? It takes 2 to 3 days before the antiarrhythmic treatment even reaches the fetus sufficiently to have some effects. Thus, an early effect is relatively unlikely. Within 5 days, usually we should see some control of the heart rate or even conversion to a normal rhythm. If this is not achieved, often we escalate the treatment and give additional medication or higher doses. And then it usually takes another 5-10 days until we have probably reached the plateau what we can achieve. SVT is more easy to treat than atrial flutter, which only about half of patients we get back to normal rhythm before birth. Atrial flutter is usually well tolerated because it's the third trimester arrhythmia, and these babies are not going to die because of that. But the cardioversion to normal rhythm allows the mother to deliver the fetus normally. With SVT, in particular AVRT, we would like to achieve a cardioversion to normal rhythm, or at least a control of the heart rate to a better tolerated heart rate, so that the baby can survive and doesn't go in heart failure or dies from heart failure. A condition that is pretty scary to see before birth is Epstein's anomaly and dysplasia of the tricuspid valve. In this situation, the tricuspid valve is abnormal and often leaks significantly. When we looked at the outcome in a multi-center study that included 243 fetuses with this condition, about 50% of the actively managed patients died in utero or in the neonatal period. A group that's particularly at risk of uterine demise is the ones that present with significant tricuspid regurgitation. If the tricuspid valve is not competent but severely leaky, the RV is unable to generate sufficient pressure to pump blood forward from the right ventricle to the pulmonary artery. In this situation, the blood flow in the ductus arteriosus is reversed and the condition is duct dependent after birth. The blood will recirculate from the right atrium to the left atrium, left ventricle, and then pump up in the aorta. Patients with significant tricuspid regurgitation Epstein's often have a low cardiac output, even with one functioning ventricle, which is the left one. Now, what happens often towards the end of gestation with a low pressure right ventricle is that the pulmonary valve itself becomes leaky. What happens then is that there's flow reversal in the ductus arteriosus through the pulmonary valve to the right ventricle, to the right atrium, and the blood recirculates between the two ventricles unnecessary. This leads to a low blood pressure and systemic perfusion because about half of all blood that the left ventricle ejects will now go the wrong way and will not be useful for the systemic perfusion. This condition is associated with an extremely high risk of uterine demise, and in fact, if we don't intervene, we have never seen a survivor with these conditions if this was diagnosed in a fetus at about mid or late or early third trimester. Here is an example of an early third trimester fetus, 30 weeks, who has developed pericardial effusion, nuclear edema, and ascites. If you look at the echocardiogram here, you know why this condition often leads to wall-to-wall heart. This heart takes a significant part of the entire chest because the right atrium is so massive because there is a lot of flow reversal in the tricuspid valve, the blue flow, and the right ventricle is not generating any sufficient pressure to open up the pulmonary valve. As expected, the blood flow in the ductus arteriosus is reversed, but in this situation, the pulmonary valve has become severely leaky, which means we have a circular shunt. Part of the consequences includes absent end-diastolic flow in the cerebral artery and low peak velocities into the brain flow and flow reversal in the umbilical artery due to the diastolic steal across the duct. Management option we usually offer to families include no intervention, which will result in uterine demise, delivery plus surgery, but is not going very well in the 30-weeker, as well as attempts to constrict the blood flow across the duct, thus reversing the circular shunt, or at least limiting it by use of NSAIDs. This is shown here. This is in the presence of a huge duct with flow reversal in the umbilical artery and the brain and abnormal flows in these vessels. If you restrict the duct, reduce the flow across the duct, will result in higher pressure in the umbilical artery and antegrade flow in diastole, and the same in the middle septal artery, allowing the baby to have a better perfusion and potentially survive. We started treating this fetus immediately when we saw that with intrametazine 100 milligram 3 times daily. This is now at 32 weeks. The amount of regurg is there's still regurg, but it's less, and the amount of pulmonary regurgitation has also reduced. But most importantly, the flows in the vessels have changed. The middle septal artery flow is now antegrade in diastole, and there are higher peak velocities compared to the middle septal artery, suggesting improved brain perfusion. And the umbilical artery flow also has improved from less reverse flow to no reverse flow in the umbilical artery as a result of the diastolic steel. So overall, stable hemodynamics to birth is what we achieved. We delivered this baby at 36 weeks, went directly to OR, performed a tricuspid valve exclusion surgery, so single ventricle repair, because the right ventricle was unable to generate sufficient pressure. Ligation of the main pulmonary artery in the shunt, and this baby is alive, status postfrontal. Now, we have done that in a number of babies, and they do quite well in the once we control the circular shunt, but there are significant concerns regarding their neurodevelopment. As mentioned before, they have already a relatively low systemic output just with Epstein's, but with a circular shunt, the amount of brain flow, which is illustrated here with the SVC flow by MRI, significantly lower when compared to an Epstein's without a circular shunt, and even when compared to a normal control group. This results in low fetal brain weights, which is worst for the ones with circular shunt when compared to no circular shunt, but is not normal when compared with the control group. So all patients with Epstein's anomaly and tricuspid dysplasia are at risk of neurodevelopment delay, but in particular the ones with circular shunts. When we examined them, and we just published this in Cardiology, a majority of these patients actually have global delay with reduced cognitive language skills and motor skills at 18 months. And it will need more research and close follow-up to really assess the long-term impact of our management. So some warning here that management of patients with severe Epstein's might actually result in handicapped patients. Cardiac tumors is another group you might consider in utero treatment. This is from a series of 37 fetuses that we published some years ago. The ones that died in utero were the ones with the larger tumors. If they were more than 4 centimeter, I think we had no survivors. And the ones that were hydropic, 6 out of 7 had hydrops at the time of diagnosis, while none of the ones that were alive was hydropic. I show you an example of rhabdomyomas, what you can potentially do to save the life of these patients. This was one we saw first at 21 weeks. The tumor is already quite big. Rhabdomyomas tend to grow after 20 weeks or appear, and then can grow rapidly towards the 3rd trimester and become much bigger. So 21 weeks, that's what you saw. This is the left ventricle here. Sorry, go back. Anyway, you see a massive mass here in the left ventricle, and at 29 weeks, the baby is flipped now. This is the tumor filling the entire left ventricle. So the tumor had grown from about 1 centimeter in diameter to more than 4 centimeter. At this stage, the baby is hydropic, and we know from our experience that this will not go well unless we consider management. There have been previous reports to treat cardiorhabdomyoma with mTOR inhibitor rapamycin, and there was about the same time we saw that fetus a first report in the medical literature about maternal sirolimus, also an mTOR inhibitor as anti-tumor treatment for a fetal cardiorhabdomyoma that ended out well. I think ours was the second patient in the literature treated, and as you can see, from 29 to 35 weeks, the tumor actually became significantly smaller. There's again a left ventricle cavity that allows filling, and the ventricle diameter went back to about what you would expect, at least the volume if you did with MRI. But we saw the tumor growing rapidly again when we stopped the medication. So we had to reinduce it after birth for a period of time until we could completely stop it. This is the heart at 3 years of life. The ventricle is not obstructed. There's a small amount of tumor mass left. Rhabdomyomas tends to shrink after birth, which was in favor of that particular baby. This is another example of potential management that's quite aggressive, what we use. It's a pericardial teratoma at 23 weeks in a hydropic fetus. This is the teratoma. This is the size of the heart, and you see the mass is massively bigger. So pericardial teratomas this big leads to in utero demise. The mother was again offered options of doing nothing or potentially to try to operate and remove the tumor mass, which the family elected. This is actually the tumor. This had to be removed in multiple pieces, and this was the scan at 29 weeks, where the heart looks perfectly fine, and there have been no reason of concern, but unfortunately the baby demised a week later for, to us, unknown reasons. Now there's also a group of patients to consider prenatal treatment to fortify the postnatal outcomes for conditions with significant morbidity and mortality after birth, including, for instance, a need of transplant in early life. This includes conditions that often result in single ventricular physiology if left alone in utero, like critical aortic stenosis, pulmonary atresia with an intact ventricle septum where the right ventricle becomes small, but also conditions that can result in damage of the lungs due to outflow obstruction of the restrictive atrial septum, like hypoplastic left heart syndrome, which damage the lungs and make them not repairable after birth with a frontal circulation. Critical aortic stenosis by itself typically presents, if ideally, would present with a dilated left ventricle hypertrophy, but often we see already this at our first echo. But whenever you see a dilated left ventricle with dysfunction and the aortic valve is thickened, we potentially can consider this as an indication for treatment to prevent the outcome on your right, which is hypoplastic left heart syndrome. Hypoplastic left heart syndrome requires a series of surgeries or heart transplant that starts in the neonatal period, goes to 4 years of life, and eventually will require heart transplant sometimes in later in life, because the right ventricle will fail. This is the survival, the single ventricular study, where you see that already at 4 years of life, the chances of survival are only about 60%. So obviously, this is a condition we very much would like to improve the outcome by intervening early. We do have criteria that is quite strict. So the cardiac anomaly needs to be valvular aortic stenosis. The findings we find during mid-gestation are expected to progress to hypoplastic left heart syndrome without intervention to birth. And the biventricular outcome will still be possible with successful intervention at the time of diagnosis. This is not a condition we can wait for weeks. We have to intervene immediately. what we offer is an ultrasound-guided percutaneous procedure that goes through the maternal womb. She's not in general anesthesia, but mildly sedated. She gets freezing of the womb. The baby is muscle relaxed and paralyzed, is given some fentanyl, and we give some atropine to prevent bradyarrhythmias. And then the needle is advanced, larger needle is advanced through the womb of the mother, the abdominal space, into the chest, through the chest of the child, into the left ventricle. With the needle below the valve, we advance a wire, and over the wire will advance a balloon to the procedure. This is shown here on the right. The needle is in the left ventricle. The aorta is up here, you don't see it. In the next step, we have advanced the wire across the stenotic aortic valve. You see the left ventricle is hardly squeezing in this fetus due to the high pressure. So this is a critical aortic stenosis. The next thing is we advance the wire across the balloon across the wire at the right spot, and you see there are two dots which indicates the position of the balloon. So this is the lower end and the upper end of the balloon, and then we inflate the balloon away from the needle tip so that we don't get any rupture of the balloon, and we inflate this several times to achieve opening of the aortic valve. We want something we don't want to see afterwards is aortic regurgitation, but in the fetus this is what we want to absolutely see, because it shows that we were successful opening up the valve. And then we remove everything. We have to watch a few minutes to an hour for developing of pericardial effusion, which we might need to tap, and for bradycardia in the fetus, which we might need to be need to treat with epinephrine and other medication. There is a mortality risk about 15% related to the procedure directly, and an additional risk that the baby might die subsequently due to in the next days due to some complications. So this particular patient was actually our first one that we did successfully in 2009, and the patient came from Quebec, and she underwent only 2 neonatal balloon valvuloplasties, but never required open heart surgery. As you can see, the mitral valve is not normal. The aortic valve is still dysplastic, but opening much better. And there's actually only a mild to moderate gradient across the valve, and there is also some regurgitation, which is mild to moderate. Long term, this will require replacement of the valve, but the findings here are actually quite satisfactory for a condition that could have ended up as a hypoplasty. Now, how often are we able to achieve a biventricular outcome if we intervene? These are the Boston data from 2009 and 2015 compared to early periods. Technically, success, which means you can do the balloon, is about 94% nowadays. 88% were life-born in their series, and 52% of the entire series ended up as a biventricular circulation, which is quite an improvement from early years, where only about 21% eventually achieved a biventricular outcome. If we compare our outcomes from 2009 to 2021, we are in a similar situation, but much less patients. There were 18, and we achieved a biventricular outcome in 9 out of this 18 patients. But in 4, we ended up with a single ventricle or heart transplant repair or compassionate care. There is an ongoing risk of demise after these procedures. For instance, we had one listed for a transplant post-Ross that died from poor LV function, so did not recover. And we had one where we achieved a biventricular outcome, but had to replace the mitral valve which ended up with a clotted mitral valve and died from poor output. Then finally, a group of patients we consider potentially management as a new indication is transposition of the great arteries with an intact ventricular septum. In these patients, if the situation is that the left ventricle pumps into the pulmonary artery and the right ventricle into the aorta with deoxygenated blood after birth, and this condition is critical at birth but well tolerated in utero without any atrial or ventricular communications, these babies are at immediate risk to die. What we can offer, and we have done that twice, is open up the intraatrial septum. In utero, this is 36 weeks. You see the atrial septum is intact. We end up and did balloon dilation, and 37 weeks, and the septum is opened up, and the child has a good outcome without any need of acute emergency management like ECMO. And we have now 2 patients with normal outcomes. So where are we? Where are we going to? There's a rapid evolution in prenatal therapy to aid the unborn baby. I think we have still indications we have to explore further, but some of these kids clearly benefit from the management. I'm open up to any questions that you may have related to this contentious topic. Thank you very much for it.
Thank you so much, Dr. Yegi, for this great presentation and enlightening us about the future of fetal cardiac interventions, both medical and more interventional. So now we will have a Q&A session. So I welcome all of you to provide any questions in the chat that you may have. So we have our panelists here. And the first question is for Dr. Cavalle. We know that currently a lot of the ultrasound screen is currently being done in the community by obstetrics and radiology, and there's possibly some variability across, Canada and even the world. And one of the questions is related to what are the current recommendations and what do you think the future is going in terms of augmenting detection in fetal life in the community during routine ultrasonographic follow-up?
So thank you very much for the question. It is a very excellent question that we are all trying to address. So the current recommendations, as we mentioned in our talk, is for the obstetrical scan done in the second trimester, done by obstetricians and any pregnant woman, is to obviously have a very detailed analysis of the baby's body, and in particular for the heart. The current recommendation is to obtain the 4-chamber view, the outflow view where the aorta is seen coming out of the left ventricle and the pulmonary artery coming out of the right and crossing, and then the higher up view that we mentioned, the 3-vessel view, where from right and posterior and from right and posterior to anterior and left, and from small to big, we see the 3 vessels, the superior vena cava, the aorta, and the pulmonary artery. So every obstetrical scan should have these views, because if these views are not normal, we're not asking the people that are doing the fetal ultrasound to diagnose congenital heart disease. We are asking them to identify abnormal. If things don't look normal, then you refer. Right. So what we think is that education is going to be the main vehicle by which people are going to learn to do this view systematically and recognize abnormalities. As I said, scanning the fetal heart is hard. It's a complex anatomy. We also need to understand the physiology to detect things. When we put, as I mentioned, color, the flows are going in the opposite direction. We need to recognize that that's abnormal. And also sometimes the babies are in difficult positions where, the spine is up and then you cannot see the 3-vessel view well, or sometimes you have twins and the arm is on top of the heart of the other baby. So it can be difficult, but if we develop a systematic approach and we follow the recommendations that are currently put forward by ultrasound organizations, then at least we can say, okay, this is not normal, so I can refer. As Dr. Daller said, just scanning the high-risk population has a very low yield because most of the babies with congenital heart disease are born of women with no risk factors. So there's really a lot of education to be done in the people that are the gatekeepers, the people that do the fetal ultrasound. And as I briefly mentioned, now there's also some developments in terms of artificial intelligence and machine learning and incorporating algorithms to the ultrasound scanning to, raise red flags about abnormalities that maybe the operator cannot recognize. But for that, you need to obtain those views at least, because if you don't obtain the views, then the algorithm cannot be applied. So lots of education, I think, is the key.
Thank you, Dr. Cavalle. Dr. Daller, one of the questions that was asked by a member of the audience, well, actually one of the chair is, are there significant differences in the diagnosis and the outcomes for the congenital heart defects that are detected versus not detected antenatally in Quebec, I suppose, compared to, for example, other provinces in Canada? Oh, Frédéric, we cannot hear you. I think maybe you need to, in the setting, let your microphone, I'll let you troubleshoot that. In the meantime, I'll switch to Dr. Yegi for a question. So thank you so much for exposing us to some of the current fetal interventions and upcoming fetal interventions that you have in your practice. I found some of them were quite very interesting to see, like the NSAIDs treatment for the Epstein's anomaly with circular, physiology. One of the things that came up is regarding NSAIDs treatment. You mentioned that one of the patients came to you at a later gestational age, like 30 weeks. Would you consider treating some of the mothers much earlier if there's an early detection, for example? What is the risk for like post, natal transition regarding, pulmonary vascular remodeling in some of these mothers, the babies?
Well, I hope you hear me.
Yeah, we do.
Okay. So, we have seen, first of all, indomethacin works probably better late in gestation than before, but we have seen actually a twin-to-twin where that had circular shunt, where it worked already at 19 or 20 weeks and closed the duct almost entirely. We had actually one that closed completely, which is not what you want. So we ran into troubles too. The problem with indomethacin, in addition to a low cardiac output, is that you can end up with quite significant kidney damage. I didn't mention that. So renal failure is one of our concerns, and we would not want to have to treat too long whenever possible. But when you have a circular shunt, you have no choice. Either these babies do not well, they die, or you try to treat them. We treated one at the beginning of a circular shunt, and my center has the advantage via fetal MRI, so we can quantitate actually flow and the amount of shunting across the duct and relate it to the findings we have. And this fetus still had antegrade umbilical artery flow in diastole, but already had a circular shunt of 40%. So we started to treat that one before we had the full picture. And that child did actually well. And I think it's probably wise, if you want to have a brain that functions, it's probably wise to start treating when you still have a decent cardiac output. Yeah, I will treat whenever I see something that points me to a beginning circular shunt.
Thanks so much for enlightening us on that. It is a rare condition, but I'm sure, it's a very severe condition, and postnatally, it's much more, troublesome to manage these kinds of circular physiology. So knowing that there are interventions you can do in fetal life. One other condition that we sometimes encounter in fetal life for which, fetal interventions are important is the, anti-Ro, anti-La population of mothers. And we see a fair bit of these patients, at least in our practice. And I was wondering what's your in terms of current management or future possibilities, especially for those that are presenting earlier without signs of, signs of heart block? Like, what's your approach to some of these mothers that initially present with normal rhythm during fetal life? Do you start preemptively some of the treatments and then taper them off? Do you actually just watch them regularly and then start treatment if there's signs of AV block? Like, what's your recommendations?
Yeah, so we have a huge clinic actually with referrals of moms. We know they have the anti-RO antibodies. Our approach is first to get antibody titers because about more than half of the patients do not have anti-RO antibody titers significantly high to cause problems. So these are not the group of patients you need to follow between from 18 weeks onwards. So we actually determine titers using a novel method because they took us our old testing modality away. So, but it's exactly the same finding. You need a high amount of anti-RO antibodies if it's not the cause of the disease, but it's a marker. If we have them, we see them actually weekly between usually 18 and 24 weeks because heart block typically develops somewhere between 18 and 22 weeks. We give them heart rate monitors as well. So they check daily the heart rate in the morning and the evening. If it becomes irregular or slows down, we will see them immediately and start treatment. That's our approach. I left heart block away here in the talk because I know it's contentious, but we just published actually Wadi Mawad, who from your center is the first author. We just published a multi-center study looking at the long-term outcome of patients and survival rates of patients with treated prenatally because we treat them routinely. Once we have a diagnosis of cardiac manifestations, we treat them with steroids, dexamethasone, plus minus IVIG. And our survival is significantly better compared to any previously published study that use treatment only once the baby is not doing well. So yes, we might treat patients unnecessarily, and we will have to define this better. I think one important point is too, we had one single patient that developed a cardiomyopathy after birth, which is one of the concerns with heart block. In the literature, the risk is about 15 to 20%, and these patients are mainly untreated of so-called late onset cardiomyopathy, which means developing cardiomyopathy sometimes as a young child. And this is a very serious condition that often requires a transplant. So we had one patient out in 130 patients we treated that way.
Thank you for your insight because, I know it's a challenging condition and there's a lot of controversy and many questions I received by email are often related to that condition. But
yeah, especially neonatologists are very concerned about the steroids. We have actually followed them in school age, and we have done testing. There's no difference between the treated and the untreated patients with steroids in neurocognitive outcome.
That's quite reassuring.
Yeah.
Dr. Dallaire is back online. Maybe you can try your microphone.
Can you hear me?
Yes, we can hear you.
Oh,
okay. So maybe I'll repeat the question. It was a question from one of the chairs. Dr. Santana was wondering about, is there any differences, at least in Quebec, regarding the diagnosis and outcomes of CHD prenatally versus what's happening in the rest of Canada, and in terms of the outcomes related to the detection?
So the postnatal outcome we have not studied. It's a great question, but we haven't compared if the postnatal outcome were improved by prenatal detection. I think this was the question. If we look at the prenatal detection, it's kind of similar to what we have seen in Canada for where it was studied, with better detection of univentricular heart or all the lesions that have an abnormal fortune review, but this lower detection from those with an abnormal outflow tract view, like tetralogy of Fallot or transposition of the great artery. The numbers are very, very, very similar to the rest of Canada. The postnatal outcome we haven't studied specifically. One thing I would add to Dr. Cavier's comment when she said what we expect from obstetrician and radiologists is to identify abnormal hearts. I think what we expect from them is to identify a normal heart. And if they can't, if they're not sure if the heart is completely normal, these are the fetus that we want to see in fetal cardiology. Because there's some gray zone where we think it's normal, we're not sure, something is weird, we're not sure. Those should probably be referred for a complete fetal echocardiogram. And I think if we free up from some of the resources because we scan less of the fetus where the obstetrician was completely sure it was normal, then we'll have lots of room and lots of resources to scan the we're not sure, it's borderline, we haven't seen very well. So we expect to be referred those where we're not sure it's normal. And not those we're sure it's abnormal. It's
Absolutely, I totally agree. So, and we do scan many of those that, the obstetrician is not sure. We receive a lot of calls. I'm not sure. Should we see this patient? Of course, if there's a question, we are here for those patients. Absolutely.
And Dr. Dallaire, stemming from the frequency study that you're on that's currently ongoing, do you think that there's a push or a move, at least across Canada, to standardize the recommendations, or do provinces speak to each other? Who actually pushes the way we refer to fetal cardiology?
Well, it's there'll be a lot of debate because, as I said, if you go from province to province, they have completely different approaches to prenatal diagnosis. So one thing we want to do is to compare actually with another province. If you don't do fetal echocardiogram for risk factor, does it improve your detection rate compared to a province that does? And I think there is some talks to have a Canadian recommendation to the prenatal diagnosis of CHD, but I'm assuming that these discussions will be heated because people have been doing what they're doing for years and years and years, and I don't think people will say, oh, let's change that completely. But we'll see. We'll try to have something that can be applied. There's no reason to be so different from something that could be very standardized, but I'm assuming it will be heated discussions.
I think it will help any QI or research if we all agree across Canada with the way we manage these pregnancies. One last question before the break. We have 2 minutes. It's for Dr. Cavaillé. You addressed a lot like what's happening also in the community for referral, but once these mothers come under your care, many of these mothers are referred because the views are not so great, or there's maternal obesity, maternal diabetes, and then it's hard to access actually good images for detection. Because we have a lot of pediatric cardiologists and fetal cardiologists on the line, what would be your recommendation? Are there other modalities to try to obtain some of these images or clarify the diagnosis if there is indeed a CHD or not? Should these mothers just deliver in a tertiary care center because we're unclear about the cardiac anatomy? So what would be your advice on this?
So really, realistically, ultrasound is the only modality. For people that have difficult windows, there's always the option of transvaginal ultrasound instead of transabdominal, which is not done routinely. But I think in general, if it's not that the heart, it's very rare that the heart cannot be seen completely, right? It's that maybe some images are harder to see for detail. I think in my experience, it's rare that the imaging is so bad in the hands of a fetal cardiology unit that we have no clue whether the heart is normal or not. So I think those cases have to be taken as a look at as a whole. Sorry for the background noise, and see if there's any risk factors. What have I seen? What have I not seen? Where does the person live? And so it's not there's not like a black and white answer for this consideration. But I think if we can't see very well one part, but overall everything looks normal, we may say, okay, you can deliver locally, but then we can see the baby after birth. It depends. It's a very, very gray kind of answer, I know, but it depends of how much have you seen, what are the risk factors of the patient, where do they live, how easy is for the baby to come after birth right away. There's many considerations. And then always people ask about cardiac MRI. So maybe that's why the question came up. It's not something that is readily available. It is a sick case, but you need special equipment. You need to gate for a baby that is inside the mother, breathing and with a beating heart. So it's not something that can be done without a certain degree of organization and a proper setup. So in certain occasions that could be done. And maybe Dr. Jay wants to add on this.
Actually, we do very rarely MRIs for this indication, and then we have usually problem that the patient might be too big for getting into the MRI. So it's not something we do. I can't recall that we have seen not sufficient images to have some idea on the cardiac findings. I think it's rare. If you know, honestly, I can't recall. I have not seen enough to be quite sure about the finding that this is a normal scan.
Perfect. We will finish here and go on break. Thank you so much for our panelists, Dr. Dallaire, Dr. Yigui, Dr. Cavaillé. Thank you for your great presentation, and we'll be back at 10 a.m. for the next presentation. For all the audience, please make sure to fill up your feedback and evaluation form on the website. We will see you back in a few minutes at 10 a.m.
Every solution needs a reason to exist. So why not focus on using this technology to solve real problems in our society? At a time when neonatology had an important reduction in mortality, and today it has the challenge of preserving the quality of life of patients and their families, in a scenario where the number of children with disabling diseases is very large, representing a hard socioeconomic burden in Brazil and in the world. In a country of continental proportions where the heterogeneity of resources, protocols, and conducts represents a harsh reality. PBSF, Protecting Brains and Saving Futures, was born with the motto of bringing accessible technology and intelligence to prevent neurological sequelae, as with the objective of promoting initial and longitudinal education and training, and also facilitating the implementation of methodologies and tools for early diagnosis and neuroprotection on a large scale. And for this, we created the CSI, a central of surveillance and intelligence where we use an advanced telemedicine system to break borders and shorten distances. In this scenario, we've already monitored more than 4,000 children in more than 270,000 hours of monitoring, distributed in more than 30 hospitals located in all 5 regions of the country. In addition, we're extremely pleased to work with international partnerships with a focus on education, research, and technological development. But we want to go further, generating homogeneity of protocols and conducts between distant centers and with different resources. With intelligent monitoring, longitudinal education, and capacity building, we can better serve high-risk babies. Together, we can make a difference in the lives of each of these little patients. We believe in the fundamental importance of each of these children being able to read, learn, and believe in tomorrow. Only in this way can we build a country and a better future. PBSF. Learn more at pbsf.com.br.
Good morning, everybody. I hope you can hear me. Is that okay? So we're gonna keep going with the conference after those three great talks. So in the next block, we have 4 presentations. So, we'll keep the same style. So please put your question in the chat. I'll be moderating this session. I promise I will look at your question and convey the question during the QA section. So our next speaker is Dr. Dancia. Dr. Dancy is an associate professor of pediatrics, director of the Heart Catheterization Lab, and since 2009, he's the pediatric cardiology division head. His clinical research interests include, of course, the interventional cardiology, pulmonary hypertension, and long-term follow-up of patients with congenital heart disease. Today, Dr. Dancy will be talking about screening for congenital heart defect and beyond screening, the key pointers on physical exam and history. Thank you.
Good morning, everyone. My name is Adrian Dancia, and I'm a pediatric cardiologist at the Montreal Children's Hospital. It is my pleasure to share with you this morning my thoughts on screening for congenital heart disease in newborns, the role of oximetry as part of the general clinical assessment. This will be a case-based approach to this issue. I would also like to thank the organizing committee for providing me with the opportunity to share my thoughts on this topic this morning. I have no conflicts of interest. The first objective of this presentation is to understand what key findings on history and physical examination should trigger a consultation with a pediatric cardiologist. The second main objective of this talk is to understand the role of oximetry in the screening of newborns with severe congenital heart disease. I will convey my message by using 3 clinical scenarios, all of which are inspired from my recent practice, that I think illustrate the use of oximetry as part of a general clinical assessment in newborns with suspected congenital heart disease. The first case is that of a newborn with cyanosis of a few hours of age. The history is brief and self-explanatory. This is a term newborn born after an by his nurse, Dusky, at which point she performs an oximetry and notices that saturation is 72%. She also makes note of the fact that the child is in no respiratory distress. Now, this is a pretty straightforward history. However, I'd like to share with you my thoughts on what are the red flags on a history in a newborn that might point you in the direction of congenital heart disease. First, is there any clues on the obstetrical ultrasound, or even better, on a fetal cardiac ultrasound, if one was done, that might point you in the right direction, or at least raises a suspicion for a possible congenital malformation of the heart? Were there any findings on the amniocentesis that uncovered a chromosomal anomaly that is known to be associated with congenital heart disease? Is there a previous child or a strong family history of congenital heart disease? Was there a history of gestational diabetes? Because as we know, the presence of gestational diabetes increases the likelihood of congenital heart disease 4-fold. Similarly, a history of in vitro fertilization is associated with a 45% in risk for congenital heart disease. We know that certain viral infections with rubella and CMV, for instance, are associated with an increase in congenital heart disease. And finally, ingestion of certain substances such as alcohol, lithium, anticonvulsants, or exogenous female hormones can increase the incidence of congenital heart disease. Your complete evaluation at 6 hours of age is that of a newborn who is in no respiratory distress and is not dysmorphic. You validate that indeed the child is cyanotic. You repeat the saturation in both the right arm and the right foot, and it's giving you similar numbers, but no difference. You confirm this a few times, you change probes. At this point, you are trying to become concerned and appropriately worried about the possibility of heart disease. The rest of the vitals, fortunately, are unremarkable. The child is warm, well perfused, with a normal precordial activity, with normal heart sounds and no murmurs, and the liver is normal in volume, as are the peripheral pulses. So what happened to this child? Well, you have appropriately given supplemental oxygen at 100%, and that did not sort of affect the saturation. You're concerned about this child, and you intend to start prostaglandin, which you do have in your nursery, and you intubate this child, not without difficulty, prophylactically, and you start prostaglandin after consulting with the referring hospital to do so. The child is transferred to the Montreal Children's Hospital urgently. Your friendly cardiologist, who has been already advised about this child coming in, being quite blue, is at the bedside, and we immediately or very quickly make a diagnosis of transposition of the great vessels that is followed immediately by a balloon atrial septostomy done at the bedside and a surgical repair following the next week with excellent outcomes. So what are some of the pearls from this vignette? Well, as I've mentioned already, alluded to already, the presence of severe cyanosis in the first hours of life without respiratory distress that does not respond to 100% oxygen should immediately point you in the direction of a congenital heart disease until proven otherwise. The other important message from this vignette is that PGE, you should have it in your nursery because it's going to be a crucial medication to stabilize the child and before transfer and during transport to a tertiary care pediatric facility. The second case is that, again, of a term newborn with a murmur and who fails your oximetry screen. Now, the history, again, is very unremarkable. This is a term newborn born by vaginal delivery who is completely asymptomatic and who has no red flags on history. I've just mentioned some of the red flags that you should be looking for. And the child, as per routine, undergoes an assessment at 30 hours of life. So your evaluation, or complete evaluation at that time, reveals a child that it's non-dysmorphic and is in no distress with unremarkable vitals. However, when you do the oximetry, you notice that the oximetry in the right arm is 92% and in the left foot is 91%. As per your protocol, you repeat these measurements 1 hour apart a couple more times, and then you've established that this is a failed oximetry screen, and therefore more needs to be done. Your rest of the physical examination is remarkable for the presence of potentially an extrasound and a 3/6 systolic ejection murmur at the left sternal border. Your peripheral pulses are normal, and the liver is normal in volume. So now a word about oximetry. I think that summarize this slide is that you should be doing it. I think that for those of you practicing in nurseries that do not yet have implemented an oximetry protocol, a screening protocol, you should be looking into establishing one, and we'll be happy to share with you our experience and our protocol so that you can implement something similar in your institution. The oximetry screening is now mandatory in several provinces in Canada, not yet in Quebec, although I know that the appropriate instances are looking into making this a mandatory screening in the next couple of years. It is a non-invasive and inexpensive test. By itself, oximetry has a specificity of 99.9% and a sensitivity of 76.5% in detecting congenital heart disease. However, as it's an usual practice, when combined with clinical examination, the sensitivity goes up to 92%. In order to decrease the number of false negatives, the false positives, screening should be done after the first 24 hours of life. And it is important to measure the saturation in both the right arm and one of the lower limbs. When you do implement a screening protocol in your institution, the data shows that you increase the likelihood of detecting congenital heart disease more than 5-fold time. For that reason, many learned societies, including the Canadian Cardiovascular Society, have fully endorsed implementation of oximetry screening in newborn nurseries, as and this has been published in 2017 in the Canadian Journal of Cardiology. Similarly, the Canadian Pediatric Society has also endorsed it, as have the American Association of Cardiology, etc. In terms of the protocol, I don't want you to stress about this particular slide, which is very busy. Again, for those of you who practice in nurseries that do not have this established, it's very feasible, it's easily done. We'll be happy to share our experience and our protocol with you. Some of the key points in this protocol, I don't want you to follow this to go into the details of this at this point. It wouldn't be necessary at this point, but screening should be done between 24 and 36 hours of life. As mentioned previously, you should measure the saturation in both the right arm and one of the lower limbs. What constitutes a positive, at least in our protocol, it's saturation less than 95% or more than 3% difference between the right arm and one of the lower limbs. For borderlines, we do 2 more measurements before calling it a fail and involving more people into making the final diagnosis. What about the clinical evolution in this child with a failed oximetry screen? Well, the baby was transferred to the NICU. The failed screen actually happened at the Royal Victoria Hospital, so the transfer was pretty quick. We saw the child very quickly in consultation. We made a diagnosis of critical pulmonary stenosis. PGE was started. The child underwent a few days later balloon dilatation of the pulmonary valve with excellent results, and the child was discharged home 1 week later, on no medications. So what are the pearls from this particular case? Again, it's important that you look into, if you don't have already, to establish an oximetry protocol in your nursery. In order to decrease the number of false positives, you should screen between 24 and 36 hours of age. And it's important to increase the sensitivity of your screening protocol to complement your oximetry with a rigorous and a complete physical examination. And again, repeating from the first vignette, availability of PGE is going to be important in the immediate stabilization and management of this child. So make sure that you have it in your nursery. The last case that I'd like to discuss with you is that of a late preterm newborn with feigned femoral pulses and failed oximetry screen. So the history is that of a late preterm child who was born by C-section for decelerations. At birth, you've noticed mild respiratory distress. In terms of your history and in terms of looking for the red flags that I've mentioned, there is a history of maternal diabetes. And after the initial stabilization of the child is transferred to the nursery, to the NICU for CPAP treatment. Your complete evaluation at 24 hours of life shows a non-dysmorphic newborn in mild respiratory distress who is on CPAP. The heart rate is 150 beats per minute. The respiratory rate is slightly elevated in keeping with the respiratory distress. And of note, you know that there is a pressure difference between blood pressure difference between the right arm and the right leg. And when you do your oximetry, the oximetry in the right arm is normal, 97%. However, the oximetry in the left foot is 92%. And as per your protocol, which you have already implemented in your this is repeated twice, and again you confirm that this is a fail. The rest of the physical examination, the precordium is normal, the heart sounds are normal. There is a non-specific systolic ejection murmur at the left sternal border. You notice when you examine the pulses that the brachial pulses are normal. However, you have some difficulty feeling the femoral pulses, although you feel that they're there. The liver is present at the right costal margin with a sharp edge. A word about the peripheral pulses. This is an important part of the physical examination, then one that should not be skipped, omitted, or gleaned over. It should be done carefully, and when you do that, you should carefully examine the volume of the brachial versus the femoral pulses. You don't try to look for a delay. That'd be very difficult to assess in a newborn, but just look at the overall volume of the brachial versus the femoral pulses. We've mentioned that in this particular scenarios, 4-limb blood pressures were done. It's something that is routinely done in our nursery. I would sort of warn against some of the technical limitations of performing 4-limb blood pressures in newborns. They revolve around the problems with movement of the child that makes some of the measurements difficult to interpret, or not using the appropriate, for instance, a cuff. So I think that's a useful part of the physical examination. I would not assume that the child does not have a significant obstruction in this particular left-sided obstruction, just based on the fact that that there's no difference in pressure. Now, in terms of in this scenario, we've noticed that there's a difference in saturation, and this is what constitutes, in this particular case, the failed screen, the fact that there is a 5% difference between the right arm and the left foot. When you're faced with this persistent difference in saturation, well, that raises essentially a differential of two main areas, two main physiologies. One is left-sided obstructive lesions, be it aortic stenosis, coarctation, plastic left heart syndrome, interrupted aortic arch, or perhaps more commonly, that of persistent pulmonary hypertension of the newborn that can be caused by a variety of causes. So in either case, even if it's not a congenital heart disease, the presence of persistent pulmonary hypertension, as you will all agree, is something which is worthwhile noticing, evaluating further, and also treating. Both of these physiologies that I've described before, left-sided obstructive lesions or persistent pulmonary hypertension of the newborn, will be associated physiologically with right to left shunting at the PDA level, explaining, therefore, the difference in saturation. The clinical evolution, this child underwent urgent consultation in cardiology, and a diagnosis of coarctation of the aorta was made. PG was started. Coarctation was repaired surgically at 5 days of age with excellent results, and the child was discharged home 2 weeks later. The pearls from this case is that when you're applying the oximetry protocol, it's not sufficient just to look at the saturation in one of the limbs, but you really have to look also at the differential between the right arm, the preductal arm, and one of the lower limbs. You have to meticulously examine the peripheral pulses, and again, have PG available in your nursery. So some of the takeaway points from this presentation that I like to remind you of is, in terms of the history, look for the red flags that we talked about before. And one of the things that would add, is important to, some of the information or some of the questioning regarding the possibility of congenital heart disease might already been raised by the obstetrician or by the fetal cardiologist. So look for that evidence. If you haven't already, please implement an auxiliary protocol in your nursery. Please pay attention to the pulses, and in particular the difference in volume and pulses between the brachial and the femoral pulses, and make sure that you have PG available in your nursery. I'd like to thank you for your attention, and I'd like to open the session.
Thank you, Dr. Dancia. It was a great presentation, very practical. I love the cases, and I'm sure a lot of people will benefit from the take-home messages you gave. I just want to make a note that Dr. Dancia is on service. He might not be able to join the QA session, as well as Dr. Jean-Marc Coté. Both of them will take questions by email. We're going to put the emails on the chat, so if you have questions to them, please just email them. Next speaker is Dr. Jean-Marc Coté. He's a full professor in the Department of Pediatrics at Laval University. He's a pediatric cardiologist at the CHU de Quebec and the pediatric electrophysiologist associated with the IUCPQ. Dr. Coté has a particular interest in the invasive management of arrhythmias in children, adolescents, and young adults. He created the Pediatric Cardiology Training Program at Laval in 2004, and he's the head of the Pediatric Cardiology Department at CHU de Quebec since 2019. Today, he's going to talk to us about the approach to the common neonatal arrhythmias. Thank you.
Bonjour tout le monde, il me fait plaisir de vous rencontrer aujourd'hui et de pouvoir vous entretenir de l'approche des arythmies néonatales courantes. Cette conférence fait partie de la 11e conférence néonatale à McGill, tenue le 1er juin 2022. Je suis cardiologue pédiatre, électrophysiologiste formé à Montréal et entraîné par la suite à l'hôpital de Boston pour enfants dans le domaine de l'électrophysiologie pour la prise en charge des arythmies et le traitement invasif des arythmies. J'ai aucun conflit d'intérêt à déclarer. À la conclusion de cette présentation, le participant connaîtra les principales arythmies retrouvées en période néonatale. Il sera familiarisé avec les critères diagnostiques des principales arythmies et il aura démystifié la prise en charge des arythmies courantes du nouveau-né. Avant d'aborder les arythmies, cependant, je vais redéfinir le rythme sinusal normal. Il faut être capable de reconnaître le rythme normal pour pouvoir différencier celui-ci des arythmies. Car le nouveau-né qui présente des arythmies cette arythmie pourra être de 3 catégories. Soit que le rythme sera irrégulier, soit que le rythme sera lent, ou soit que le rythme sera tachycarde au-delà des normales. Et c'est ces 3 types d'arythmies que nous allons définir et caractériser aujourd'hui. Le rythme cardiaque normal d'un nouveau-né se situe généralement entre 100 par minute et 180 par minute. C'est généralement le rythme sinusal normal. Lorsque l'enfant est bradycarde, il peut être bradycarde de façon modérée. On aura affaire en général à de la bradycardie sinusale ou un rythme auriculaire ectopique. Et si le rythme est très lent, voire aux alentours de 50-60 par minute, généralement, on a affaire à 2 arythmies, une plus maligne, le bloc AV complet, ou une tout à fait bénigne, le bigéminisme auriculaire bloqué. Nous allons voir la différence entre les deux vers la fin de la présentation. Maintenant, lorsque l'enfant est tachycarde, on a la tachycardie modérée est généralement représentée par de la tachycardie sinusale ou soit une tachycardie auriculaire, certaines tachycardies ventriculaires ou certains faisceaux accessoires comme le PGRT. Le rythme sera généralement aux alentours de 200-220 par minute, tandis que le nouveau-né très rapide, au-delà de 240-260 par minute, on a généralement affaire à un faisceau accessoire typique de type Wolff-Parkinson-White ou du flotteur auriculaire. Nous allons donc aborder toutes ces arythmies dans la prochaine demi-heure. Avant tout, redéfinissons le rythme sinusal. Vous savez tous que le rythme sinusal est un rythme où il y a un P devant chaque QRS, mais le P doit être sinusal, c'est-à-dire le P doit être positif en D1, D2 et V6, comme sur cet électro, où le rythme est clairement sinusal avec un beau P devant le QRS en D1, D2, en AVF et en V6. Le P doit être positif. Pour quelle raison? C'est que, étant donné que le nœud sinusal est en haut à droite et que l'influx se dirige en bas à gauche, le vecteur doit être entre 0 et 90 degrés, donc avoir un P positif en D1, D2 et AVF. Ici, on a un autre électro où on a un P positif en D1, mais on voit que le P est négatif en inférieur, en D2, D3, AVF, signe que le rythme n'est pas sinusal. En effet, les P sont négatifs en inférieur et positifs en D1, de sorte que le vecteur pointe vers le haut et vers la gauche. On a donc affaire à un rythme auriculaire droit du bas de l'oreillette. Donc, le nœud sinusal, le rythme sinusal, l'onde P doit être devant le QRS, mais doit être positive en D1 et D2. C'est donc important d'avoir un électro 12 dérivation pour être certain du rythme de l'enfant. Maintenant, on a parlé du rythme sinusal, on va revoir un peu la tachycardie sinusale un peu plus tard, l'arythmie sinusale, mais qu'en est-il des nouveau-nés avec un rythme cardiaque irrégulier? Je dis souvent aux parents, lorsque le rythme est trop lent ou lorsque le rythme est trop rapide, on a un problème. Lorsque le rythme est simplement irrégulier, généralement, notre enfant n'est pas à risque. Généralement, l'enfant va très bien tolérer son arythmie, mais il est important pour le clinicien d'être capable de reconnaître l'arythmie sous-jacente. Donc ici, on a un bel électro d'un enfant peut-être un peu plus vieux que la période néonatale, mais c'était pour remontrer quand même la cause numéro 1 de l'arythmie chez l'enfant. En fait, on voit que le rythme cardiaque est irrégulier. On voit qu'il est tantôt lent, tantôt rapide, tantôt lent, tantôt rapide. Mais ce qu'on voit surtout, c'est que d'emblée, tous les P sont similaires. Tous les P devant le QRS ont la même morphologie. On a donc affaire à un P qui est sinusal, positif en D1 et D2, mais qui est irrégulier. C'est ce qui définit l'arythmie sinusale. Donc, un rythme qui est irrégulier, mais les ondes P sont toujours pareilles et les QRS sont toujours pareils. Et on voit qu'il y a une certaine régularité dans l'arythmie. Je dis toujours que ce rythme-là n'est pas juste normal, il est obligatoire. Donc, un enfant qui fait de l'arythmie sinusale, soyez heureux, soyez contents, c'est un signe de santé. Maintenant, les extrasystoles. Le nouveau-né présente souvent des extrasystoles auriculaires. En effet, l'extrasystole auriculaire est fréquente seulement chez le nouveau-né. Au-delà de la période néonatale, il est rare de retrouver des extrasystoles auriculaires fréquentes chez l'enfant. Donc, l'extrasystole auriculaire va se manifester de 3 façons. Premièrement, ça prend un P qui est différent du P de base. Donc, si vous regardez sur la ligne en haut, on a un PQRS, 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 et là, on a un QRS qui est précoce, qui ressemble bien gros aux autres QRS, mais si vous regardez très facilement, on voit une encoche dans l'onde T. Il y a donc un P qui est nettement plus tôt que prévu, qui a une forme qui est différente. Donc, ça, c'est une extrasystole auriculaire qu'on dit conduite normalement avec un QRS normal. Si on regarde le rythme d'en bas, encore une fois, un rythme à peu près à 150 par minute, mais il y a 2 pauses. Il faut toujours regarder dans la pause. Il faut regarder les ondes T. Voyez-vous, les ondes T de cet enfant sont belles, sont rondes, mais ici, il y a une encoche vers le bas. Même chose ici. Donc, encore une fois, ces encoches-là ne sont pas une vue de l'esprit, ce sont des extrasystoles auriculaires, un P auriculaire, mais cette fois-ci, qui n'a pas conduit vers les ventricules. L'onde P a rencontré des voies de conduction réfractaires, donc ça ne s'est pas rendu au ventricule. On a donc une pause. On appelle ça une extrasystole auriculaire bloquée. On en a 2 sur le tracé ici. Ici, on a un tracé intéressant, assez fréquemment retrouvé chez l'enfant, c'est-à-dire on a deux ondes P suivies de QRS et on a une pause et ça se répète continuellement. Et ici, on voit très bien un QRS qui est différent des autres QRS, un QRS qui est élargi. Donc, lorsque vous voyez un QRS qui est différent du QRS de base, d'emblée, vous auriez dû dire c'est une extrasystole ventriculaire. En effet, ça peut être une extrasystole ventriculaire, mais avant de conclure que c'est une extrasystole ventriculaire, il faut regarder devant l'extrasystole. Est-ce qu'il y a une extrasystole auriculaire? Est-ce qu'il y a un P qui est différent du P de base, qui aurait pu conduire vers les ventricules, cette fois-ci avec aberration, c'est-à-dire qu'il rencontre une branche qui n'est pas prête à l'accepter. Donc, on a un P sinusal Et ici, voyez-vous, encore une fois, dans l'onde T, on voit une encoche. Il y a donc d'emblée une onde P. Et cette onde P a pu conduire dans les ventricules, mais avec une aberration, de sorte qu'on a un QRS qui est élargi. Il s'agit donc d'une extrasystole auriculaire conduite avec aberration. Donc, le troisième type d'extrasystole auriculaire. Les trois types sont bénins, que ce soit conduit normalement, que ce soit conduit avec aberration ou que ce soit bloqué. Ce sont des extrasystoles auriculaires tout aussi bénignes. Et juste petite particularité sur ce tracé, à chaque fois qu'il y a une pause, c'est que l'enfant avait une extrasystole dans l'onde T. Si vous regardez l'onde T, elle est un peu plus haute que l'onde T précédente. Même chose ici. Donc, c'est une onde T qui est bloquée. Donc, sinusale, sinusale, extrasystole bloquée, sinusale, sinusale, extrasystole bloquée. Et ici, il y a eu une extrasystole, la même T pointue, mais ça l'a conduit avec aberration vers les ventricules. Donc, extrasystole auriculaire conduite avec aberration. Encore une fois, j'en montre beaucoup, mais des extrasystoles auriculaires chez le nouveau-né, c'est fréquent et ça manifeste par des extrasystoles conduites normalement, conduites avec bloc ou conduites avec aberration. Encore une fois, un QRS large, vous auriez le goût de dire extrasystole ventriculaire, mais regardez en avant, il y a encore un accident dans l'onde T qu'on n'a pas aux ondes T précédentes. Il y a donc une extrasystole qui est conduite avec aberration. Ici, encore une fois, une onde P qui est différente du P précédent, conduite relativement normalement, extrasystole conduite normalement. Ici, un battement jonctionnel, battement sinusal, battement sinusal, battement sinusal, et encore une fois, un accident dans l'onde T qui n'est pas conduite, donc une extrasystole auriculaire non conduite. Toutes des extrasystoles auriculaires, toutes aussi bénignes une que l'autre. Maintenant, bien sûr qu'il existe d'autres sortes d'extrasystoles que des extrasystoles auriculaires. Ici, on a PQRS, PQRS, QRS. Et si on regarde, le QRS est naturellement différent du QRS de base. On aurait le goût de dire ventriculaire ou auriculaire conduite avec aberration. C'est pas subtil. Il n'y a pas de déformation de l'onde T. L'onde T est bien belle et d'emblée, c'est une extrasystole ventriculaire. Dernière extrasystole, dernier cliché d'extrasystole, un beau rythme, un battement différent, un beau rythme, un battement différent, un battement qui est nettement différent du QRS habituel. Et si on regarde en avant de ce QRS, bien, l'onde T ici est très belle et l'onde T ici est identique. Il n'y a donc pas d'accident dans cette onde T. Donc, c'est un QRS large, différent du QRS de base. C'est une extrasystole ventriculaire car il n'y a pas d'extrasystole auriculaire qui le précède, qui en aurait fait une extrasystole conduite avec aberration. Donc, extrasystole ventriculaire. Donc, les arythmies chez le nouveau-né, fréquents, toujours bénins ou presque. L'arythmie sinusale, c'est rassurant. L'extrasystole auriculaire, bonne nouvelle, ça dure 3-4 jours et ça disparaît. Rarement, les extrasystoles auriculaires vont persister au-delà de quelques jours. Excellent pronostic. On retrouve souvent des extrasystoles auriculaires chez le fœtus. Et finalement, les extrasystoles ventriculaires sont habituellement bénignes chez un enfant asymptomatique. On les retrouve à peu près 10 du temps chez les extrasystoles du nouveau-né. On fait un petit peu plus d'investigation. Tout au moins, on s'assure que le cœur est normal de l'enfant. Mais l'évolution chez le nouveau-né va généralement être d'une résolution spontanée, tout comme les extrasystoles auriculaires. Mais chez l'enfant malade, l'enfant intubé, l'enfant aux soins intensifs, la présence d'extrasystoles ventriculaires justifie d'éliminer une cause sous-jacente, par exemple une myocardite ou des débalancements métaboliques. Donc, on a abordé les arythmies. Maintenant, on va parler de tachycardie. Donc, l'enfant nouveau-né qui est tachycarde, c'est plus grave qu'un enfant dont le rythme est irrégulier. On peut avoir affaire à un enfant qui est en tachycardie sinusale, il faut savoir définir, le caractériser. On peut avoir affaire à un enfant qui a une tachycardie supraventriculaire typique par un faisceau accessoire. Mais on va aborder aujourd'hui les tachycardies auriculaires, soit par tachycardie auriculaire ectopique ou par flottaire. On va aborder très brièvement la tachycardie ventriculaire. Donc, encore une fois, la tachycardie sinusale va se définir par une tachycardie qui n'est pas trop rapide, qui est généralement en bas de 120, en bas de 220 par minute, avec une onde P devant le QRS et une onde P qui a un aspect sinusal, c'est-à-dire positive en D1 et D2. On va voir une certaine variabilité du rythme cardiaque. La tachycardie sinusale, des fois, est plus grave qu'une tachycardie supraventriculaire parce que l'enfant peut être en choc peut être septique. Et s'il roule à tout près de 220 par minute, l'enfant peut être beaucoup plus malade que l'enfant qui roule à 258 à la minute en tachycardie supraventriculaire, qui nous regarde, qui sourit, qui boit et qui est tout à fait asymptomatique. Donc, tachycardie sinusale à différencier des autres tachycardies supraventriculaires. Ici, vous avez un tracé qu'on va définir comme une tachycardie à QRS fin régulière. Et si vous regardez les QRS, on voit qu'ils sont à peu près à la vitesse d'un carreau, donc ils sont à près de 300 par minute. Donc, tachycardie d'emblée supraventriculaire, 300 par minute, on est dans le registre des tachycardies rapides, très rapides. Et donc, j'ai dit tantôt, probablement un faisceau accessoire typique versus un flotteur auriculaire. Vous avez ce bébé-là qui n'est pas trop malade ou il peut être très malade. D'emblée, un rythme rapide, régulier, on peut tenter une manœuvre de Valsalva ou injecter de l'adénosine. Et c'est ce qu'on a fait. On donne de l'adénosine à cet enfant et on voit qu'il y a cassure du rythme. On voit ici le QRS suivi d'une petite onde P rétrograde, QRS suivi d'une petite onde P rétrograde. On voit ici un P QRS avec une sorte d'empattement du QRS. On voit ici qu'il y a un battement avec une préexcitation. Ici, on a un battement jonctionnel, un autre battement jonctionnel et de la préexcitation. Donc, un rythme qui a été converti par l'adénosine, une tachycardie qui avait 1 P par QRS, donc une relation P-QRS 1 pour 1, jusqu'à preuve du contraire, un faisceau accessoire. Donc, les tachycardies supraventriculaires, on va, pour ne pas se mêler aujourd'hui, chez le nouveau-né, on peut retrouver principalement le flotteur auriculaire, qu'on va discuter un petit peu plus tard, les tachycardies par faisceau accessoire, soit le faisceau accessoire caché ou le Wolff-Parkinson-White. On a aussi le PGRT, qui est une arythmie typique de l'enfant, qu'on va voir. Et on peut avoir affaire à des arythmies automatiques, c'est-à-dire un rythme qui commence progressivement, qui accélère progressivement et qui décélère progressivement. Une tachycardie auriculaire unifocale à l'occasion multifocale. Donc, quelle est la caractéristique d'une tachycardie par réentrée? C'est quand même important d'en parler. Les enfants qui font des TSV par faisceau accessoire, ça commence tout d'un coup et ça se termine tout d'un coup. Généralement, c'est débuté par une extrasystole auriculaire. La tachycardie, donc, peut être initiée et terminée par des extrasystoles. La fréquence est fixe, un début et fin brusque, et ça peut être terminé par une cardioversion de l'adénosine ou un entraînement rapide du rythme de l'enfant. Donc, les causes de réentrée, bon, chez l'enfant, le flotteur, le faisceau accessoire typique, le PGRT. La réentrée nodale, c'est une arythmie de l'adolescent et la FA, c'est une arythmie de la personne plus âgée. Maintenant, les arythmies automatiques, encore une fois, c'est important de définir quand vous allez voir sur les électros qui s'en viennent la différence entre les deux. Les arythmies automatiques, c'est des arythmies où l'accélération est progressive et il y a une décélération progressive. C'est pas un début brusque et une fin brusque. La fréquence peut être variable. On a un phénomène d'accélération, de décélération, et ça ne répond pas à une cardioversion, ça ne répond pas à l'adénosine, ça répond à une médication qui est introduite et qui va tranquillement s'installer pour ralentir la fréquence cardiaque de l'enfant. Donc, les problèmes automatiques, principalement les foyers auriculaires. Il y a le jet aussi, qui est une arythmie qu'on retrouve surtout en post-opératoire. Donc, rappelez-vous la tachycardie à 300 par minute qu'on a vu il y a quelques minutes. 300 par minute, je vous ai dit qu'il y avait un QRS et un P rétrograde. Donc, les tachycardies auriculo-ventriculaires, donc qui utilisent un faisceau accessoire, ont cette caractéristique d'avoir un ratio P-QRS 1 pour 1 obligatoire. Il y a un P pour chaque QRS. Et la distance entre le QRS et le P rétrograde va nous aider à faire un diagnostic. Je vous montre ces trois tracés où on a un QRSP qui est très court. Ça, c'est typique de la réentrée nodale de l'adolescent. On n'en parlera pas trop aujourd'hui, étant donné qu'on parle des nouveaux-nés. Lorsqu'on a un QRSP de longueur intermédiaire, environ 70 millisecondes, on a affaire à un faisceau accessoire typique. Un faisceau accessoire qui donne des tachycardies très rapides, 250, 300 par minute, convertis par l'adénosine. Et lorsqu'on a un QRSP qui est très long, ça, c'est plus rare, c'est le faisceau accessoire de type PJRT, faisceau qu'on retrouve principalement en pédiatrie et qui va aussi répondre à l'adénosine et qui, généralement, va donner des tachycardies un peu plus lentes. On sait quoi un faisceau accessoire? Un faisceau accessoire, c'est un bris dans l'isolant du cœur. Le cœur est une structure musculaire, autant au niveau de l'oreillette que du ventricule. L'oreillette est musculaire, le ventricule est musculaire, mais entre les deux, il y a une gaine fibreuse isolante qui fait en sorte que l'oreillette et le ventricule ne se touchent pas sur le plan électrique. Donc, cette gaine fibreuse, c'est cette structure qui est représentée en rose ici. Et s'il y a une brèche dans cet isolant, ben, il y aura contact entre l'oreillette et le ventricule, quelque part le long de l'anneau mitral, quelque part le long de l'anneau tricipidien ou entre les deux. Et c'est ce qui va être appelé un faisceau accessoire. Généralement, l'électricité du haut va descendre vers le bas par le nœud AV, mais s'il y a une petite brèche dans l'isolant, ben, il y aura un faisceau accessoire qui donnera des tachycardies orthodromiques, donc ça descend par le nœud et ça remonte par le ventricule. Donc ici, on a une tachycardie à QRS fin régulière, un petit peu moins que 300 par minute. Et voyez-vous, l'onde P rétrograde est loin du QRS précédent. QRS-P, c'est l'électro assez typique d'un PGRT, un autre faisceau pédiatrique, et qui est un peu plus difficile à traiter, qui est un petit peu plus lent que le faisceau accessoire typique et qui va quand même répondre à l'adénosine. Maintenant, vous avez un autre nouveau-né malade en défaillance cardiaque qui est rapide, mais regardez cet électro. Ce qu'on remarque tout de suite, c'est que, c'est un peu moins rapide que la tachycardie par faisceau accessoire, mais surtout, la tachycardie est irrégulière. Donc, si la tachycardie est irrégulière et qu'on a quand même des QRS relativement fins, encore une fois, il faut regarder pour les QRS, il faut regarder pour les ondes P. C'est toujours les deux structures de l'électro qu'il faut regarder. Et si on regarde ce tracé, on a vraiment l'impression qu'il y a beaucoup d'ondes P. On a un P ici, on a un P ici, on a un P ici. Lorsqu'on a plus de P que de QRS, ou lorsqu'on a beaucoup de P, on a affaire d'emblée à une tachycardie auriculaire. Le problème, il est auriculaire et le nœud AV va en laisser conduire une certaine quantité de sorte que le rythme va être irrégulier. Des fois, les QRS vont être fins, d'autres fois, les QRS vont être larges, mais c'est pas large parce que on associe rythme supraventriculaire et ventriculaire. Non, pas du tout. C'est de l'aberration. P-là a conduit avec aberration, tandis que celui-ci a conduit avec un QRS fin. Donc, il s'agit ici d'une tachycardie auriculaire, ectopique, un seul foyer parce que les ondes P sont toujours pareilles, avec une conduction variable. Donc, toujours le même patient où, lorsqu'on regarde le scope, il y a des périodes où il est moins rapide, mais d'emblée, entre les QRS, on voit beaucoup d'ondes P. Ça confirme ce diagnostic de tachycardie auriculaire. On n'a donc pas à faire une tachycardie auriculo-ventriculaire, on n'a pas à faire un faisceau accessoire, on n'a pas à faire une arythmie qui va répondre à l'adénosine. Ce serait tout à fait acceptable, cependant, d'essayer l'adénosine pour démasquer. Si notre patient est très rapide et on a de la misère à voir les ondes P, si on donne de l'adénosine, on va voir du bloc dans le rythme et ça va nous permettre de porter le diagnostic. L'adénosine dure quelques secondes, il n'y aura pas d'effet négatif chez l'enfant. Donc, une fois qu'on a fait le diagnostic, cet enfant a reçu une médication, il a reçu de la cordarone Peros, qui s'est installé tranquillement dans son système, et on a vu un ralentissement du rythme cardiaque, on a vu un ralentissement du rythme des oreillettes. Les oreillettes ont ralenti, beaucoup moins d'arythmie. Et le lendemain ou le surlendemain, on a que quelques extrasystoles auriculaires résiduelles, et après 4 jours de traitement, on a vraiment un rythme cardiaque tout à fait régulier. C'est pas un rythme qui aurait pu être converti par l'adénosine, c'est pas un rythme qui aurait été converti par la cardioversion, c'est un rythme qu'il fallait traiter médicalement. Les options, il y avait plusieurs options, on en reparlera dans quelques minutes, mais un bébé malade répond très bien à la cordarone Peros, cordarone qu'on pourra donner pendant 4-5 jours en dose de charge et continuer en dose d'entretien, souvent associé à un bêta-bloqueur. Donc, la tachycardie auriculaire est tout de même une arythmie qui est beaucoup moins fréquente, mais il faut être capable de la différencier du faisceau accessoire typique. Donc, la tachycardie auriculaire est d'origine des oreillettes. Comme je disais, les P et les QRS, le ratio est égal à 1 ou surtout, la plupart du temps, plus de 1, beaucoup plus de P que de QRS. Et l'arythmie va persister malgré le bloc. Si on donne de l'adénosine, si on fait une manœuvre vagale, l'arythmie auriculaire va persister. On a 2 exemples ici de tachycardie auriculaire. Pourquoi? Parce qu'on a beaucoup d'ondes P pour des QRS beaucoup moins fréquents. Même chose ici, plus de P que de QRS. D'emblée, il faut savoir que ce sont des tachycardies auriculaires. Ici, les ondes P sont en forme de dentitie, un flotteur auriculaire, donc une arythmie par réentrée, tandis qu'ici, les ondes P sont irrégulières, il y a des pauses, des fois sont plus rapides, des fois sont plus lentes. On a affaire à un foyer auriculaire ectopique automatique avec une conduction vers les ventricules qui est variable. Donc, les tachycardies auriculaires ectopiques, le foyer ectopique, c'est rare, ça vient des oreillettes, ça peut être incessant et ça représente environ 10 à 15 des tachycardies supraventriculaires du jeune enfant. Donc, c'est pas toujours les faisceaux, ça peut être des tachycardies auriculaires. Généralement, on ne trouve pas de cause. Ça peut venir de l'oreillette droite dans à peu près 70 des cas, de l'oreillette gauche dans 30 des cas. Ça ne fait pas de grande différence. Ici, un autre exemple de la même chose, un bébé rencontré au printemps 2021 qui s'est présenté un peu en défaillance cardiaque, tachycarde, vomissement. Là, on retrouve ce rythme qui est irrégulier, qui est assez rapide, qui est tout près de 200 par minute, mais vraiment irrégulier. Donc, pensez, rythme irrégulier, des QRS tantôt élargis, la plupart du temps fins. On regarde et on voit des P qui ressemblent à des P sinusaux, mais on a beaucoup d'autres P. Ici, on a un autre P, plusieurs P ici. Donc, encore une fois, on a affaire à une activité auriculaire autonome, un rythme auriculaire avec une condition ventriculaire irrégulière, chaotique, mais c'est toujours des ondes P qui ont la même morphologie. Ici, on a vraiment une certaine régularité, mais on voit encore une onde P ici, une autre onde P sur l'onde P, une autre ici. Donc, c'est vraiment des ondes P qui sont irrégulières avec des ventricules irréguliers. Cet enfant a eu un écho qui a démontré une large communication interauriculaire. Il y a eu une dose de cordarone per os, 500 mg par mètre carré, et cet enfant s'est converti. Le lendemain, il était en rythme sinusal. On a vu un ralentissement progressif de sa fréquence cardiaque. Et on voit ici l'électro typique d'un enfant qui a une communication interauriculaire, R, S, R', une surcharge de volume en V1, typique d'une communication interauriculaire, telle que retrouvée chez cet enfant. Donc, tachycardie auriculaire ectopique. Autre exemple de tachycardie qu'on peut retrouver, c'est un autre enfant qui s'était présenté à nous en tachycardie. Bon, ici, on peut la définir comme une tachycardie régulière à QRS large. L'enfant, il a quelques mois de vie. D'emblée, on doit penser à une tachycardie ventriculaire. Il pourrait s'agir d'une tachycardie supraventriculaire par faisceau, qui serait beaucoup plus fréquent, mais conduite avec aberration. Il ne serait pas une erreur du tout de donner de l'adénosine. En fait, cet enfant a eu de l'adénosine et ça n'a rien fait sur son rythme. Et si on regarde comme il faut, on voit qu'il y a comme un accident. Il y a des accidents de parcours. Il y a un accident ici, il y a un accident ici, il y a un accident ici. L'accident, c'est une onde P. Dans un tracé d'électro, il y a des QRS et il y a des ondes P. Donc, cet enfant avait des ondes P à travers un rythme très rapide. Donc, plus de QRS que d'ondes P. Donc, à ce moment-là, il s'agit soit d'une tachycardie ventriculaire ou d'une tachycardie jonctionnelle ectopique, un jet. Étant donné que le QRS est large, on a affaire à une tachycardie ventriculaire. Autre enfant qui a bien répondu à une dose de charge de cordarone par la bouche et qui a ralenti son rythme jusqu'à tomber en sinusale dans les quelques heures qui ont suivi et qui a été traité médicalement pendant un certain nombre de jours. Pour finir, les tachycardies, cet électro est un électro d'un enfant qui, en fin de grossesse, a été retrouvé en tachycardie fétale et avec une fonction in utero très mauvaise. L'enfant a été sorti d'urgence par césarienne et c'est le tracé qu'on avait à la naissance. Et si vous regardez, on a un rythme qui est un peu rapide, environ à 200 par minute, mais si on regarde comme il faut le tracé, encore une fois, beaucoup d'ondes P, 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 P. Ici, on voit des P partout, P, 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 donc 2 P par QRS, tachycardie auriculaire, mais très, très régulière. Il s'agit en fait d'un flotteur auriculaire. Si on regarde l'enfant qui avait été monitoré, on voyait ici des périodes très régulières, mais on voyait des périodes où il y avait un petit peu de bloc, soit pendant les respirations, et on avait beaucoup de P entre les QRS. Encore une fois, une tachycardie auriculaire. Et on voit les ondes en dentitie typiques d'un flotteur auriculaire. Cet enfant a donc été cardioversé et c'est le rythme qu'on a retrouvé par la suite. Il était en rythme sinusal. Le flotteur néonatal est rare. Lorsqu'il est présent, il faut le convertir, soit par médication. Antérieurement, on donnait du lanoxin. Nous, on a tendance à donner de la cordarone pour le convertir. Une fois qu'il est converti, on va traiter pendant 3 mois, mais généralement, l'enfant ne récidivera pas. C'est une arythmie qu'on retrouve chez le fœtus et chez le nouveau-né, mais qui ne récidivera pas la plupart du temps. L'enfant va très, très bien évoluer. Un autre flotteur auriculaire, encore une fois, les dentities. Donc, beaucoup de d'ondes P, des QRS beaucoup moins rapides. c'est un flotteur auriculaire. On va retrouver cette arythmie-là au-delà de la période néonatale, à l'occasion chez des enfants malades, bronchiolites, aux soins intensifs. Ça va amener les pressions un peu plus hautes dans les oreillettes et ça peut favoriser le flotteur auriculaire. Donc, comment on prend en charge les tachycardies? Bien, la première chose, c'est de reconnaître rapidement le rythme sous-jacent, faire la différence entre une fessure accessoire, une tachycardie auriculaire ectopique, une tachycardie ventriculaire. Faire attention aux interventions qui pourraient déstabiliser l'enfant. Faire attention à la cordarone intraveineuse. En forme intraveineuse, la cordarone a un effet hypotenseur important chez le petit enfant. C'est le lexicipient dans lequel la médication est diluée qui est hypotensive. Donc, la cordarone se donne lentement chez les jeunes enfants. Dans notre centre, on a tendance à le donner par la bouche, très bien toléré, dilué dans quelques millilitres d'eau stérile. Et l'effet va se faire progressivement dans les minutes, voire les heures qui suivent. On aura un effet donc beaucoup plus progressif et beaucoup moins d'effets secondaires d'hypotension. Et il faut utiliser un antiarythmique efficace, comme je viens de dire, pour arrêter l'arythmie. L'adénosine est un très bon choix chez tous les enfants. Chez le jeune enfant, l'adénosine va être un bon choix pour convertir le rythme, mais aussi pour nous aider à faire un diagnostic. Dans la tachycardie auriculaire ectopique, on démasquera les ondes P. Dans le flotteur auriculaire, on démasquera aussi les ondes P. Dans la tachycardie ventriculaire, on n'aura pas d'effet la plupart du temps. Dans le faisceau accessoire, on va avoir une interruption de la tachycardie. Très bon, les médicaments utilisés en général, je ne propose pas de préférence. La procainamide est utilisée pour les faisceaux accessoires, pour la plupart des arythmies. La flécainide est une forme par la bouche qui peut être utilisée pour maintenir les enfants en rythme sinusal, surtout dans les faisceaux accessoires. En aigu, dans les bêta-bloqueurs, la forme intraveineuse peut être utilisée et la forme par la bouche, le propranolol ou le métoprolol qui se prend un peu moins souvent quotidiennement. Le sotalol, qui est un excellent médicament classe 3 pour prévenir les tachycardies, et la cordarone intraveineuse ou Péros. Dans notre centre, on va convertir assez souvent avec la cordarone Péros et on va poursuivre comme traitement médical soit le propranolol, soit le sotalol ou la cordarone Péros dans la plupart des cas. Donc, en résumé, pour les tachycardies, si on a une relation P-QRS 1 pour 1, on a affaire à un faisceau accessoire, 1 P pour chaque QRS. Si le VA est court, la distance entre le QRS et le P est court, on a affaire à un faisceau accessoire typique le plus fréquent. Si c'est long, on a affaire à un PGRT la plupart du temps. S'il y a moins de P que de QRS, à ce moment, s'il y a plus de QRS que d'ondes P, on a affaire à un rythme des ventricules autonomes. Donc, c'est généralement la tachycardie ventriculaire. Ici, on a plus d'ondes P que de QRS. Et on a affaire à une tachycardie auriculaire, soit le flotteur, soit la tachycardie auriculaire ectopique. On complète aujourd'hui avec les bradycardies néonatales pour faire le tour des arythmies retrouvées chez le nouveau-né. On peut avoir affaire à une bradycardie sinusale, on en reparle. On peut avoir affaire à des extrasystoles auriculaires bloquées en bigéminisme. On appelle ça un bigéminisme auriculaire bloqué. Je vais beaucoup vous en parler car c'est une arythmie qui est relativement fréquente, excessivement bénigne, mais qui doit être différenciée du bloc auriculo-ventriculaire complet. La bradycardie du nouveau-né, c'est fréquent. On nous appelle fréquemment la pouponnière. On a un bébé qui roule à 80, 85 par minute. On regarde l'électro, il y a un P devant chaque QRS. C'est relativement fréquent. Ça a tendance à s'améliorer assez rapidement dans les jours qui suivent la naissance. Et c'est favorisé la plupart du temps par surtout une hypertonicité vagale, mais éliminer un problème intracrânien, s'assurer que c'est pas un enfant qui a un problème neurologique, s'assurer qu'il n'y a pas d'hypothyroïdie. Mais généralement, la bradycardie sinusale qui est relative là, aux alentours de 80-85 par minute va s'améliorer, va être très bien tolérée et est surtout très fréquente. On voit ici la fréquence cardiaque chez les nouveau-nés et les enfants un peu plus vieux. Le premier est jusqu'au 99e percentile. En moyenne, le nouveau-né roule à 127 par minute et varie de 90 à 164. Mais on a quelques exceptions des enfants qui vont rouler à 80, 70 par minute. Et bien sûr qu'on va les observer. Généralement, cette bradycardie sinusale va s'améliorer spontanément. Maintenant, un autre enfant peut être plus lent. Ici, on a un électrode d'un enfant un peu plus vieux on voit un phénomène de bigéminisme. On a des phénomènes de 2 QRS à chaque fois, mais on a un P normal suivi d'un QRS normal, suivi d'un P inversé suivi d'un QRS normal. Normal, anormal, normal, anormal, etc. Donc, on a affaire ici à un bigéminisme auriculaire. Donc, un enfant qui fait une extrasystole auriculaire à tous les battements sinusaux normaux. Mais les extrasystoles sont conduites de sorte que ça fait un rythme qui est présent. L'enfant n'est pas très lent, mais il est irrégulier à tous les 2 battements. On appelle ça un bigéminisme auriculaire. Maintenant, ce qu'on voit chez le nouveau-né, c'est du bigéminisme auriculaire bloqué. Le même enfant qui fait des extrasystoles auriculaires, bien, les extrasystoles auriculaires peuvent être bloquées 1 sur 2. Et donc, ici, on a un P sinusal, une extrasystole bloquée, P sinusal, extrasystole bloquée, P sinusal, extrasystole bloquée. En fait, l'extrasystole, elle est ici dans l'onde T, donc à la base de l'onde T. Et donc, cet enfant a un rythme vraiment lent, aux alentours de 60 par minute. Il est très bien, il pleure, il est actif. Et ce rythme-là, il faut le reconnaître parce que dans les 24 heures qui suivent, il va se normaliser sans intervention. Le bigéminisme auriculaire bloqué, c'est des extrasystoles auriculaires à tous les 2 battements. Généralement, ça disparaît dans les premiers jours de vie et ça disparaît spontanément sans traitement. Donc, l'enfant n'est pas en danger et l'enfant, il n'y a pas d'intervention particulière qui sont nécessaires. Donc, le bigéminisme auriculaire bloqué, sachez que c'est assez fréquent. Il faut savoir le reconnaître. On retrouve donc des extrasystoles dans l'onde T à qui suit chaque battement sinusaux précédent. Tandis que le bloc auriculo-ventriculaire, la différence avec le bigéminisme, c'est que les ondes T sont toujours pareilles. Donc ici, on a un bloc du 2e degré type 1, donc on a un PR qui allonge du veine Québec. Ici, on a un PR qui est constant suivi d'un bloc. Ici, vous regardez l'intervalle entre les P, il est tout à fait constant et les P sont tous pareils. Donc ici, on a affaire à du mobit. Tandis que le 3e degré, les ondes P sont régulières, les QRS sont réguliers, on a affaire à un bloc AV 3e degré. Et ici, on a l'électrocardiogramme d'un enfant qui est en bloc complet. On a donc ici des P réguliers avec des QRS qui sont lents. On a affaire à un bloc auriculo-ventriculaire complet chez un nouveau-né, ce qui est tout à fait pas normal, tout à fait peu fréquent, mais généralement, on a affaire à un bloc auriculo-ventriculaire congénital secondaire à la présence d'anticorps chez la mère. Excusez-moi. Donc, le bloc AV congénital, c'est généralement secondaire à la présence d'anticorps auto-immuns dans la circulation de la mère qui amènera une destruction du nœud auriculo-ventriculaire chez le fœtus. Si la mère a des anticorps lupiques, de 2 à 3 de bloc chez l'enfant et il y aura récurrence d'un bloc chez l'enfant suivant dans une proportion de près de 20 Donc, ce n'est pas toutes les mères qui ont des anticorps lupiques qui vont provoquer un bloc chez leur enfant. Mais si un premier enfant avec un bloc, il risque d'en avoir sur une 2e grossesse, monte aux alentours de 20 Le bloc auriculo-ventriculaire complet chez le nouveau-né peut aussi être secondaire à une malformation cardiaque. Ce bloc va être beaucoup plus grave et il va d'emblée nécessiter un cardiostimulateur, tandis que le bloc AV congénital secondaire aux anticorps lupiques chez la mère, bien, généralement, on peut suivre l'enfant pendant plusieurs mois, voire plusieurs années. Et lorsque l'enfant aura un rythme d'échappement trop lent, ou des extrasystoles ventriculaires, ou de longues pauses, ou l'apparition de symptômes ou de dysfonction ventriculaire, bien, cet enfant aura besoin éventuellement d'un cardiostimulateur. Mais généralement, on réussit à se rendre à 5, 6, 7, 8, 10 ans avant l'implantation du cardiostimulateur en présence d'un bloc auriculo-ventriculaire congénital, secondaire aux anticorps lupiques chez la mère, en absence de malformation et en absence de dysfonction ventriculaire. Tandis que les autres blocs, les blocs complets qui ne sont pas congénitaux, ou en fait qui ne sont pas causés par des anticorps chez la mère, ben, ont un pronostic moins bon et doivent être appareillés plus rapidement. Donc, en résumé, le rythme cardiaque irrégulier doit être reconnu, mais n'a rarement de grandes conséquences. L'arythmie, soit qu'elle est normale comme l'arythmie sinusale, ou soit qu'elle sera temporaire comme l'extrasystole auriculaire. Les tachycardies ont un potentiel grave et doivent être prises en charge rapidement et avec précision. Les bradycardies sinusales, la bradycardie est fréquente chez le nouveau-né, elle est généralement bénigne. Quelques jours d'observation et le tout devrait rentrer dans l'ordre. Éliminer les problèmes intracrâniens, l'hypothyroïdie, la souffrance néonatale. Et savoir aussi différencier le bigéminisme auriculaire bloqué, qui est assez fréquent, du bloc auriculo-ventriculaire complet, qui nécessitera une investigation, un suivi et généralement l'implantation d'un cardiostimulateur quelque part dans la première décennie. Je vous remercie beaucoup de votre attention. J'espère que j'ai pu un peu démystifier l'arythmie chez nouveau-né, les rythmes irréguliers, les rythmes rapides, les rythmes lents.
Hello, everyone. My name is Gabriel Altit, and I'm a neonatologist at the Montreal Children's Hospital. And today I will be presenting on the Blue Baby evaluation and immediate management. So my disclosure is that Medtronic, via peer-reviewed competitive grant process, provided monitors and sensors for a research project ongoing at the MCH. We will review today the differential diagnosis of cyanosis in newborn. We'll elaborate the key findings on history, physical exam, and pertinent investigation that will refine the diagnostic approach. And we'll elaborate a comprehensive immediate management plan when evaluating a cyanotic newborn. The first case of Julia, you're called to the delivery room for an urgency section for fetal decel. She's 40-week female, and at birth she's not vigorous, so you decide not to do a delayed cord clamping. She's brought to the warmer and is blue, apneic, with pre-ductal saturation below targets and a heart rate that is low. So you start resuscitation with PPV and increase FiO2 appropriately so from 21 to 100% very quickly. And despite this, the baby remains with a very low saturation at 55% pre-ductally and a low heart rate. The baby gets intubated at 4 minutes of life, and after that, their CO2 detector changed, the heart rate response, and she has good air entry bilaterally. Despite this, your saturation is quite low with the FiO2 of 100%, so she's brought to your nursery. In the nursery, the pre and post saturations are different. The saturation post is higher. She has normal blood pressure in the 4 limbs. Her cord pH is normal, and her capillary pH is not so bad, 722 and CO2 in the 50s. You do an X-ray and you don't find that there's marked RDS, the tube is being pulled a bit, but there's no big issues that you can find on the X-ray. So why could this baby appear blue and desaturated? Well, first of all, let's think about oxygen transport and content. So typically in the body, our oxygen transport mainly occurs because we attach oxygen molecules to hemoglobin. And hemoglobin transport oxygen, you get oxygen extraction in your organs, and eventually your venous compartment get desaturated, typically in the 75%. So the majority of the oxygen transport occurs via hemoglobin transport, and a small quantity gets dissolved into the arterial blood. We call this the PaO2. So in a normal heart configuration, the right ventricle is the pump that will pump to your lungs, provide the oxygenated blood to the lungs. The lungs will be filled with oxygen, will do the work of capturing the oxygen onto this hemoglobin, and eventually you get a lot of oxygenated blood flow to your left atrium via your pulmonary veins, and eventually your LV will pump into the aorta and provide all the organs with this oxygenated blood. So the pulmonary vein saturation actually reflects what is happening at the level of your lungs. If the lungs have issues, oxygenated blood, well, your PaO2 hill will be low. So what is cyanosis? It is this bluish tinge or hue of the skin and mucosa, and it's typically mostly appreciated at the level where the skin is very thin. So lips and mouth and earlobes and fingernails, and it's observed clinically when you have more than 30 grams per liter of reduced hemoglobin in your capillary bed. So let's think about cyanosis in three categories: peripheral, acrocyanosis, and central. The peripheral is a situation where you have increased tissue oxygen extraction, and because of this, the hemoglobin on the venous part of your capillary bed is very desaturated. Typically in that situation, the systemic arterial oxygen is normally saturated. Acrocyanosis is very common in healthy newborns. It's a type of peripheral cyanosis. There is increased oxygen extraction because of peripheral vasoconstriction, and typically it occurs at the level of the mouth and the extremities. And what's very common for peripheral and acrocyanosis is that babies will have this very pink membranes because your arterial component is normally saturated. And finally, the one we'll focus today is central cyanosis. So it's really reduced arterial oxygen content and can occur in the first 5 to 10 minutes of life, as we know, as a normal part of transition. But if it's persistent beyond that, it is abnormal and should be evaluated and promptly treated. So why could we have desaturated hemoglobin enter the systemic compartment? Well, one of the reasons could be because the lungs are not doing the work that they're supposed to do. So the blue blood goes to the lung, and the lung is not providing oxygen, with blood coming back to the heart deoxygenated. So think about parenchymal disease, such as RDS, atelectasis, pneumonia. You can think about airway issues. So you have a blockage in the airway, and air is not able to fill the alveoli with oxygen. So plug, malacia, stenosis. You can think because the lungs are actually not being triggered. So CNS anomalies, hypotonia, neuromuscular disorder, or central nervous system issues like HIE, meningitis, apnea, or diaphragmatic issue like if you have a plexus with a phrenic nerve injury. And sometimes you have a mixed picture where you can have a bit of lung disease or airway disease and CNS disease. So you can think about meconium aspiration syndrome. And there are certain diseases with diffusion impairment. So at the alveolar level, the alveoli is filled with fluid or blood, and because of that, oxygen is not able to get into that capillary. The end result of all this is that the blue blood comes back to the systemic compartment and is desaturated. One of the second rare diseases that can cause desaturated blood or blue blood to stay blue is because the hemoglobin is abnormal and is not able to capture the oxygen. So we think often about methemoglobinemia, especially in the context of an intoxication to inhaled nitric oxide, but you can be genetically, have genetic anomalies that leads to methemoglobinemia, and there are other rare hemoglobin variants that can alter the hemoglobin oxygen affinity. The third category of etiologies that we will focus on today is when blue blood enters the systemic circulation by an intracardiac or extracardiac communication. So the end result is that you get these systemic venous blood that is desaturated or deoxygenated blood that will bypass the alveoli in the lung and enters the systemic compartment without being oxygenated. So if you have these situations, you have to think about congenital heart disease. The reasons could be because you get shunting at the ductal level, at the atrial level, mixing at multiple levels, including the ventricular level. And really, you could also have a situation where blue blood never reaches the lung because it keeps on recirculating into the systemic compartment. If you do get blue blood entering your systemic circulation at the atrial level, this will profoundly decrease your pre-ductal saturation. And if you have blue blood entering at the ductal level, this is a typical context where you get pre- and post-ductal differences of saturation. So what are these cardiac conditions that we have to keep in mind when we see a baby with central cyanosis not responding, for example, oxygen? And we will explore some of these diseases a bit more in detail. So think about detransposition of great arteries, either conventional or associated with your double outlet right ventricle. And in this context, the ductus is essential to promote left atrial filling and mixing. You can have situation where your pulmonary blood flow is ductal dependent. So think about situation where you have a right ventricular outflow tract obstruction and blood is not able to reach your lungs because it's blocked. So the typical situation is a pulmonary atresia or pulmonary stenosis, but there are variants where you have tetralogy of Fallot or double outlet right ventricle with TOF type, where they have RVOT obstruction and not enough blood flow goes to the lung. There are also situations with tricuspid atresia or Epstein anomaly, where there's a pulmonary valve atresia or functional atresia or stenosis. And because of that, you need your ductus to send blood flow to the lungs so that blood gets oxygenated and provide oxygen to the rest of the body. One other cardiac reason why you can be blue is because your blood that contains oxygen actually mixes with the blood that does not contain oxygen, and everything kind of mixes in one cavity. So one typical lesion that is in this context is total anomalous pulmonary venous return, where all the blood coming back from the lung full of oxygen reaches your right atrium, which usually receives all the blood coming back from the system. And so because of that, you get your oxygenated and deoxygenated blood, and they're all mixing into your right atrium, and baby looks blue. And in this particular context, the PDA may actually worsen or help the situation, and it really depends, and we will discuss this. You have truncus arteriosus, where you have a common arterial trunk and common vessel coming out of the heart, where all the blood will actually mix, and eventually it will distribute differentially between the lung and the systemic compartment. And in this context, PDA will be needed if there is an interrupted aorta or there is a coarctation to provide blood flow to the system. And finally, you can have a single ventricular physiology where all the blood mixes at the ventricular level. And the PDA is most often needed because you either need it to provide blood flow to the systemic compartment or the pulmonary compartment. So examples could be hypoplastic left heart syndrome, double in the left ventricle, tricuspid atresia, pulmonary atresia and septum, and there are various different diagnoses that can lead to single ventricular physiology. So when you suspect a cardiac case, in the majority of time, you will need your PDA. And so if you are in doubt, start PGE, because it will be extremely rare that you will cause any harm while in the community until confirmation of diagnosis. The only caveat is this total anomalous pulmonary venous return. And it is controversial because yes, it can cause harm if, for example, you increase the pulmonary blood flow, but there's an obstructive end. But actually, it can also benefit some of these babies if the pulmonary blood flow goes back through the ductus venosus, which is the one becoming obstructed. So if you have a lung transport, it also is, in certain cases, considered to give PGE for these babies. And TAPVR is extremely rare. So at the end of the day, if you have a blue baby and you think of a cardiac disease, you start PGE, you talk to your referral team, and you make sure that this baby gets an open ductus. The one part that I want to talk before going on is when you have differential cyanosis, but that your preductal and postductal limb are different, with a preductal being more saturated than your postductal. This can be a situation where you have PPHN, and we'll talk about it later, but it could be a cause of, for example, interrupted aortic arch or critical coarctation. In this situation, pink blood coming back from the lungs enters the LV, goes into your aorta, and is normally saturated in the preductal limb. But because you have an interrupted aortic arch or a very severe coarctation, your ductus is quite essential for the postductal perfusion and blood flow. But this blood is coming back from the pulmonary artery, which is actually deoxygenated. So you get normal saturation in the pre, abnormal saturation in the post, but on top of it, clinical clues include low blood pressure in the lower limbs, hypoperfusion of the lower limbs, poor renal output, and very abnormal femoral pulses or absent femoral pulses. So these patients, they need their ductus because they need that to perfuse their organs. So let's go back to Julia. She's a non-responder to oxygen, and this should be a clue to the etiology that it's possibly a cardiac disease. As you know, these babies can be profoundly hypoxemic, and despite that, not show much work of breathing. And the X-ray doesn't look so bad. They don't have that much, tugging or retractions. And some of these babies, you can be fooled because if they become very acidotic due to hypoperfusion, they may become tachypneic by compensatory mechanisms. So we used to talk about the hyperoxia test. This test is you give 100% oxygen for 10 minutes, and you do a pre and post radial sampling or artery blood sampling, and you measure the partial arterial oxygen content. And this is rarely done nowadays, But theoretically, babies with heart disease will not respond to oxygen and their PaO2 will not increase, while those with pulmonary disease will respond and there's more oxygen, and so your PaO2 will be high after this test. The babies with PPHN or high pulmonary pressure are kind of an in-between. They may respond a bit to oxygen, but will often stay cyanotic. And the reason they respond to the oxygen is because oxygen is a pulmonary vasodilator. And there are tables available out there to guide based on the response. But in situation where now we have the pulse oximetry, if the baby does not respond to oxygen and you stay profoundly desaturated in a situation where there's no marked lung disease on X-ray or even clinically, you have to think of a cardiac etiology. You should be transferred to a referral center where cardiology will be able to confirm the diagnosis with an echocardiography. So here, Julia, in this particular case, has a pre- and postductal differential saturation, but here the postductal saturation is higher. This means that actually pinker blood is entering the descending aorta and goes towards the distal limb, while the preductal saturation is contained of blue blood into the ascending aorta. So what could occur? Well, you can think, okay, could it be the transducer? Do I need to troubleshoot? Is my limb perfused? Do I have a clot or tourniquet? Do I have limb ischemia? Or do I have a congenital heart defect? And really the congenital heart defect that causes this presentation is a detransposition of great artery into a scenario where you do have a ductus and you have higher pulmonary pressure than systemic pressure, which means that the pink blood in the pulmonary artery enters the systemic circulation into the descending aorta. The other situation is a transposition of great artery where there is this interrupted aortic arch or coarctation, and through the ductus, you get pink blood feeding that descending aorta. So let's go back to TGA. Transposition of great artery, the DTGA, is the most common cyanotic heart disease presenting in the first week of life, and this is why I wanted to start with this case. And these babies, as you can see, they get an aorta that is attached to their right ventricle. So the blue blood stays into the blue systemic circulation and they will never reach the lung, while the pink blood keeps on recirculating through the lungs. And so the classical X-ray is this egg on a string, which we did not see in our case, but little caveat. And why is this missed still? Well, this is a 4-chamber view in a normal fetus, RV, LV, RA, and it actually looks exactly the same in a DTGA. And so unless you actually do other views during the fetal ultrasound, you may miss it. And typically in a normal configuration, the two great vessels will cross each other, while in a DTGA, they will typically be parallel to each other. And it's really by doing these extra 3-vessel views that you're able to capture some of the babies with DTGA. And that's why it's still one of the most missed prenatal diagnoses. So think about a DTGA here, where you get your blood coming back from your lung, oxygenated, entering your left ventricle, going to the pulmonary artery, and kind of recirculating like this. The only way you can send blood with oxygen into your systemic circulation is via this area between the atriums. Here, oxygenated blood enters your right atrium, enters your right ventricle, and eventually your ascending aorta in order to feed your organs. Typically, aortic pressure is higher than your pulmonary pressure, so blood flow through the PDA will increase pulmonary blood flow, will increase left atrial flow, and hopefully will favorize this shunt from the LA to the RA. But really, the PDA doesn't help with your mixing. And in this context, you can see that the saturation that you're starting here with is going to be the same here, the same here, and the same here, because the pink blood does not enter, in any case, your systemic circulation via the ductus. Now, in a situation where you have higher pulmonary pressure or you have an interrupted or coarctation, what happens is that suddenly your descending aortic pressure is much lower than your pulmonary arterial pressure. And so the pink blood is able to enter your systemic circulation via the ductus, giving you this reverse differential saturation. Babies in that situation with higher PVR than SVR will eventually drop their PVR and eventually will have pulmonary arterial pressure that are lower than their descending aortic pressure. And at that point, they will not get mixing at their PDA level, and they will be fully dependent on their atrial shunt. So when you think about transposition of great arteries in the DTGA format, you get these two circulations that are actually not communicating between each other. They're in parallel. You get hypoxic, and eventually you can become into severe metabolic acidosis. So the initial management, if you're in the community, is that if there is a restrictive septum, these babies will be profoundly or could be profoundly desaturated. And it is an emergency. You need to bring this baby under the hand of someone capable of enlarging this intraatrial shunt, ASAP. And so in the meantime, you can buy time by starting PGE. This will allow to keep the ductus open, will promote left atrial filling, and will promote this atrial shunting so that there is some oxygen reaching the systemic compartment. And usually right after birth, you don't need high dose PGE. Typically 0.02 mics per kilo per minute will be sufficient to keep your ductus open. Very different from the baby coming much later in life with the need to reopen a ductus. And at that point, you need to start at a higher dose, like 0.05, 0.1 mics per kilo per minute, and sometimes even higher than that. And at higher dose, you risk apnea. These babies may need some stabilization of their airway and respiratory status, especially if they become apneic, especially if they're blue and acidotic, so you might need to intubate. Some babies which are more around the 65, 75, 85% of saturation could be relatively stable and may just need non-invasive support. But in many cases where you have a very profound hypoxia, your baby will require intubation prior to transport. This baby should get an intravenous line and start D10 at maintenance level. And you should organize to be seen as soon as possible to get a balloon atrial septostomy. While waiting for transport, you want to monitor for your vital sign, keep the baby NPO, send some initial workup. Sometimes you don't have the diagnosis, so you want to make sure maybe there's not an underlying sepsis. You might want to have a CBC, make sure you're not anemic, send your gas, your lactate level, your electrolytes, and your glucose level. Some of these babies may eventually need inotropic support, especially if they had acidosis and hypoperfusion and coronary hypoxia, which can lead to ventricular dysfunction. Eventually, they get to a center that is capable to do a balloon atrial septostomy. This is an example here. And locally, we talk about a golden hour. We want to time it from the time of diagnosis or the time of birth to actually achieving efficient mixing at the atrial level. And so if known prenatally, these babies need to be born in a center that can offer this advanced cardiac care. And so we need to have a very rapid sequence of postnatal stabilization, and every player needs to be in place. So locally, we actually developed a septostomy protocol with a multidisciplinary involvement with NICU, neonatologists, NNPs, cardiology, RN, RT, radiology, in order to make sure we achieve the most efficient timing from the moment of birth to actual mixing. And we call this the golden hour. We've done multiple simulations in order to go through the different scenarios in order to achieve the perfect sequence of event so that we can achieve appropriate mixing at the atrial level. And we produced also pre-printed orders for our nurses to be efficient with RTs and medical teams. We also provided and created a pamphlet for the community, both in French and English, so that the transport team is able to provide this to the parents when they take a baby with cyanosis, because if you remember, this is the most common cyanotic heart lesion in the first week of life. And if they need septostomy, often cardiology will need to call them very quickly and obtain the consent very quickly. And so you don't want to have any time wasted, and having these kinds of information template may help the parents prepare about the information they're about to get. The second case is Julian, which was born at 35 weeks in the mono-di twins, Apgar 999, was vigorous with no resuscitation. He was admitted to the nursery because the weight was 1.9 kilo, was kept on room air, but was found to have saturation between 80 to 83%, both in the pre and post-ductal limb. You auscultate the patient and found a hollow systolic murmur. The baby's in no distress. The heart rate is normal, has normal pericardium, precordium, and normal pulses, and the x-ray looks within normal limit. You call your referring center, in this case, the Montreal Children's Hospital, and we recommend to start PG at 0.02, and on arrival, the saturation 94%. This is the patient echo, and what we see here is the RV outflow tract and the pulmonary valve, which we see quite still-ming. And when you look at the blood flow, there's acceleration, and this redness is actually the ductus providing blood flow to the pulmonary artery. So this is a diagnosis of critical pulmonary stenosis. In the context of critical pulmonary stenosis, what happens is that the RV is facing a very, very high afterload. And because of that, the RV is not able to pump much blood flow into the pulmonary artery. Blood will flow back to the right atrium, which will be under higher pressure and will pop off into the left atrium, in which case you get deoxygenated blood mixing with oxygenated blood into the systemic compartment, giving this desaturation all throughout your ascending and descending aorta. In this case, your ductus is quite important to provide blood flow into your pulmonary circulation because you don't get enough RBCs going into your RV outflow tract into the pulmonary circulation. And the more this ductus will close and the more profoundly this baby will become desaturated because you get more blood flow pop-off from the RA to the LA. So in this case, you get a pulmonary dependent ductal circulation, which can occur actually in different setting and heart configuration, and eventually will lead to different types of neonatal management and prognosis down the line. But in the community, these patients, if they're blue, will need PGE for ductal patency. So on its own, pulmonary valvular stenosis can be mild to severe, and the most critical one is actually pulmonary atresia. And pulmonary atresia can also occur in the context of an intact or non-intact ventricular septum, and these two entities are quite different. And finally, tetralogy of Fallot or DORV-TOF also may have various degrees of RVOT obstruction and can present sometimes in a similar fashion. So when blue, you want to maintain your ductal patency until confirmation of the underlying diagnosis. And you want to consider stabilization of her respiratory status to avoid confounder. So for example, if the baby was quite unstable, we would have probably intubated or provided non-invasive support. But in a baby with absolutely no respiratory distress, normal CO2, maybe this patient can also stay in room air and just unload those PGE, but you need to engage a discussion with your local expert teams. This case is Maria, which was born from a mother with a rheumatological condition that required biological therapy. But this mother had actually very high arthritic changes and pain during her pregnancy that actually required naproxen therapy. A C-section was done at 34 weeks because the baby was not growing and there was abnormal Doppler profile. She received bedmetazone before delivery. Baby was born small for gestational age. PPV was initiated in the delivery room because the baby was hypoxic and apneic, and eventually is brought to the NICU on 100% oxygen with pre and post saturation of 75%, despite 100% oxygen. This baby was put on high frequency oscillation and the CO2 was around 55 with a profoundly low PaO2. This is the X-ray of this patient, and you can see there's not marked RDS, but the fields are quite black. So big expansion of lungs and very black fields. Upon an echo, what you can see here are different views of the atrium. This is the right atrium, this is the left atrium. Blue means going away from the probe, and what you can see is that there's blue blood continuously entering into your systemic circulation. Upon ductal view, this patient doesn't have a ductus. So this is a diagnosis of PPHN. In the context of PPHN, what happens is that you have high pulmonary vascular resistances, and there's disturbed extrauterine transition where these pulmonary vasculature is not relaxing. Because of that, the RV is facing a high afterload. Because of that, the RV fails. Eventually, there's backup into the right atrium, which will send blood flow from the RA to the LA as a pop-off, bringing the oxygenated blood into the left atrium. The other thing is that because there's not a lot of pulmonary blood flow, well, the pulmonary veins are not receiving a lot of blood flow and the LA is underfilled, promoting this shunting, and you get pre-ductal saturation that is very low. But this patient doesn't have the ductus. So the pre-ductal saturation stayed low all along the course of the aorta. And despite the absence of pre and post-ductal differences, this patient is in PPHN. So this is a reminder that in prenatal life, you get very limited amount of RV output going to your pulmonary circulation. And because of that, the pulmonary vasculature will grow normally, but without being over-muscularized. If you get after birth, during your normal transition, your PVR will drop quite acutely, but will continue to drop up to 6 weeks of life to reach normal values of the pediatric life, while the systemic vascular resistance will rise because you actually clump your placenta. And so you get rid of a big vascular network that is of low resistance. So the premature closure of the ductus has been reported in patients exposed to maternal NSAIDs. And so in this case, you get more than the 10% and excessive pulmonary blood flow into the pulmonary vascular bed. This leads to pulmonary vascular remodeling, vasoconstriction, and the arterioles become much more muscular. So in the postnatal setting, you don't get this nice drop in the pulmonary vascular resistance. These patients will present with hypoxic rest failure, black lungs, and RV failure. If you do have a ductus, that's when actually these patients may unload their pulmonary pressure into the systemic circulation. And if you start with a low preductal saturation because of the mixing at the atrial level, you may even so more have a profound postductal differential. So these babies might have, like, for example, 85% of saturation in preductal and 70% in the postductal because of the shunting at the ductal level. And just notice that, I just mentioned that interrupted aortic arch and coarctation can present with these pre-postductal saturation differences, but typically the interrupted aortic arch will have quite normal preductal saturation, and they will also show signs of very profound hypoperfusion to the distal limbs. So this is an echo showing the ductus, pulmonary artery to aorta, and in that particular patient, you can see blue flow, showing that blood flow is going from the pulmonary artery and bringing the oxygenated blood into the descending aorta. This is an echo showing very dilated RV with the LV that eventually gets completely pancaked and squished by this RV that is suprasystemic in terms of pressure. So what is the management? Well, you want to ensure appropriate ventilation, but avoid hypocapnia because of the cerebral vasoconstriction. These patients require some degree of calmness. So sometimes they need sedation and analgesia, but you want to use also non-pharmacological way to avoid reactive increase in PVR. Oxygen should be administered to aim higher saturation in the 90 to 95%, so whatever we aim for babies. But because of the shunt, sometimes there's a threshold at which increasing oxygen does not increase your oxygen saturation. And INO is the only agent that has been studied in RCT for PPHN, but really for the term and near-term newborns. These patients may need inotropic support and hydrocortisone. Some of them may actually need prostaglandin to unload their RV if they have a ductus that is restricted. So in the case of a premature closure of the ductus, you can give PG, but the ductus will unlikely open. And in some of these babies with PPHN, they may have concomitant stressor and perinatal depression, and you have to consider that they may have underlying hypoxic ischemic encephalopathy. And so these patients should be evaluated for candidacy for therapeutic hypothermia. The last case I want to briefly talk about is Caroline. She's 39 weeker, 2.4 kilo, normal core pH. She was well at birth, and at 10 minutes of life, she was found to be hypotonic with superficial breathing. She was started on CPAP. She was eventually transitioned to hyponasal cannula, and oxygen actually profoundly increased because of desaturation in the 84. When the transport team arrived, the 502 was over 100%, and despite that, B was still in the low 80s, and sometimes saturation around 92%, but really between 88 and 92%. So the baby was intubated, gave surfactant, transferred to us, and at that time, the FI2 was 70% with saturation of 94, and there was no differentials of SATs. This was the X-ray on arrival, which was kind of odd. We wondered, well, could it be TTN? Could it be that there's a bit of edema? Is it RDS? But the lung looked nicely expanded. So due to the non-response to surfactant and the pulmonary edema suspicion on X-ray, we actually called cardiology and we said, well, could this be TA-PVR? And so they confirmed that this was an obstructed TA-PVR of infracardiac type. The atrial septal defect was shunting right to left. There was a suprasystemic RV with severe RV dilation, and this baby was operated the same day for repair. So in this context, what's happening is that all the pulmonary venous return fully mixes into the right atrium with the systemic venous return, And so your entire blood becomes desaturated, enters your RV, your PA goes back to your lungs. And to get blood flow into your left atrium, you have an obligatory shunt from your RA to your LA, eventually going to your LV and feeding your aorta. The big problem with this disease is if this conduit that's bringing back the pulmonary venous return gets obstructed. And this often happens in infradiaphragmatic type of TAPVR because it goes to the ductus venosus, which eventually closes. If it closes, what happens is that the pulmonary venous drainage is impaired, it's blocked, and so you get pulmonary edema because the lungs cannot drain, and you get post-capillary pulmonary hypertension, and eventually RV failure. And this is actually a surgical emergency. Because there's full mixing and obligatory right to left shunt, these babies will never saturate at 100% despite 100% oxygen. And this is another case actually that presented a bit later in life, and you can see how there's actually very significant pulmonary edema. So in conclusion, the blue baby differential diagnosis includes pulmonary and cardiac conditions, but they're clinically discernible. Non-response to oxygen likely indicates an extrapulmonary right to left shunting. Physical examination may allow to differentiate between these entities. And when you consider an underlying cardiac condition, management in the community is key and should include prostaglandin, stabilization of the risk airway with possible intubation or non-invasive support. And you should be calling your teams at the referral center from neonatology and cardiology because time is of essence for many of these conditions, such as transposition of great artery, which is the most common diagnosis in the first week of life, so cyanotic heart defect, and they may need urgent balloon atrial septostomy, or TAPVR, which may need an urgent surgical correction. So thank you so much for your attention. You'll find here a QR code that will bring you to the website of the NeoCardio Lab, or you can download the NeoCardio Lab app. You can follow me on Twitter at CardioNeo, and on the app, you will find many of the solutions, physiology, and echocardiography that could be of help for educational opportunities. Thank you for your attention.
Hello, everyone. I would like to thank the organizers for letting me speak here today. And I will talk about cardiac assessment and management of infants with neonatal encephalopathy. I have no conflicts of interest to disclose. Our objectives for today are to discuss physiologic concepts that are important to understand about these babies with neonatal encephalopathy. We will talk about assessment with different tools and management strategies for these babies. And by the end, we will talk a little bit about predictors of outcome. Starting with the first part, physiologic concepts of babies with neonatal encephalopathy. The fetal circulation is different from the postnatal circulation because oxygen delivery comes from a different origin, the placenta as opposed to the lungs. As such, oxygenated blood from the placenta goes through the umbilical vein to the ductus venosus, inferior vena cava, and there to the right atrium, where preferential flow causes the most oxygenated blood to cross through the foramen ovale into the left side of the heart, and then left atrium, left ventricle, and through the aorta to the most important part or target organ, which is the brain. Blue blood is shunted away from the lungs through the PDA into the aorta to supply the lower parts of the body. And the lungs themselves, which are not very active in this cycle during fetal life, get only about 10% of the cardiac output. When a baby is born, that circulation needs to rapidly change. With the first breath and clamping of the cord, many physiologic adaptations happen almost at once. There is an increase in systemic blood pressure because the low pressure placenta is no longer connected. The lungs, which are filled with fluid in fetal life, need to fill with air, and increased oxygen concentration in the lungs causes vasodilation of the pulmonary vasculature and the increase in pulmonary blood flow. That would enable the lungs to fulfill their new job as the gas exchange organ. But the transition process isn't always as smooth. About 10% of babies would need some degree of active intervention to ensure proper transition during birth. In 1 to 2 per 1,000 births, a full resuscitation is needed. And depending on where you live in the world, neonatal encephalopathy or hypoxic ischemic injury occurs in between 2 to 9 babies per every 1,000 live births. These are some important definitions. Hypoxia or hypoxemia talk about the partial or complete lack of oxygen supply or oxygen in the blood. Ischemia is the reduction or complete cessation of blood flow to an organ. And asphyxia talks about the specific situation of fetal life where blood and oxygen supply are not coming through the placenta. The pathophysiology of the hypoxic ischemic event is usually multifactorial. There can be a catastrophic event, such as placental abruption or maternal cardiac arrest. And then the event is mostly acute and could be timed. But there can be many more chronic and subtle contributors. In these cases, like when there are some maternal risk factors, a degree of placental insufficiency, and prolonged partial hypoxia ischemia process, the fetus has to compensate in utero already and has lower reserves. And then a seemingly uncomplicated delivery can become a significant stressor for that fetus. The pathophysiology and cardiovascular changes with hypoxia ischemia are complex. I will now try to address some of the most important concepts. When partial chronic hypoxia ischemia occurs in utero, there are some adaptations that help protect the vital organs. Blood flow is diverted to mainly the brain, heart, and adrenals, and vasoconstriction decreases blood supply to other organs, which means that the fetal lungs get less than that 10% of cardiac output that they usually get. The brain is relatively protected by an ability to use alternative substrates like ketones and lactate, but other organs are less resilient. The increased catecholamines also cause a decrease in lung liquid clearance in preparation for delivery and worsen the peripheral vasoconstriction that happens. And with the increasing severe hypoxia ischemia, the protection mechanisms start to fail. And then the end result is severe metabolic and lactic acidosis with concomitant multi-organ failure. Sadly, the initial insult is not the only contributor to injury. And secondary injury, reperfusion injury, and our interventions, while life and neuron saving, also contribute to further damage and injury to those organs. Even without ischemic injury, the neonatal heart does not react to challenge the same way as an adult's heart would. A small increase in afterload causes a steep decrease in contractility and heart function. To add to that, hypoxia upregulates molecular pathways that cause further decrease in contractility, and the immature heart is more vulnerable to reduced perfusion than the adult one, thus resulting in a vicious cycle of injury. Decreased function that causes more severe decrease in perfusion and further myocardial injury. There is also a difference in the effect on each ventricle, with the right ventricle being more vulnerable because of its shape, increased surface area, and its more active metabolic role in fetal life and transition. Interventricular interactions complicate matters further with shared myocardial fibers and a shared septum. If one ventricle fails, then the other's function is also affected. We already explained how these babies are primed in utero for pulmonary hypertension because of the fetal diving reflex. Other contributors to pulmonary hypertension can be various lung diseases, metabolic acidosis, and our own interventions and treatments. This leads us to a second vicious cycle, where pulmonary hypertension causes a brick wall that prevents from blood to go into the lungs. There is reduced pulmonary blood flow that leads to lower preductal cardiac output, which magnifies the ischemic insult to the heart, causing right ventricle injury and even further decrease in the pulmonary blood flow. Ventilation perfusion matching, or VQ matching, is an important concept. In this illustration, baby A is a healthy baby who has normally dilated blood vessels and aerated alveoli. B is a baby with lung disease. The healthy reaction to that is vasoconstriction of the blood vessels to improve VQ matching. Baby C has severe neonatal encephalopathy with pulmonary hypertension, but otherwise a normal lung parenchyma. These lungs can partially compensate by pneumoconstriction, and these babies might not even need increased O2 at all. Baby D is the most severely affected because with both severe pulmonary hypertension and lung disease, there is VQ mismatching that cannot be corrected, and we would need to work extra hard to prevent these babies from dying on us. Our interventions also affect the physiology. Lung volume is a major determinant of pulmonary vascular resistance. So if we ventilate the baby with too much pressure, we can actually cause kinking or constricting of pulmonary vasculature and increase the pulmonary hypertension that is already there. You may remember the Laplace law, that an increase in preload or volume causes an increase in stroke volume. That is the idea behind giving an older child or an adult some volume to increase cardiac output and contractility. But in the neonates, a failing and sometimes immature heart cannot compensate in the same way, and the compensation is very limited. Adding to that, most babies have renal injury because of the hypoxic insult, and volume in the form of excess fluids or blood products becomes very dangerous and should be given judiciously. Therapeutic hypothermia is the only treatment following HIE that was shown to improve long-term outcomes. But hypothermia also causes many challenges to the already struggling organs. The low temperature on its own increases pulmonary pressure by 1% for every 1 degree Celsius. It causes hormonal and metabolic changes. It shifts the hemoglobin-oxygen dissociation curve to the left, and it affects the hemodynamics by reducing cardiac output and increasing vascular tone. When VQ mismatch is severe, the baby may not tolerate cooling and manifest as hypoxic respiratory failure. Luckily, this is not very common, and it is quite rare that we need to stop hypothermia because of pulmonary hypertension. For the second part, we will talk about assessment and management of babies with neonatal encephalopathy. Our strongest tool as medical personnel still lies in the basics of clinical knowledge. But as we assess these babies, it is crucial to remember the pitfalls. Capillary refill is prolonged because of vasoconstriction and not reflecting whole body perfusion. Urine output will be decreased due to multiple insults. Heart rate is not predictable, and lactate is typically more reflecting the initial injury and not adding information about the ongoing processes. Blood pressure in itself is a rat hole. How do we assess and interpret blood pressure? Do we look at the mean blood pressure, at the systolic, at all the different components at once? In a survey of American NICUs published by Dr. Regan Gaisinger and colleagues, no universal definition for hypotension was accepted, and at least 17 distinct thresholds for intervention were identified. If we stop looking at only the mean and use systolic blood pressure as more reflective of cardiac output, and diastolic blood pressure as reflecting vascular tone, it could improve the detection of low cardiac output states. We should also remember that the mean is affected more by the diastolic blood pressure, it's 2/3 of it, and therefore would be abnormally high when the systolic might be a bit low. If blood pressure is measured at a post-ductal location, then a PDA can augment the cardiac output and would cause us to overestimate brain perfusion. So what measure can be used reliably? Well, I'm not exactly objective, but targeted neonatal echocardiography may enhance precision of the diagnosis and the interventions that we use, and allow us to differentiate between babies that have different underlying problems, but clinically would give a similar presentation. Here we can see an apical 4-chamber view showing us the 4 chambers, right atrium, right ventricle, left atrium, and left ventricle together. Right ventricular dysfunction can be appreciated in this video. This right ventricle is dilated and larger compared to the left. We can also use TAPSE, tricuspid annular plane systolic excursion, which is a measure of right ventricular systolic function. And here, taken on the right, it is very flat and low. Pulmonary pressure estimation can be done by measuring the tricuspid regurgitation by a continuous wave Doppler on the tricuspid valve and adding to that 5 millimeters of mercury estimated as the right atrial pressure, and that would give us an estimated pressure of the pulmonary arteries. We can also assess pressure by looking at a parasternal short axis, which is the video here on the right, that shows the left ventricle on the bottom and right ventricle above it. And we look at the septum in between them. Usually the septum needs to look very round. And if we see septal flattening or see it pancaking and bowing into the left ventricle, that is a subjective and qualitative measurement of pulmonary hypertension. We can also quantify it and measure an eccentricity index to give it a number. Fetal shunts are also useful for evaluating the pressure balance between heart chambers. Blood would always flow to where there is less resistance, meaning lower pressure. So a patent foraminal is normally with red flow over it, meaning left to right flow. But with increasing pulmonary hypertension, the flow becomes bidirectional and eventually completely right to left, indicating suprasystolic pulmonary hypertension. A patent ductus arteriosus, or PDA, is another shunt that can give us an indication about the pressure between chambers. What we see here on the left is a PDA shunting both red and blue, which means that it shunts bidirectionally. It is also important to remember that if the PDA is only blue, meaning right to left, it may also serve as a pressure release and actually be supporting of a failing right ventricle. In this apical four-chamber view, we can appreciate a very dilated left ventricle as opposed to the right one we saw before. And with putting our pulse wave Doppler on the outflow track towards the aorta, we can reveal a low left ventricular output state. So now, after seeing some images and understanding how we can measure cardiac function, I will tell you and I will show you some studies explaining how cardiac function correlates with severity of hypoxic ischemic injury and improves after therapeutic hypothermia. In a study done by Hochwald, the left ventricular output of babies was measured during therapeutic hypothermia after warming and compared to healthy infants. The lowest cardiac output was seen during the hypothermia, with some improvement after rewarming, and the best and highest cardiac outputs seen in the control babies. Strain measurement or speckle tracking also shows decreased cardiac function in babies with hypoxic ischemic injury. The white circles in this graph are healthy infants, and they demonstrated better function compared to both therapeutic hypothermia treated HIE infants and normothermia treated HIE infants. In another study by Segal et al., they compared the global longitudinal strain between infants following asphyxia during therapeutic hypothermia to healthy comparable gestational age and weight newborns. The 21 asphyxiated infants had lower longitudinal strain, LV output, and shortening fraction, which is a measure of systolic left ventricular function, compared to the healthy neonates. Global longitudinal strain positively correlated with the left ventricular output, as seen in this graph. And infants that were on inotropes had greater global deformations compared to those not treated with inotropes. In a prospective study that we conducted of 56 neonates that had moderate to severe neonatal encephalopathy and were undergoing therapeutic hypothermia, we did serial echocardiography assessment for babies that had confirmed brain injury on MRI. The markers of cardiac performance, like TAPSE, which is systolic right ventricular function measure, right ventricular output, and left ventricular output, significantly increased over time, indicating improved cardiac function by the 10th day of life. Cardiac biomarkers can also indicate cardiac function. In the adult world, there is large understanding of which markers to use and their thresholds. In neonates, the knowledge is yet to be obtained and established. Different markers were studied by different investigators, and not all laboratories and all hospitals perform the same markers and offer results for all of them. I will talk today about 4 main markers: troponin, which can be divided into cardiac troponin T and cardiac troponin I, but are both considered cardiac specific, and creatine kinase, which can be measured as a total and is considered non-specific, and CKMB, which is supposedly cardiac specific. In a study by Gunas, they measured troponin T, CKMB, and total CK in 45 asphyxiated and 15 healthy infants during the first 15 days of life. All 3 biomarkers had trends that were corresponding to the Cernat degree, meaning the degree of hypoxic ischemic injury. In a different study by Lee, troponin I levels within the first 6 hours after birth were obtained in 61 infants and were significantly higher in those that had severe or moderate HIE compared to those who had only mild injury. A troponin I cutoff of more than 60 picograms per milliliter predicted moderate to severe injury with a specificity of 81% and a negative prediction rate of 77. There was no difference in troponin I levels between infants that underwent therapeutic hypothermia to those who did not, meaning that troponin I is not affected by therapeutic hypothermia, but does correlate with HIE severity. Only a few studies correlated markers of cardiac function as seen by echocardiography to cardiac viral markers that can be measured in the blood. In this study by Bu, there was a correlation between low ejection fraction below 60 with troponin T, but not with CKMB. Ejection fraction is a measure of left ventricular systolic function. In our study, the 3 biomarkers that were measured were troponin I, total CK, and urotensin. All 3 decreased over time in correlation with the increase in measures of cardiac function as measured by echocardiography. Of the 3, CK had the best correlation with cardiac function, especially with measures like TAPSE, which is a measure of right ventricular systolic function, and the ventricular outputs. We constructed receiver operating curves, ROC curves, to assess the optimal sensitivity and specificity of the biomarkers. CK was more sensitive and troponin I more specific of less than 7 millimeters. Combining the 2 can allow physicians in settings where echocardiography is not available to have an idea about cardiac performance and especially right ventricular dysfunction. Other methods that we can use to monitor and assess these babies are near-infrared spectroscopy, or NIRS, that allows for evaluation of regional venous saturation. A high cerebral NIRS was associated with adverse neurodevelopmental outcomes, maybe because the injured brain consumes less O2 and therefore would give a higher value compared to an active brain. It is also important to remember that a brain that has seizures is more metabolically active, and therefore their NIRS numbers will be lower. Heart rate variability measurement is another novel method of well-being assessment. Lower variability is seen in the more severely injured babies. The management of these complex babies should follow as much as possible the general concepts that are listed here. Our management needs to be targeted and individualized based on the understanding of the physiology. We need to choose our medications and treatment options by setting physiologic goals, and we need to remember the possibility of multi-organ dysfunction. It is useful to remember the agents available for treatment not only by their molecular effects like alpha and beta receptor activity, but by the physiologic mechanism that they fulfill. For me, it's even more sensible. So we have selective pulmonary vasodilation, that is inhaled nitric oxide. We have non-selective vasodilators like milrinone and sildenafil. We have agents that are primary vasopressors like dopamine, norepinephrine, and vasopressin. We have inotropes that I called them here cardiac supporters. The classic ones are dobutamine and epinephrine, but I listed here also prostaglandins, because in cases where there is extreme, very severe pulmonary hypertension, keeping that ductus open with prostaglandins can actually save a failing right ventricle because it gives it a pop-off. It also is important to remember endocrine modulation or hydrocortisone that many times is needed because of adrenal insufficiency. This great table can be found in Dr. Gazinger's article. It gives several management suggestions based on the physiology as seen in echocardiography. It differentiates between different treatment options and suggestions based on the physiology. If you see right ventricular dysfunction, left ventricular dysfunction, pulmonary hypertension, or some combination between the three. Inhaled nitric oxide is a good selective pulmonary vasodilator and is the first line of treatment in babies with isolated pulmonary hypertension with normal ventricular function. It is important to remember that when lungs are intact, so is VQ matching. An excessive pulmonary return can cause increased cerebral blood flow and reperfusion injury, especially during the rewarming phase. Milrinone is used by many units as it is considered to have both vasodilatory treats and to support cardiac function. However, caution is advised. In this study by Adrian Bishop, they compared HIE babies that were treated with Milrinone to HIE babies without Milrinone and to non-HIE babies that were treated with Milrinone for other reasons. The HIE Milrinone infants depicted in red in these graphs had lower systolic and diastolic blood pressures, along with higher need for inotropes following Milrinone exposure. It is also important to remember that Milrinone is cleared by the kidneys, and if we have renal injury as part of our multi-organ failure, then this Milrinone will remain metabolically active and just stay in the baby's body and not go anywhere. Dopamine, although used as a first line for any neonatal instability situation for years, should also be used with caution, as it causes an increase in pulmonary vascular resistance that is disproportionate to the increase in systemic vascular resistance, especially at a high dose, as seen here in this study done on piglets, compared to both placebo and low-dose dopamine with epinephrine. And for the last part of my talk, a few words about outcome predictors. Different markers in different modalities were associated with outcomes, and these are just a few of the examples that can be found in literature. A cardiac troponin I cutoff of less than 0.15 nanograms per milliliter in babies treated with therapeutic hyperthermia predicts good outcomes. Higher superior vena cava flow seen by echocardiography was associated with poor outcomes on MRI. Pulmonary hypertension itself, if present, was associated with injury on brain MRI of babies. And right ventricular dysfunction at 24 hours was associated with death or abnormal MRIs and with long-term. And as I mentioned in the previous slide, in this study, impaired right ventricular performance seen by both TAPSE and fractional area change, which are measures of systolic right ventricular function, are associated with worse outcomes. And we can see in this raw curve here that they both had quite good area under the curves for prediction. So in conclusion of my talk, a few take-home messages. Cardiac function understanding and assessment is crucial for the correct management of the infant with neonatal encephalopathy. Management should be individualized according to physiology, and preferably as seen by echocardiography. Neurologic outcomes are associated with aspects of cardiac function. But the question remains, can we really improve outcomes by better correcting the physiology? That is yet to be answered, and hopefully studies in the future will give us more information about that. I want to thank you all for being with me here today and would love to answer any questions. Thank you.
Thank you for the poor speakers, and the presentations were great, fantastic, and very practical. Unfortunately, it's 12:05, so we need to go for lunch break. There are lots of questions, many of them already being answered. If you have more questions, just email. The emails are there. Just email the speakers, and see you at 1 o'clock. Thank you.
Il y en a partout des enfants avec des malformations cardiaques. Si vous questionnez, si vous cherchez, vous entendez toujours parler d'histoires. Dans le temps, on disait, nos grands-mères accouchaient puis ils perdaient un bébé. On disait, oh, c'était un bébé bleu. Mais ces bébés bleus-là, c'était des bébés avec des malformations cardiaques. Bonjour, je suis Anne Fournier, je suis une cardiologue pédiatre qui travaille avec les enfants malades du cœur depuis plusieurs années maintenant. J'ai l'impression que c'est hier. Enfin, je les aime beaucoup, ces enfants-là, puis je me sens privilégiée de faire le travail que je fais. Alors, j'étais jeune étudiante à l'hôpital Sainte-Justine, j'étais encore en formation et mon patron de l'époque, le docteur André Davignon, m'a dit, il faudrait bien qu'il y ait une fondation pour les enfants malades du cœur. J'ai dit, faites-le, puis j'embarque. Et ça a commencé comme ça. On a trouvé des mamans d'enfants cardiaques qui étaient motivées, qui se sont impliquées. Et on a mis sur pied la Fondation En Cœur, la Fondation québécoise pour les enfants malades du cœur, en 1984. Alors, qu'est-ce que ça fait En Cœur? Plein de choses. Alors, c'est là pour soutenir les parents puis les familles. Alors, soutenir par de l'information. Soutenir par les mettre en contact avec d'autres gens qui ont vécu les mêmes choses. Fait que ce support-là, ça aide les parents à passer à travers, puis ça aide l'enfant à passer à travers. Il y a des recherches qui montrent que si les mamans sont moins anxieuses, moins inquiètes, l'enfant va avoir un meilleur devenir avec les années. Mon cœur aussi offre des services d'hébergement. Alors, les hôpitaux qui offrent des services de chirurgie cardiaque pour les enfants dans la province de Québec, c'est ici à Québec au CHUL, c'est l'hôpital Sainte-Justine à Montréal, puis l'hôpital de Montréal pour enfants. Mais les enfants, ils vivent partout dans la province de Québec, là. Et encore offre le logement à proximité de ces hôpitaux-là. Quand tu as déjà tout le stress de la chirurgie de ton enfant, si on peut enlever un peu de stress financier, pourquoi pas? Fait qu'Encar offre tout ça à proximité. Et ça a été déjà commencé dès les débuts de la Fondation. Une autre chose qu'Encar a permis de développer de façon importante, c'est les cliniques mobiles de cardiologie pédiatrique. Les gens de Québec, les gens de Montréal, les cardiologues ont toujours été faire des cliniques ailleurs, en périphérie. Et avec les années, puis surtout au début, le support de la Fondation Encar, cette activité-là clinique s'est développée de façon exponentielle. Et Encar a été là dans le début pour nous soutenir pour les achats d'équipements, pour la camionnette qui permettait de transporter les équipements. C'est pour l'année 2015, juste les activités qu'on fait à Sainte-Justine. On fait économiser 600 000 $ par année aux familles d'enfants cardiaques à cause des cliniques itinérantes de cardiologie. Et c'est vraiment une fierté dans le cadre d'avoir permis le déploiement de ça puis d'arriver avec des activités super importantes pour tous ces enfants-là et ces familles-là.
Technology is increasingly present in our lives, shortening distances, bringing faster solutions, and with more practical ways of living day by day. We believe that for all of this to make sense, every solution needs a reason to exist. So why not focus on using this technology to solve real problems in our society? At a time when neonatology had an important reduction in mortality, and today it has the challenge of preserving the quality of life of patients and their families, in a scenario where the number of children with disabling diseases is very large, representing a hard socioeconomic burden in Brazil and in the world. In a country of continental proportions, where the heterogeneity of resources, protocols, and conducts represents a harsh reality. PBSF, Protecting Brains and Saving Futures, was born. with the motto of bringing accessible technology and intelligence to prevent neurological sequelae, as with the objective of promoting initial and longitudinal education and training, and also facilitating the implementation of methodologies and tools for early diagnosis and neuroprotection on a large scale. And for this, we created the CSI, a central of surveillance and intelligence where we use an advanced telemedicine system to break borders and shorten distances. In this scenario, we've already monitored more than 4,000 children in more than 270,000 hours of monitoring, distributed in more than 30 hospitals located in all 5 regions of the country. In addition, we're extremely pleased to work with international partnerships with a focus on education, research, and technological development. But we want to go further, generating homogeneity of protocols and conducts between distant centers and with different resources. With intelligent monitoring, longitudinal education, and capacity building, we can better serve high-risk babies. Together, we can make a difference in the lives of each of these little patients. We believe in the fundamental importance of each of these children being able to read, learn, and believe in tomorrow. Only in this way can we build a country and a better future. PBSF. Learn more at pbsf.com.br.
Il y en a partout des enfants avec des malformations cardiaques. Si vous questionnez, si vous cherchez, vous entendez toujours parler d'histoires. Dans le temps, on disait, nos grands-mères accouchaient puis ils perdaient un bébé. On disait, oh, c'était un bébé bleu. Mais ces bébés bleus-là, c'était des bébés avec des malformations cardiaques. Bonjour, je suis Anne Fournier, je suis une cardiologue pédiatre qui travaille avec les enfants malades du cœur depuis plusieurs années maintenant. J'ai l'impression que c'est hier. Enfin, je les aime beaucoup, ces enfants-là, puis je me sens privilégiée de faire le travail que je fais. Alors, j'étais jeune étudiante à l'hôpital Sainte-Justine, j'étais encore en formation et mon patron de l'époque, Dr André Davignon, m'a dit « il faudrait bien qu'il y ait une fondation pour les enfants malades du cœur. » J'ai dit « Faites-le », puis j'embarque. Et ça a commencé comme ça. On a trouvé des mamans d'enfants cardiaques qui étaient motivées, qui se sont impliquées. Et on a mis sur pied la Fondation En Cœur, la Fondation québécoise pour les enfants malades du cœur, en 1984. Alors, qu'est-ce que ça fait En Cœur? Plein de choses. Alors, c'est là pour soutenir les parents puis les familles. Alors, soutenir par de l'information. Soutenir par les mettre en contact avec d'autres gens qui ont vécu les mêmes choses. Fait que ce support-là, ça aide les parents à passer à travers, puis ça aide l'enfant à passer à travers. Il y a des recherches qui montrent que si les mamans sont moins anxieuses, moins inquiètes, l'enfant va avoir un meilleur devenir avec les années. Mon cœur aussi offre des services d'hébergement. Alors, les hôpitaux qui offrent des services de chirurgie cardiaque pour les enfants dans la province de Québec, c'est ici à Québec, au CHUL, c'est l'hôpital Sainte-Justine à Montréal, puis l'hôpital de Montréal pour enfants. Mais les enfants, ils vivent partout dans la province de Québec, là. Et encore offre le logement à proximité de ces hôpitaux-là. Quand tu as déjà tout le stress de la chirurgie de ton enfant, si on peut enlever un peu de stress financier, pourquoi pas? Fait qu'Encore offre tout ça à proximité. Et ça a été déjà commencé dès les débuts de la Fondation. Une autre chose qu'Encore a permis de développer de façon importante, c'est les cliniques mobiles de cardiologie pédiatrique. Les gens de Québec, les gens de Montréal, les cardiologues ont toujours été faire des cliniques ailleurs, en périphérie. Et avec les années, puis surtout au début, le support de la Fondation Encore, cette activité-là clinique s'est développée de façon exponentielle. Et Encore a été là dans le début pour nous soutenir pour les achats d'équipements, pour la camionnette qui permettait de transporter les équipements. C'est pour l'année 2015, juste les activités qu'on fait à Sainte-Justine, on fait économiser 600 000 $ par année aux familles d'enfants cardiaques à cause des cliniques itinérantes de cardiologie. Et c'est vraiment une fierté d'Encore d'avoir permis le déploiement de ça puis d'arriver avec des activités super importantes pour tous ces enfants-là et ces familles-là.
Technology is increasingly present in our lives, shortening distances, bringing faster solutions, and with more practical ways of living day by day. We believe that for all of this to make sense, every solution needs a reason to exist. So why not focus on using this technology to solve real problems in our society? At a time when neonatology had an important reduction in mortality, and today it has the challenge of preserving the quality of life of patients and their families, in a scenario where the number of children with disabling diseases is very large, representing a hard socioeconomic burden in Brazil and in the world. In a country of continental proportions where the heterogeneity of resources, protocols, and conducts represents a harsh reality. PBSF, Protecting Brains and Saving Futures, was born with the motto of bringing accessible technology and intelligence to prevent neurological sequelae, as with the objective of promoting initial and longitudinal education and training, and also facilitating the implementation of methodologies and tools for early diagnosis and neuroprotection on a large scale. And for this, we created the CSI, a central of surveillance and intelligence where we use an advanced telemedicine system to break borders and shorten distances. In this scenario, we've already monitored more than 4,000 children in more than 270,000 hours of monitoring, distributed in more than 30 hospitals, located in all 5 regions of the country. In addition, we're extremely pleased to work with international partnerships with a focus on education, research, and technological development. But we want to go further, generating homogeneity of protocols and conducts between distance centers and with different resources. With intelligent monitoring, longitudinal education, and capacity building, we can better serve high-risk babies. Together, we can make a difference in the lives of each of these little patients. We believe in the fundamental importance of each of these children being able to read, learn, and believe in tomorrow. Only in this way can we build a country and a better future. PBSF. Learn more at pbsf.com.br.
Il y en a partout des enfants avec des malformations cardiaques. Si vous questionnez, si vous cherchez, vous entendez toujours parler d'histoires. Dans le temps, on disait, nos grands-mères accouchaient puis ils perdaient un bébé. On disait, oh, c'était un bébé bleu. Mais ces bébés bleus-là, là, c'était des bébés avec des malformations cardiaques. Bonjour, je suis Anne Fournier, je suis une cardiologue pédiatre qui travaille avec les enfants malades du cœur depuis plusieurs années maintenant. J'ai l'impression que c'est hier. Enfin, je les aime beaucoup, ces enfants-là, puis je me sens privilégiée de faire le travail que je fais. Alors, j'étais jeune étudiante à l'hôpital Sainte-Justine, j'étais encore en formation et mon patron de l'époque, Dr André Davignon, m'a dit, il faudrait bien qu'il y ait une fondation pour les enfants malades du cœur. J'ai dit, faites-le, puis j'embarque. Et ça a commencé comme ça. On a trouvé des mamans d'enfants cardiaques qui étaient motivées, qui se sont impliquées. Et on a mis sur pied la Fondation En Cœur, la Fondation québécoise pour les enfants malades du cœur, en 1984. Alors, qu'est-ce que ça fait En Cœur? Plein de choses. Alors, c'est là pour soutenir les parents puis les familles. Alors, soutenir par de l'information. Soutenir par les mettre en contact avec d'autres gens qui ont vécu les mêmes choses. Fait que ce support-là, ça aide les parents à passer à travers, puis ça aide l'enfant à passer à travers. Il y a des recherches qui montrent que si les mamans sont moins anxieuses, moins inquiètes, l'enfant va avoir un meilleur devenir avec les années. En Cœur aussi offre des services d'hébergement. Alors, les hôpitaux qui offrent des services de chirurgie cardiaque pour les enfants dans la province de Québec, c'est ici à Québec, au CHUL, c'est l'hôpital Sainte-Justine à Montréal, puis l'hôpital de Montréal pour enfants. Mais les enfants, ils vivent partout dans la province de Québec, là. Et En Cœur offre le logement à proximité de ces hôpitaux-là. Quand tu as déjà tout le stress de la chirurgie de ton enfant, si on peut enlever un peu de stress financier, pourquoi pas? Fait qu'En Cœur offre tout ça à proximité. Et ça a été déjà commencé dès les débuts de la Fondation. Une autre chose qu'En Cœur a permis de développer de façon importante, c'est les cliniques mobiles de cardiologie pédiatrique. Les gens de Québec, les gens de Montréal, les cardiologues ont toujours été faire des cliniques ailleurs, en périphérie. Et avec les années, puis surtout au début, le support de la Fondation En Cœur, cette activité-là clinique s'est développée de façon exponentielle. Et En Cœur a été là dans le début pour nous soutenir pour les achats d'équipements, pour la camionnette qui permettait de transporter les équipements. C'est pour l'année 2015, juste les activités qu'on fait à Sainte-Justine. On fait économiser 600 000 $ par année aux familles d'enfants cardiaques à cause des cliniques itinérantes de cardiologie. Et c'est vraiment une fierté d'En Cœur d'avoir permis le déploiement de ça puis d'arriver avec des activités super importantes pour tous ces enfants-là et ces familles-là.
Technology is increasingly present in our lives, shortening distances, bringing faster solutions, and with more practical ways of living day by day. We believe that for all of this to make sense, every solution needs a reason to exist. So why not focus on using this technology to solve real problems in our society? At a time when neonatology had an important reduction in mortality, and today it has the challenge of preserving the quality of life of patients and their families, in a scenario where the number of children with disabling diseases is very large, representing a hard socioeconomic burden in Brazil and in the world. In a country of continental proportions where the heterogeneity of resources, protocols, and conducts represents a harsh reality. PBSF, Protecting Brains and Saving Futures, was born with the motto of bringing accessible technology and intelligence to prevent neurological sequelae, as with the objective of promoting initial and longitudinal education and training, and also facilitating the implementation of methodologies and tools for early diagnosis and neuroprotection on a large scale. And for this, we created the CSI, a central of surveillance and intelligence where we use an advanced telemedicine system to break borders and shorten distances. In this scenario, we've already monitored more than 4,000 children in more than 270,000 hours of monitoring, distributed in more than 30 hospitals located in all 5 regions of the country. In addition, we're extremely pleased to work with international partnerships with a focus on education, research, and technological development. But we want to go further, generating homogeneity of protocols and conducts between distance centers and with different resources. With intelligent monitoring, longitudinal education, and capacity building, we can better serve high-risk babies. Together, we can make a difference in the lives of each of these little patients. We believe in the fundamental importance of each of these children being able to read, learn, and believe in tomorrow. Only in this way can we build a country and a better future. PBSF. Learn more at pbsf.com.br.
Il y en a partout des enfants avec des malformations cardiaques. Si vous questionnez, si vous cherchez, vous entendez toujours parler d'histoires. Dans le temps, on disait, nos grands-mères accouchaient puis ils perdaient un bébé. On disait, oh, c'était un bébé bleu. Mais ces bébés bleus-là, c'était des bébés avec des malformations cardiaques. Bonjour, je suis Anne Fournier, je suis une cardiologue pédiatre qui travaille avec les enfants malades du cœur depuis plusieurs années maintenant. J'ai l'impression que c'est hier. Enfin, je les aime beaucoup, ces enfants-là, puis je me sens privilégiée de faire le travail que je fais. Alors, j'étais jeune étudiante à l'hôpital Sainte-Justine, j'étais encore en formation et mon patron de l'époque, Dr André Davignon, m'a dit, il faudrait bien qu'il y ait une fondation pour les enfants malades du cœur. J'ai dit, faites-le, puis j'embarque. Et ça a commencé comme ça. On a trouvé des mamans d'enfants cardiaques qui étaient motivées, qui se sont impliquées. Et on a mis sur pied la Fondation En Cœur, la Fondation québécoise pour les enfants malades du cœur, en 1984. Alors, qu'est-ce que ça fait En Cœur? Plein de choses. Alors, c'est là pour soutenir les parents puis les familles. Alors, soutenir par de l'information. Soutenir par les mettre en contact avec d'autres gens qui ont vécu les mêmes choses. Fait que ce support-là, ça aide les parents à passer à travers, puis ça aide l'enfant à passer à travers. Il y a des recherches qui montrent que si les mamans sont moins anxieuses, moins inquiètes, l'enfant va avoir un meilleur devenir avec les années. Cœur aussi offre des services d'hébergement. Alors, les hôpitaux qui offrent des services de chirurgie cardiaque pour les enfants dans la province de Québec, c'est ici à Québec, au CHUL, c'est l'hôpital Sainte-Justine à Montréal, puis l'hôpital de Montréal pour enfants. Mais les enfants, ils vivent partout dans la province de Québec, là. Et encore offre le logement à proximité de ces hôpitaux-là. Quand tu as déjà tout le stress de la chirurgie de ton enfant, si on peut enlever un peu de stress financier, pourquoi pas? Fait qu'Encar offre tout ça à proximité. Et ça a été déjà commencé dès les débuts de la fondation. Une autre chose qu'Encar a permis de développer de façon importante, c'est les cliniques mobiles de cardiologie pédiatrique. Les gens de Québec, les gens de Montréal, les cardiologues ont toujours été faire des cliniques ailleurs, en périphérie. Et avec les années, puis surtout au début, le support de la Fondation Encar, cette activité-là clinique s'est développée de façon exponentielle. Et Encar a été là dans le début pour nous soutenir pour les achats d'équipements, pour la camionnette qui permettait de transporter les équipements. C'est pour l'année 2015, juste les activités qu'on fait à Sainte-Justine. On fait économiser 600 000 $ par année aux familles d'enfants cardiaques à cause des cliniques itinérantes de cardiologie. Et c'est vraiment une fierté d'Encar d'avoir permis le déploiement de ça puis d'arriver avec des activités super importantes pour tous ces enfants-là et ces familles-là.
Technology is increasingly present in our lives, shortening distances, bringing faster solutions, and with more practical ways of living day by day. We believe that for all of this to make sense, every solution needs a reason to exist. So why not focus on using this technology to solve real problems in our society? At a time when neonatology had an important reduction in mortality, and today it has the challenge of preserving the quality of life of patients and their families, in a scenario where the number of children with disabling diseases is very large, representing a hard socioeconomic burden in Brazil and in the world. In a country of continental proportions where the heterogeneity of resources, protocols, and conducts represents a harsh reality. PBSF, Protecting Brains and Saving Futures, was born with the motto of bringing accessible technology and intelligence to prevent neurological sequelae, as with the objective of promoting initial and longitudinal education and training, and also facilitating the implementation of methodologies and tools for early diagnosis and neuroprotection on a large scale. And for this, we created the CSI, a central of surveillance and intelligence where we use an advanced telemedicine system to break borders and shorten distances. In this scenario, we've already monitored more than 4,000 children in more than 270,000 hours of monitoring, distributed in more than 30 hospitals located in all 5 regions of the country. In addition, we're extremely pleased to work with international partnerships with a focus on education, research, and technological development. But we want to go further, generating homogeneity of protocols and conducts between distance centers and with different resources. With intelligent monitoring, longitudinal education, and capacity building, we can better serve high-risk babies. Together, we can make a difference in the lives of each of these little patients. We believe in the fundamental importance of each of these children being able to read, learn, and believe in tomorrow. Only in this way can we build a country and a better future. PBSF. Learn more at pbsf.com.br.
Il y en a partout des enfants avec des malformations cardiaques. Si vous questionnez, si vous cherchez, vous entendez toujours parler d'histoires. Dans le temps, on disait, nos grands-mères accouchaient puis ils perdaient un bébé. On disait, oh, c'était un bébé bleu. Mais ces bébés bleus-là, c'était des bébés avec des malformations cardiaques. Bonjour, je suis Anne Fournier, je suis une cardiologue pédiatre qui travaille avec les enfants malades du cœur depuis plusieurs années maintenant. J'ai l'impression que c'est hier. Enfin, je les aime beaucoup, ces enfants-là, puis je me sens privilégiée de faire le travail que je fais. Alors, j'étais jeune étudiante à l'hôpital Sainte-Justine, j'étais encore en formation et mon patron de l'époque, docteur André Davignon, m'a dit, il faudrait bien qu'il y ait une fondation pour les enfants malades du cœur. J'ai dit, faites-le, puis j'embarque. Et ça a commencé comme ça. On a trouvé des mamans d'enfants cardiaques qui étaient motivées, qui se sont impliquées. Et on a mis sur pied la Fondation En Cœur, la Fondation québécoise pour les enfants malades du cœur, en 1984. Alors, qu'est-ce que ça fait En Cœur? Plein de choses. Alors, c'est là pour soutenir les parents puis les familles. Alors, soutenir par de l'information. Soutenir par les mettre en contact avec d'autres gens qui ont vécu les mêmes choses. Fait que ce support-là, ça aide les parents à passer à travers, puis ça aide l'enfant à passer à travers. Il y a des recherches qui montrent que si les mamans sont moins anxieuses, moins inquiètes, l'enfant va avoir un meilleur devenir avec les années. Mon cœur aussi offre des services d'hébergement. Alors, les hôpitaux qui offrent des services de chirurgie cardiaque pour les enfants dans la province de Québec, c'est ici à Québec, au CHUL, c'est l'hôpital Sainte-Justine à Montréal, puis l'hôpital de Montréal pour enfants. Mais les enfants, ils vivent partout dans la province de Québec, là. Et encore offre le logement à proximité de ces hôpitaux-là. Quand tu as déjà tout le stress de la chirurgie de ton enfant, si on peut enlever un peu de stress financier, pourquoi pas? Fait qu'Encore offre tout ça à proximité. Et ça a été déjà commencé dès les débuts de la Fondation. Une autre chose qu'Encore a permis de développer de façon importante, c'est les cliniques mobiles de cardiologie pédiatrique. Les gens de Québec, les gens de Montréal, les cardiologues ont toujours été faire des cliniques ailleurs, en périphérie. Et avec les années, puis surtout au début, le support de la Fondation Encore, cette activité-là clinique s'est développée de façon exponentielle. Et Encore a été là dans le début pour nous soutenir pour les achats d'équipements, pour la camionnette qui permettait de transporter les équipements. C'est pour l'année 2015, juste les activités qu'on fait à Sainte-Justine, on fait économiser 600 000 $ par année aux familles d'enfants cardiaques à cause des cliniques itinérantes de cardiologie. Et c'est vraiment une fierté dans le cœur d'avoir permis le déploiement de ça puis d'arriver avec des activités super importantes pour tous ces enfants-là et ces familles-là.
Technology is increasingly present in our lives, shortening distances, bringing faster solutions, and with more practical ways of living day by day. We believe that for all of this to make sense, every solution needs a reason to exist. So, why not focus on using this technology to solve real problems in our society? At a time when neonatology had an important reduction in mortality, and today it has the challenge of preserving the quality of life of patients and their families, in a scenario where the number of children with disabling diseases is very large, representing a hard socioeconomic burden in Brazil and in the world. In a country of continental proportions, where the heterogeneity of resources, protocols, and conducts represents a harsh reality. PBSF, Protecting Brains and Saving Futures, was born with the motto of bringing accessible technology and intelligence to prevent neurological sequelae, as with the objective of promoting initial and longitudinal education and training, and also facilitating the implementation of methodologies and tools for early diagnosis and neuroprotection on a large scale. And for this, we created the CSI, a central of surveillance and intelligence where we use an advanced telemedicine system to break borders and shorten distances. In this scenario, we've already monitored more than 4,000 children in more than 270,000 hours of monitoring, distributed in more than 30 hospitals, located in all 5 regions of the country. In addition, we're extremely pleased to work with international partnerships with a focus on education, research, and technological development. But we want to go further, generating homogeneity of protocols and conducts between distant centers and with different resources. With intelligent monitoring, longitudinal education, and capacity building, we can better serve high-risk babies. Together, we can make a difference in the lives of each of these little patients. We believe in the fundamental importance of each of these children being able to read, learn, and believe in tomorrow. Only in this way can we build a country and a better future. PBSF. Learn more at pbsf.com.br.
Il y en a partout des enfants avec des malformations cardiaques. Si vous questionnez, si vous cherchez, vous entendez toujours parler d'histoires. Dans le temps, on disait, nos grands-mères accouchaient puis ils perdaient un bébé. On disait, oh, c'était un bébé bleu. Mais ces bébés bleus-là, c'était des bébés avec des malformations cardiaques. Bonjour, je suis Anne Fournier, je suis une cardiologue pédiatre qui travaille avec les enfants malades du cœur depuis plusieurs années maintenant. J'ai l'impression que c'est hier. Je les aime beaucoup, ces enfants-là, puis je me sens privilégiée de faire le travail que je fais. Alors, j'étais jeune étudiante à l'hôpital Sainte-Justine, j'étais encore en formation et mon patron de l'époque, le docteur André Davignon, m'a dit, il faudrait bien qu'il y ait une fondation pour les enfants malades du cœur. J'ai dit, faites-le, puis j'embarque. Et ça a commencé comme ça. On a trouvé des mamans d'enfants cardiaques qui étaient motivées, qui se sont impliquées. Et on a mis sur pied la Fondation En Cœur, la Fondation québécoise pour les enfants malades du cœur, en 1984. Alors, qu'est-ce que ça fait En Cœur? Plein de choses. Alors, c'est là pour soutenir les parents puis les familles. Alors, soutenir par de l'information. Soutenir par les mettre en contact avec d'autres gens qui ont vécu les mêmes choses. Fait que ce support-là, ça aide les parents à passer à travers, puis ça aide l'enfant à passer à travers. Il y a des recherches qui montrent que si les mamans sont moins anxieuses, moins inquiètes, l'enfant va avoir un meilleur devenir avec les années. Mon cœur aussi offre des services d'hébergement. Alors, les hôpitaux qui offrent des services de chirurgie cardiaque pour les enfants dans la province de Québec, c'est ici à Québec, au CHUL, c'est l'hôpital Sainte-Justine à Montréal, puis l'hôpital de Montréal pour enfants. Mais les enfants, ils vivent partout dans la province de Québec, là. Et encore offre le logement à proximité de ces hôpitaux-là. Quand tu as déjà tout le stress de la chirurgie de ton enfant, si on peut enlever un peu de stress financier, pourquoi pas? Fait qu'Encore offre tout ça à proximité. Et ça a été déjà commencé dès les débuts de la Fondation. Une autre chose qu'Encore a permis de développer de façon importante, c'est les cliniques mobiles de cardiologie pédiatrique. Les gens de Québec, les gens de Montréal, les cardiologues ont toujours été faire des cliniques ailleurs, en périphérie. Et avec les années, puis surtout au début, le support de la Fondation Encore, cette activité-là clinique s'est développée de façon exponentielle. Et Encore a été là dans le début pour nous soutenir pour les achats d'équipements, pour la camionnette qui permettait de transporter les équipements. C'est pour l'année 2015, juste les activités qu'on fait à Sainte-Justine. On fait économiser 600 000 $ par année aux familles d'enfants cardiaques à cause des cliniques itinérantes de cardiologie. Et c'est vraiment une fierté d'Encore d'avoir permis le déploiement de ça puis d'arriver avec des activités super importantes pour tous ces enfants-là et ces familles-là.
Technology is increasingly present in our lives, shortening distances, bringing faster solutions, and with more practical ways of living day by day. We believe that for all of this to make sense, every solution needs a reason to exist. So, why not focus on using this technology to solve real problems in our society? At a time when neonatology had an important reduction in mortality, and today it has the challenge of preserving the quality of life of patients and their families, in a scenario where the number of children with disabling diseases is very large, representing a hard socioeconomic burden in Brazil and in the world. In a country of continental proportions where the heterogeneity of resources, protocols, and conducts represents a harsh reality. PBSF, Protecting Brains and Saving Futures, was born with the motto of bringing accessible technology and intelligence to prevent neurological sequelae, as with the objective of promoting initial and longitudinal education and training, and also facilitating the implementation of methodologies and tools for early diagnosis and neuroprotection on a large scale. And for this, we created the CSI, a central of surveillance and intelligence where we use an advanced telemedicine system to break borders and shorten distances. In this scenario, we've already monitored more than 4,000 children in more than 270,000 hours of monitoring, distributed in more than 30 hospitals located in all 5 regions of the country. In addition, we're extremely pleased to work with international partnerships with a focus on education, research, and technological development. But we want to go further, generating homogeneity of protocols and conducts between distant centers and with different resources. With intelligent monitoring, longitudinal education, and capacity building, we can better serve high-risk babies. Together, we can make a difference in the lives of each of these little patients. We believe in the fundamental importance of each of these children being able to read, learn, and believe in tomorrow. Only in this way can we build a country and a better future. PBSF. Learn more at pbsf.com.br.
Good afternoon, everybody. I would like to, again, thanks PBSF for organizing the platform for this virtual meeting, as well as all the sponsors. We have an amazing morning, 7 great talks, and lots of questions in the chat. And I'm sure we're going to have an amazing afternoon too. It's my big pleasure to introduce the keynote speaker of this afternoon, Dr. Bennett from Stanford. Dr. Bennett, it's super well known. He's the Philip Sunshine Endowed Chair for Clinical Programs and was the chief of the neonatal division at Stanford for 10 years. He's a member of the American Board of Pediatrics, the sub-board of neonatal perinatal medicine. He's a member of the AAP Committee on Drugs, and also he served as the section on neonatal perinatal medicine liaison member of the AAP Committee on Fetals and Newborn. Dr. Bennett has contributed with numerous policy statements and practice guidelines. He's an evidence-based person. He analyzed decisions, practice evaluation, including analysis related to early diagnosis, management, and prevention of neonatal infection, but also evaluation of the evidence for treatment for closure of PGA. And that's the talk he's going to have today for us, the patent ductus arteriosus conundrum. Welcome, Dr. Bennett.
Good afternoon. I'd like to begin by thanking the organizers of this conference to invite me to speak on a subject which has been on my mind a great deal over the last 10 or 12 years. As most of you are aware, my thoughts on the matter have sometimes been viewed as heretical and have disrupted the state of thinking regarding how to manage patent ductus arteriosus. I hope that you will not burn me at the stake for continuing in my heresy. I'm particularly honored to be given the opportunity to present the keynote address at this meeting, given that my opinions may be at odds with those of so many who may be listening. Here are some learning objectives for the talk which is to follow. I will not dwell on them further. I need to disclose that I served as a scientific advisory committee member for Abbott Laboratories, the manufacturer of the Piccolo PDA occluder, which met once in 2018 and for which I received compensation. I'm a member of several advisory committees to ongoing studies for which I have not received compensation, and I have no other financial conflicts of interest to disclose. I do, however, need to disclose that for many years, I was an enthusiastic practitioner of early, universal, and aggressive treatment of patent ductus arteriosus in preterm infants. It was the logical thing to do. If the PDA was present at 3 days of age, treatment with indomethacin was given to close it. If that failed, another round of indomethacin was used. And if that failed, the PDA was ligated, typically at around 1 week of age. About 10 years ago, I was asked to give a talk on PDA management, and I discovered to my dismay and chagrin that the evidence to support such treatment of PDA was non-existent, leading to the publication of a paper in 2010, which I will show you some follow-up data on in a few minutes. That realization has led to a PDA conundrum, which has grown over the years. And just to remind everyone, the definition of conundrum is a confusing and difficult problem or question, something that makes us scratch our heads and wonder what the solution to the riddle might be. I'd like to spend a few minutes at the beginning of this talking about the problems that are encountered with observational and post hoc studies. And in order to do this, I'd like to use the example of a hypothetical scenario. In this hypothetical, let's assume that you have a population of preterm infants that consists of two subgroups, which we'll call group 1 and group 2. Group 1 constitutes 90% of the population, and group 2 only 10%. You're interested in two conditions, condition A and condition B, which are not causally related. Neither one causes the other. In group 1, the prevalence of condition A is 100% at birth, but it declines with a half-life of 2 days. The prevalence of condition B is 10%, doesn't change with age, and is independent of condition A. In group 2, the prevalence of both conditions is 100% and doesn't change with age. those babies have both condition A and condition B from the beginning and all the way to the end of the study period. And finally, assume that you cannot distinguish babies with group 1 or group 2 until after 30 days of age. On those assumptions, we can see what the number of subjects in a population of 1,000 babies would be that would have condition A shown in the orange, both condition A and B shown in red, or only condition B shown in the yellow. And we see how that changes as a function of postnatal age in days. The rate of condition A drops steeply over the first 5 to 10 days. The rate of condition B alone correspondingly increases as babies with both conditions transition to having only condition B. And the proportion with both A and B settles out at around 10%. If we look at the status of these babies on day 3, we see that there's a strong relationship between the presence of condition A and condition B. If condition A is present, as it is in 418 of this hypothetical population of 1,000, 132 or 32% of that subgroup have condition B. If condition A is absent, only 58 out of 582 subjects, or 10% of that population, has condition B. Thus, the odds ratio for condition B in the presence of condition A is 4.17, with a confidence interval which nicely excludes 1, and the p-value is very, very small. That p-value is highly dependent on the overall sample size, but would remain highly significant if we cut the presumed size of the population from 1,000 to only 100 subjects. If we look at the risk of condition B in subjects who have condition A on any particular day from that hypothetical population, we see, as shown in the black dots, that the proportion of infants who have condition B increases from about 20% of the population, 19% actually, to nearly 100% over the first 20 postnatal days. If we do a logistic regression using those data points as our regression elements, the logistic regression model would show that there's an odds ratio of 1.38 with a confidence interval that is very, very small, a highly significant p-value. And we would conclude from this that the odds of condition B increase by 38% with each additional day of exposure to condition A. I remind you that condition A and condition B are in no way causally related in this hypothetical. With this circumstance in hand, we can also say that resolution of condition A in group 1 creates the illusion that earlier treatment, if we simply change the lower axis here from age in days to age at treatment, and whether that treatment has any effect on condition A or not, it's associated with a reduction in the risk of condition B if it's given early. As time passes, the efficacy decreases as shown in this graph. And again, it really doesn't depend on whether it's the treatment is effective in eliminating group A or not. But if we assume that it is effective in group 1 and not at all effective in group 2, we would see the relationship shown on this graph, declining efficacy with postnatal age. Even if that treatment is completely ineffective for condition A, however, spontaneous resolution in group 1 creates the apparent appearance of efficacy, and this decreases with age. If we look at a lag time of 3 days after treatment, the treatment is less effective than it is if we look at a lag time of 7 days after treatment. So the more time that elapses from presumed treatment to the time of evaluation, the more effective the treatment appears to be, but the later the age at which treatment is given, the less effective it appears to be. If we, in that setting, decide that we're going to give treatment on day 2 to all babies who have condition A present, we can assume that that treatment is completely effective in eliminating condition A. We see a distribution of status as a function of age as shown here, with the color coding being the same as shown in that earlier slide. Condition A completely disappears. There are no babies with both A and B, and only a residuum of babies in this population of 190 who have condition B, and that persists over time. If we compare the circumstance where we had no treatment and we looked at the number of babies who had condition B on day 20, there would be 190 out of 1,000. Or, and as shown on the graph, if we treated and had complete efficacy, there would be 190 out of 1,000 who had condition B, which of course are identical rates of 19%. The odds ratio is 1.0 and the p-value is 1.0. So if we have a circumstance where there's spontaneous resolution of condition A in a large proportion of the population and a strong correlation of condition A with condition B in the remainder of the population, this leads to a powerful correlation of group B, of condition B with persistence of condition A. The appearance that prolonged exposure to condition A leads to a greater risk of condition B, when in fact there's no causal relationship. Apparent loss of treatment efficacy with advancing age, whether the treatment is actually effective or not, for changing the rate of condition A. The illusion that earlier treatment of condition A reduces the risk of condition B, and the observation that elimination of condition A fails to reduce condition B. I think everyone in this audience can recognize that this model would apply perfectly if we called condition A patent ductus arteriosus and condition B bronchopulmonary dysplasia, ethybronchopulmonary dysplasia, neurodevelopmental outcome, or any of the other outcomes that have been systematically evaluated here. So what's the cure for this problem? Simply, it's randomized controlled trials. If we applied a randomized controlled trial construct to that hypothetical, we would see on the left-hand side of this slide that of the 550 babies in each cohort of 1,000 randomized to either treatment on day 3 or day 14, of those that were randomized to treatment on day 3, based on the presence of condition A still being there at day 2, we would see that 418 of those babies still had condition A on day 3, whereas only 107 would still have condition A by day 14. So more infants qualify for treatment if the treatment is given earlier. In the middle panel, we can examine the rate of condition B on day 20 as a function of the treatment day. And we can see that of the 418 babies who were treated on day 3, 132 or 32% had condition B on day 20. Whereas of the 107 who were treated on day 14, 101 still have condition B present on day 14, or a rate of 94%. So we would conclude that condition B is more common in late treated infants. This might be inverted to make the argument that earlier treatment reduces the rate of condition B, and therefore we should be treating babies on day 3 rather than waiting until day 14. If, however, we look at the entire population of 550 babies from each of these two cohorts of 1,000 who were eligible for treatment based on the fact that they had PDA or condition A present on day 2, we would see that 145 of those selected for treatment on day 3 still had condition B, and on day 14, 145 would have condition B. No difference at all. Prevalence of 26% in both groups. The outcomes are identical in the randomized cohorts, whereas they were quite different in the subsets of those cohorts who actually received treatment based on the persistent presence of condition A. Well, what do randomized controlled trials tell us? So this is an update of the meta-analysis that I originally published back in 2010, and this includes data up through the PAS meeting that took place in late April in Denver. After that meeting, I added 2 additional trials that brought the total number of randomized control trial reports to 67, including 8,057 randomized subjects. And as reported previously, we can see at the upper left that treatment to close the ductus is quite effective at achieving that objective, but that none of the other outcomes shown here, with the exception of intraventricular hemorrhage, about which I will have more to say in a few minutes, were statistically different than no effect whatsoever. It's particularly important to note that for death or BPD, oxygen at 36 weeks, necrotizing enterocolitis, sepsis, PVL, ROP, severe developmental delay, cerebral palsy, neurosensory impairment, or death or neurosensory impairment, the confidence intervals are quite narrow, and we can be quite confident that despite the clear efficacy of treatments for achieving ductal closure, that none of those outcomes were significantly impacted. Well, one of the excuses for why these results are negative with respect to identifying beneficial effects on outcomes of real importance is that the randomized controlled trials have not shown a clear benefit of symptomatic PDA treatment, partially due to high rates of open label backup treatment in the experimental and control arms. Well, my partner, Mira Sankar, and I examined this question a couple of years ago, and this was published in the Journal of Perinatology. We looked at what would happen to the data that I just showed you, shown on the left-hand panel here, where all of the trials available at that point in time, where we were looking about 6,000 enrolled subjects are considered. In the middle panel, we looked at how the meta-analysis would change if we excluded the trials that had open treatment of more than 50%. And in the right-hand trial, what would happen if we excluded trials of more than, where open treatment occurred in more than 33% of the infants in the control groups. We could do a similar analysis excluding all trials where treatment occurred in more than 20% of the control groups, and we would see the same phenomenon. What we observe here is that treatment for achievement of ductal patency is certainly preserved, but there's no shift in the point estimates of the important outcomes shown in the remaining bars going all the way down the rest of the graphs shown here. Because the sample sizes are smaller, because we've excluded a substantial number of studies, the confidence intervals are a little bit wider, but they remain relatively narrow. And this is a strong argument that the exclusion of or the open treatment of babies in the control groups is not the explanation for the failure to identify beneficial effects. Another argument which has floated to the surface lately and has been remarkably widely cited is the observation that there's a lack of physician equipoise, which was demonstrated in particular in the PDA Tolerate trial with respect to the ability to enroll subjects in randomized controlled trials so that we can gain the knowledge that we need. In this post hoc analysis, Leibowitz and colleagues analyzed the outcomes of the babies who were eligible for but not enrolled in the PDA Tolerate trial and compared those outcomes to the infants who were enrolled and randomized. And they noted that despite being less mature and needing more respiratory support, infants with a lack of physician equipoise had lower rates of mortality than enrolled infants, and that infants with lack of equipoise who were treated before day 6 had lower rates of late respiratory morbidity than infants who were treated after day 6. Let's take a little closer look at this data. This is an example of the phenomenon that I described to you in the hypothetical at the outset, in which there's no causal relationship between the presence of condition A and the probability of developing condition B. Remember that because of the spontaneous disappearance of condition A, there's an illusion that earlier treatment, whether it has any effect or not on condition A, actually reduces the risk of condition B. And this is the primary fallacy in the analysis of the lack of equipoise data from the PDA Tolerate trial. This is an artifact, not a real phenomenon. If we look at the non-enrolled versus the enrolled groups and put all 4 groups, those not enrolled and treated before day 5, those not enrolled and treated at day 6 or later, and those who were enrolled and randomized to early routine treatment or conservative treatment groups, we can see that the age of treatment in the first group here was a mean of 3.3 days. In the second group, those treated at greater than 6 days, of course, were treated later at 8.8 days on the average, whereas those in the early routine treatment were also treated at about 8 days of age, and those in the conservative therapy group were treated at about 20 days of age, but only 48% of that latter group received treatment. The mortality rates were significantly different across all of these 4 groups, but they did not significantly differ between the early and late treatment, the 1% or 6% in the non-enrolled groups. And the remarkable finding here is that 19% of the early routine treatment subjects died, whereas only 10% of those randomized to control therapy. This difference is statistically significant. The mortality was higher with early routine treatment. So the argument that the failure of equipoise should somehow controvert the clear statistical observation of a higher mortality rate associated with early routine treatment really is one that should be viewed with skepticism. Now, Dr. Kleiman points out that this excess mortality in this group is due largely to the occurrence of bacterial sepsis due to gram-negative bacteremia in the early routine treatment group. There were an extra 9 cases of that compared to the conservative treatment group. And it's not clear what the reason for that might be. It's a little bit hard to come up with a plausible explanation for what the mechanism of that difference might be. And it is certainly possible that this is a statistical fluke and not real. But if there is an effect within these 4 groups, it is on the mortality in the early routine treatment group, which appears to be excessive. Well, another excuse is that failure of treatment to close the ductus obscures benefit. In other words, if you give a treatment that doesn't achieve the initial effect, the closure of the PDA, then that failure of the treatment to work for step 1 will result in failure of the treatment to work for step 2. This argument has been made repeatedly, and I cite here one recent paper that comments on the results of an RCT, that there was a low overall rate of PDA closure in the intervention arm and a high rate of PDA persistence in the placebo arm. So there was a difference, but the PDA persisted despite treatment in the treatment arm of the trial. And the lack of the relationship between treatment and improvement in outcomes may stem from the fact that treatment is not uniformly effective. Let's take a look at the relationship between the efficacy of treatment to close the PDA, which, as you can see from the scatter of the data on these slides from left to right in all three panels, that the odds ratios for persistence of the PDA do scatter significantly from about 0.04 or 0.05 to about 0.2 across the range for odds ratio for persistent PDA. But if we plot those values against the odds ratios for death in the left-hand panel, for the use of oxygen at 36 weeks in the middle panel, or for either as a combined outcome in the right-hand panel, and then regress the odds ratios against one another with the linear regression, we can see that the slope of the regression line is essentially zero, and that regression line sits right on the line of identity for the odds ratios for these three different outcomes, and implying that the effect of treatment on the outcomes of interest is completely independent of the efficacy of treatment for closure of the PDA. If PDA closure did mediate the avoidance of these outcomes, there should be significant correlations between the odds ratios for PDA persistence and those for the outcomes of interest. And the slope of these regression lines should be significantly different from zero. Increased closure with treatment or decreased closure in controls, therefore, is unlikely to alter the outcomes, because as we move from right to left, which would be the direction of moving the data along the axis for odds ratio for persistent PDA, the regression curve shows that the odds ratios for the outcomes do not change significantly. The slope is zero. They're unrelated. Well, here's a post hoc analysis that attempts to delve into this in a little bit more detail. I quoted a justifying statement for doing this analysis a moment ago. In this post hoc analysis of a randomized controlled trial, the treatment group was subdivided further into those who were assigned to the treatment arm of the randomized trial, shown in the gray column here, into the subgroups who had successful closure of the PDA and those whose PDA failed to close after treatment. Numbers in this trial, which was a pilot study, are relatively small, but we can see that, of course, successful treatment was associated with PDA closure by 8 days and 100%, where failure was associated with none. Treatment overall was associated with closure in 57%, but placebo, the control group, in only 17%. If we look at the outcomes towards the bottom here, we can see that the difference in mortality of 13% in the placebo group and 27% in the treatment group was not significant. And similarly, neither BPD nor the combined outcome of BPD or death differed between the two trials. Now, because of the small sample size, it's possible that this pilot study was just underpowered to see the differences. But if that's the case, the differences appear favorable in that the mortality point estimate is actually higher in the treatment group. If we compare success and failure, we also see that the mortality rate is not different, but the mortality point estimate is higher in the failure group, again, with a very small sample size. BPD, or the combined outcome of BPD or death, were more common in the subgroup of infants who failed to close the ductus. Now, this only tells us something that we've already known for a long time. Persistent patency of the ductus arteriosus is associated with a whole variety of bad outcomes. The question is not whether that's the case, but whether treatment is of value. So persistent PDA was associated with increased risk for BPD, but treatment did not significantly reduce that risk in the randomized comparison. Here's some data from Korea, which should raise some very troubling concerns about the utility of treatments to close the ductus in the very smallest group of babies that come under our care. In this study, the Kaplan-Meier curve for the incidence of persistence of the PDA in the non-intervention versus an ibuprofen treated group for infants less than 23 to 26 weeks of age were identical. Ibuprofen was simply ineffective in achieving ductal closure in this population of the smallest babies. It was somewhat more effective in achieving earlier closure in infants at 27 to 30 weeks of age, but that difference disappeared by about 40 days of postnatal age. In these populations, there was no difference in the odds ratios for death or BPD or death associated with treatment. So from this, we should conclude that treatments that do not reliably achieve PDA closure cannot, of course, prevent sequelae of prolonged ductal patency. They don't work for step 1. They're not going to achieve the results for step 2. And because of that, we should stop using them. Failure of treatment to achieve ductal closure could also be looked at in this hypothetical cohort that I outlined for you earlier. If we assessed 1,000 babies, a cohort of 1,000 babies who, for identification of those who had condition A on day 2, we would find that 550 total babies still had condition A present at 2 days of age. If we then looked at, in that 550 babies, a comparison of those who still had condition A present on day 7 or absence on day 7, we would see that 180 babies still had that at day 7, but 370, it had spontaneously disappeared. In the babies where condition A was still present, condition B would be diagnosed by day 20 in 108, whereas in only 82 of the 370 where it had disappeared. That is, the prevalence of condition B would be 60% in those where condition A still persisted, but only 22% where condition A had gone away. The odds ratio for this and the p-values are highly significant, but remember, in this hypothetical, there is no relationship. But this is an example of how resolution of condition A creates the illusion that that process reduces the risk of condition B, which actually is completely independent of condition A. So I think it's very important for us to rely not on observational data, but randomized controlled trial data to draw conclusions about how we should approach this. So these hypothetical data do confirm that there's an association between, but they have no implications regarding any causal relationship or effects of treatment of condition A. The question is not whether PDA closure is associated with better outcomes. It is. But whether treatment to achieve PDA closure is associated with better outcomes. And so far, it is not. Simply has not been demonstrated, despite 67 trials, 8,000 enrolled babies. The slopes of the regression lines, which I showed you earlier, of the odds ratio for PDA closure versus odds ratios for outcome, suggest a low probability that treatments that achieve higher rates of PDA closure will demonstrate better efficacy for other important outcomes other than PDA closure. And finally, as shown from the hypothetical example that I just discussed, post hoc comparison of subjects with intervention success to those with intervention failure is statistically invalid and not informative. And we can only hope that journal editors and reviewers will be more conscientious in avoiding publication of such specious trials or analyses. Let's turn attention for just a moment to indomethacin prophylaxis for intraventricular hemorrhage. In the recently released consensus statement from the Canadian Pediatric Society, the question was raised, should prophylactic COX-1 inhibitors indomethacin, ibuprofen, or acetaminophen be used for PDA closure. And the conclusion at the end of that paragraph was that selective prophylaxis with intravenous indomethacin may be considered in extremely low birth weight infants at high risk for severe IVH. And I would like to dissociate the latter conclusion from the question about whether these agents should be used for PDA closure. Let me show you some data that relates to that. Again, if we look at the relationship between the odds ratio for persistent PDA on the horizontal axis and the odds ratios for either any IVH or for IVH greater than grade 2, and plot the studies, again, with the size of the bubbles being proportionate to the number of subjects included in the trial, we see that the slope for these regression curves is essentially 0. It's very flat. And on the left, the regression line essentially overlies the odds ratio of 1 or the axis of no effect whatsoever. On the right-hand side, that regression line is displaced downward, reflecting the observation that overall, the randomized controlled trials support a reduction in the risk of IVH greater than grade 2 with the use of prophylactic indomethacin. The effect is not at all related, the effect on IVH or grade 2 or greater IVH is not at all related to the success in closing the ductus, so that we can conclude from this that IVH prevention is not mediated by closure of the PDA. This lack of a relationship was noted by Laura Ment in her paper in 1985 and again in 1988. The Schmidt papers related to the TIP trial did not examine this issue at all, but I would just remind the audience that the objective of indomethacin prophylaxis is prevention of IVH, not PDA closure. Let's look for a moment at the relationship between the duration of PDA exposure and the risk for bronchopulmonary dysplasia. Many reviews make statements that are very similar to the one that I quote here, which is that long-term exposure of the lungs to overcirculation may predispose the infant to chronic lung changes and bronchopulmonary dysplasia. Certainly, we know that these things are correlated, but we don't know that there's a causal correlation. In fact, if we look at the studies that examine the relationship between duration of PDA exposure and the risk of bronchopulmonary dysplasia, we find something that is quite different. In the left-hand panel here, the data from Italy, from a paper by Dr. Shana, which shows that the risk of death or BPD is significantly greater if the PDA is present for more than 7 days as compared to the left-hand column where the PDA was present for less than 7 days. However, the risk of death or BPD did not change significantly whether that exposure for greater than 7 days was the severity level E2, E3, or E4. So we can conclude from this that the death or BPD is associated with PDA present more than 7 days, but not with the severity of the ductal shunting. And because of the statistical design of this paper, we can't assess whether persistence of the PDA for periods of longer than 10, 14, or 21 days, for example, further increased the risk shown here. We only know that less than 7 days versus more than 7 days is statistically significant. And the right-hand panel is data from MIRSA, which addresses the latter question in a little bit more detail, again, looking at the risk of death or BPD as a function of duration of exposure. And we can see that if the PDA is present, as shown in the 3 right-hand bars, there's an increased risk of death or BPD, but the more prolonged presence is shown in the 2 right-hand bars does not further increase the risk of death or BPD with increasing duration of exposure. The 3 bars on the right-hand side of this panel are statistically indistinguishable. Similar data comes from 2 recent papers by Dr. Kleiman. On the left-hand side is data showing death or BPD as a function of duration of exposure at UCSF, showing that combined outcome is increased with more than 7 days of exposure, but beyond that point in time, there is no further incremental risk in that outcome with more prolonged exposure. That data is broken down in an analysis from the PDA Tolerate trial, which shows in the orange bars on the right that exposure to PDA for longer than 11 days is associated with significantly increased risk of grade 2 to 3 BPD if the infant was intubated for greater than 10 days, but not at all if the infant was intubated for less than 10 days. Here's similar data from Korea showing, I won't go through this in detail, but simply for multiple outcomes of interest, the adjusted odds ratios are essentially 1, not significant, no relationship with increasing duration of exposure. The conclusion that I would draw from that is that while the presence of dose-response relationship does not always support causality, its absence, when it's expected, would lead us to doubt causality. I'm quoting from authorities on the question of how we assess causal relationships. Finally, there are excuses given that few studies examine non-interventional strategies, but actually the control groups of the many trials that I have described to you do provide very substantial evidence that less intervention to close the PDA is safe. Here's a report from an observational comparison of non-interventional strategies showing in their conclusion that the change in approach to PDA to a more expectant approach was associated with an increase in BPD and in BPD or death. I would point out, however, that the increase in severe BPD was not statistically significant, and that the prevalence of death before 36 weeks postmenstrual age weighed in the direction of being less after the change to a more expectant approach. Here's some data from right there in Montreal from Dr. Altide's group, where they used a creative approach of a differences analysis to demonstrate that adoption of a conservative PDA management at site 2 was followed by an increase in death or BPD among infants less than 26 weeks gestation. However, when they went back and looked at the subsequent course at that same site, we can see on this graph that integration of that conservative PDA management strategy into their unit was subsequently followed by decreased death among infants less than 26 weeks and decreased BPD among those greater than 26 weeks. So there was an implementation lag in achieving the benefits, but in fact, from that same institution, adoption of a more conservative expectant approach to management was associated, in fact, with better outcomes. The 2 recent RCTs that were reported at PAS showed, in the case of the Benedictus trial, a reduction in the rate of BPD or the composite outcome in the expectant management group. And in the baby Oscar RCT, there was no evidence of a reduction in death or moderate to severe BPD by early selective treatment. So the hot off the press most recent data supports the use of a more expectant strategy. Following one of those presentations, there was a comment from the audience saying, well, we're randomizing the wrong babies. And my comment on that would be, well, then we're treating the wrong ones too. We know what doesn't work, and it's time to stop using and studying treatment strategies that have been amply demonstrated to be ineffective. So here's some areas of unexplored territory that do merit exploration and consideration of babies who fall into these categories for possible treatment, with the full understanding that there is simply no evidence to reliably guide whether we should or shouldn't treat them or what the criteria should be. Perhaps babies at the extremes of prematurity, those with extremely large ductal shunts, say QP to QS greater than 5 or perhaps greater than 7. Advanced postnatal age greater than 21 days. There's a paucity of data on how to manage babies later in their course. The studies that have been done really address the first 3 weeks after birth. Perhaps more effective treatment, but as I've shown earlier, that seems unlikely to be the answer. And finally, there may be unassessed outcomes, including those shown here. I would point out, though, that it's very important to evaluate the historical data that suggests that persistent ductal patency may lead to pulmonary hypertension. If we trace back the source of the information that suggests that the presence of an untreated large PDA will result in pulmonary vascular disease in at least 50%. We see that that comes from a back of the envelope calculation that was presented by Dr. Julian Hoffman at an NICHD workshop that estimated that the incidence of pulmonary vascular disease in untreated PDA might be 33%. In the same paper, there's a citation that suggests that as many as 60% of children who were exposed to persistent PDA may develop pulmonary hypertension. But if you look at the source paper for that, it explicitly excluded infants who were born preterm. So that paper cannot be informative in that regard. So here's the conundrum that I have about PDA. Why are we still pursuing treatments known to be ineffective for improving measured outcomes in preterm infants? I hope some of you in the audience will be able to help answer this question. I urge those of you who have the wherewithal to do so to explore those areas around the margins that I mentioned earlier to determine which babies might benefit, and then to focus our efforts on demonstrating which treatments actually are effective in preventing those babies from having specific adverse outcomes, which we can measure. Thank you for your attention, and we'll look forward to discussion when we have the panel discussion later this afternoon. Thank you very much.
Thank you, Dr. Bennett. It was an incredible, elegant talk showing the evidence. So to let Dr. Bennett go, I'm going to make a very small change in the schedule. I'm going to open for questions of the keynote speaker now, and then we'll have the other two presentations after that. Nice to see you, Dr. Bennett.
It's really wonderful to be here. I just wish I could be at McGill along with all of you and be there in person.
We wish so too. Hopefully, and in the close future, with the situation get better, you can come by.
Sounds lovely. I'm available.
Okay, Gabriel, you have a lot of questions, so I'll give to you the first.
I think we could have an entire conference, well, just on that subject, it seems, but you summarized really in your presentation all the key findings and the key messages. And I think there's a lot of people in the audience, obviously, that are still wondering similar questions about, yes, like the extremes of what you just mentioned. But I think for example, one of the struggles we still go through are, for example, some of these rare cases of pulmonary hemorrhage. And we know that pulmonary hemorrhage might just be, increased flow into the pulmonary vasculature just because it's, PVR drop, and this pulmonary vasculature is actually very friable and very vulnerable to increased surface tension and it might not be related to the PDA at all. But I want to hear one of your thoughts about this entity, and is there at least a role for accelerated ductal closure in these particular patients?
Well, I think the challenge with pulmonary hemorrhage is that it's an event that occurs pretty early in the course. If you look at the breakdown of the studies going back to the post hoc analysis of the TIP trial, the reduction in pulmonary hemorrhage was something that was early pulmonary hemorrhage. In fact, it was early severe pulmonary hemorrhage. And if you looked at all pulmonary hemorrhage or pulmonary hemorrhage over the entire hospital course, there was no effect. There are now about 6 or 8 randomized trials that include this as an outcome. And that's not on the graphs that I showed you, but that is an outcome for which there is a statistically significant effect of early prophylactic use of indocin or ibuprofen. So that actually might be something that could be prevented, but you would have to give it to a very large number of babies. The data from Klukau's group suggests that there may be echocardiographic findings that would allow selection of a group of babies that are particularly high risk. But it's not easy from reading those papers to figure out what those findings might be. But if we're going to do so, we need an early diagnostic study that identifies the high-risk group, and we need to get in there early with intervention, I think, in the first 12 hours. And I think that's a pretty daunting challenge. Fortunately, pulmonary hemorrhage is a relatively rare event. I think that the DETECT trial from Australia showed an anomalously high rate of pulmonary hemorrhage in their control group that isn't similar to what most of us experience in our nurseries. So that's a possible endpoint, and I would include that in the list of potential endpoints that haven't been adequately evaluated.
In the case of a baby that developed pulmonary hemorrhage, would that be an indication for treatment afterwards? If you cannot control the bleeding, let's say some cases, you give the inhaled epi, you increase the pressures, you adjust the ventilation, but the patient continues to bleed.
Yeah, I don't know of any evidence that really addresses that. You're operating in a situation where there is no evidence to guide our practice one way or the other, and we have to fall back on our standby of relying on our best understanding of the physiology and our best ability to assess that in a particular baby, and then try to do the right thing. But with full understanding that we're doing so without evidence to guide us. And, we're all in the same boat there. It's not that any of us are slackers or anything. We just simply don't know. So we do the best we can. I think it's a very logical and reasonable course to take if you have a baby who's got ongoing pulmonary hemorrhage and a big roaring ductus with a large left to right shunt. I would not object to treating that baby.
Yeah. So there's a question here from Dr. Frederic Dallaire, who spoke in the morning. Magnificent presentation. I have seen a few cases of neck right after the start of ibuprofen treatment. Have you seen data in line with this, like a potential adverse effect of PDA treatment?
The good news about the meta-analysis that I did is that the effects for necrotizing enterocolitis and SIP overall across the studies sit right on the line of identity. So there's no benefit, but also there seems to be no harm. But I think that there are data that show clearly that there are some potential adverse effects. That data is strongest for the relationship between spontaneous intestinal perforation and combined exposure to hydrocortisone and indomethacin. I don't know of data that suggests that there's a risk for NEC in association with ibuprofen, and I would worry a little bit about confounding by indication in those situations. And an analogy that I would use is the data that suggests that there's an association between packed red blood cell transfusion and NEC. I think that the link there is that the baby's starting to become unstable and people are looking for something that they can fix. They discover that the baby's anemic and they give a transfusion, and a few hours later it becomes apparent that really what was happening was that they were developing necrotizing enterocolitis and the transfusion was incidental. So I would worry about that possibility, underlying the observation that ibuprofen administration was followed by the development of necrotizing enterocolitis. I don't know of any data from RCTs that suggest that's a risk factor.
Dr. Bennett, I get a lot of questions about, okay, now we seem to, have a lot of cumulative data showing that, trying to accelerate ductal closure is not associated or does not lead to improvement in outcomes. And actually, maybe there is some data that it might increase exposure to harmful, medication or medications. And so many, centers are going towards a more conservative approach to this question. And some of them, it's like erring in the desert. Like, what do we do now? Like, what are the other interventions in the bundles of the care of these babies that we implement to, I guess, address also the fact that we use a conservative approach? Do we drop fluids? Do we start diuretics? Do we keep higher pressures on our vents or on our non-invasive support? What would be your approach and recommendation to these on the line who are wondering this?
Yeah, I'm not a big believer in draconian fluid restriction. If you look at the Korean data, their fluid intakes were on the order of 110 ml per kilo per day when they eliminated the use of treatments to close the ductus. And they found that their babies didn't grow as well. I don't know of any data that suggests that you have to restrict fluids that much. So I'm very comfortable with these babies with a good-sized ductus, continuing to give them 150 or 160 ml per kilo per day. And this is it's a general phenomenon. The key to getting out of the NICU is getting bigger. So make sure that they get plenty of calories. I think you have to prioritize that. I don't know that there's a real role for diuretics. I don't know of any data that suggests that that really makes things better. And the data for the effects of diuretics in management of BPD is that you get a beneficial effect for about 2 or 3 days and then it evaporates. So I'm not a big fan of that. If the baby is on positive pressure, either non-invasively or invasively, I think that there's pretty good evidence that increasing the CPAP or the PEEP has favorable effects on the QPQS distribution. If there's an effect on total cardiac output, that can be easily overcome by volume depletion. So I'm a fan of that. And I also extrapolate from the Lister observations in babies with VSDs that maintaining a higher hematocrit can help balance QPQS. So those are the 3 things that I rely on: good nutrition, adequate fluid intake, distending pressure if the baby's already getting it. And I'm comfortable using CPAP or PEEP up to 8 or 10. And then transfusion to a crit above 45. Now, the caveat there is there's no evidence to support that those are effective treatments. They all need to be studied.
There's a question from the audience here about the use of postnatal steroids and the effects on the PDA. So some animal studies showing it helps decrease the PDA size. If you can comment on that.
Yeah, I know about the animal studies, and of course there's data about prenatal steroids reducing the risk of PDA. But I don't know of any good analyses of the effect of postnatal steroids on PDA in actual human babies. I personally am a big fan of the early use of steroids in the tiniest babies. I think the really small preemies are generically cortisol deficient. I've adopted Christy Waterberg's attitudes towards that. I don't think they need a lot of hydrocortisone, but I think hydrocortisone supplementation in the first 10 days to 2 weeks really should be something we have a very low threshold for doing. And I think that may help the ductus close as well, but I don't know of clear evidence that that's the case.
We have a question from the audience. Where is there any clinical condition that are associated with presence of PDA that you would consider worthy of being treated if any of these conditions exist?
Well, the unexplored areas that I outlined include a very large group that draws a lot of our attention, or a relatively large group at least, and that's the baby that is 4, 5, 6 weeks old. Started out at 23, 24 weeks, is still on the ventilator. Is getting a lot of oxygen. The x-ray shows evolving BPD, and you're having no luck at all weaning. And there's a raging big duct with reversal of diastolic flow and heart chamber dilation. And, the cardiologist is saying this is the mother of all ductuses, and you really got to do something about it. How we manage that baby, there are no randomized trials that look at the management of babies beyond about 3 weeks of age. I think that the PDA Tolerate trial in that control arm, that the babies were being treated at a mean of about 20 days. Some of them were later, of course, with that being the mean, but we don't really know what to do with those babies when they're that far out. So I think the first place to start is to try to optimize the approach to ventilator management for the BPD component of those babies' illness. And I'm a big fan of the long inspiratory time approach that's been advocated by Leif Nellen and Steve Abman. As you know, Gabriel, I have some refinements and tricks that can be added to that we won't go into now. But I think first you optimize your ventilator management. And if you're not succeeding, then those are babies where, again, we're in unexplored territory. And, my partners would come to me and say, Bill, I'm really sorry, I've got to ligate this ductus. This was before the Piccolo was available. And I'd say, well, how old's the baby? And they say 5 weeks. I said, you got a 5-week-old baby stuck on the ventilator. It's got a big duct. By all means, give it a try. Ron Cohen just sent me an email yesterday saying, I've seen these babies where you close the ductus and they come screaming off the ventilator over the next 5-7 days. It doesn't seem like that was going to happen. I think that's an area that we really need to study. And I think that the pivotal trial is going to help us a lot with that because it really targets that population. But I think the other thing that we should think about is that maybe weaning from the ventilator is in itself a satisfactory endpoint. When I talk to my friends, I haven't had the experience personally, but I'm old enough now that I have peers who've had heart valve or coronary artery bypass surgery, things like that, and they've been in the ICU and intubated, and they say it's no fun. And I'm sure it's no fun for our patients either. So if we wanted to say coming off the ventilator faster is a satisfactory endpoint and a reason for doing a Piccolo intervention, fine. But let's measure it and figure it out. And I think there are ways that we can design randomized trials that will help us know.
So, Dr. Bennett, in the meta-analysis you presented, you put together all treatments versus no treatment. Could you say something about, the drugs itself, like in the medicine, ibuprofen and now acetaminophen separately, if the effects is the same or there's a difference?
I think the best data from that comes from another one of the post-hoc analyses from the PD8 Tolerate trial. And what Leibowitz and Kleiman found there was that indomethacin is the most effective. Ibuprofen is a close second, and acetaminophen is a distant third. I'm really unimpressed with the data about acetaminophen. Almost all of the comparative trials are acetaminophen versus ibuprofen. But if you look at that Korean trial, I showed the Kaplan-Meier curve for the smallest babies. There was no difference. So if you're saying that acetaminophen is as good as ibuprofen, which doesn't work at all, I'm not impressed. So I am still very skeptical of the data around acetaminophen. It's not. There are only like 2 trials that have compared it with placebos. They're small. The sizes of the difference are not very good. I'm not a big fan of acetaminophen. I think that needs to be better studied.
Great. So I have a comment from our unit director here. Very nice weather in Stanford, California. Like we can see behind you.
Yes. I'm coming to you from my wife's garden. So,
so we can be here for a long time, but we need to move on with the conference. So I really would like to, thank you for your time to give the presentation and to be here for the questions. And I think next step is you come and visit us in Montreal.
That would be lovely.
Thank you so much, Dr. Bennett.
You're quite welcome. A real privilege to be a part of this. Thank you.
Thank you. Have a good afternoon.
Thanks. Bye-bye.
Bye-bye. So we're going to move forward with our next speaker is Dr. Pierre-Luc Bernier. Dr. Bernier is our cardiac surgeon. He received his cardiac surgery training at McGill, followed by fellowship in congenital cardiac surgery at Columbia in New York, and then the Children's Hospital of Philadelphia. Dr. Bernier practices congenital cardiac surgery at the Montreal Children's Royal Vic, Saint-Justine, and the Montreal Heart Institute. Today, his presentation will be about cardiac surgery in the newborn period, the perspective of the surgeon. Unfortunately, Dr. Bernier won't be able to be in the question sessions, but the next speaker will be there. Thank you.
Bonjour, my name is Pierre-Luc Bernier. I'm a congenital heart surgeon at the Montreal Children's Hospital, as well as Saint-Justin Hospital and the Montreal Heart Institute. First, I would like to thank the organizing committee for the invitation to present. I have no conflict of interest to declare. I would like to acknowledge the contribution of my colleague, Dr. Nancy Poirier, for allowing me to use some of her slides previously prepared for a great presentation that she gave on the history of cardiac surgery. As Theodore Roosevelt said, the more you know about the past, the better prepared you are for the future. I would therefore like to take you on a little bit of a historical journey through the development of cardiac surgery, specifically as it pertains to neonatal care. Gross and Hubbard in 1938 at the Children's Hospital of Boston first published on their experience with the ligation of a patent ductus arteriosus. The surgery was performed on a 7-year-old girl. You can see from their description that the surgery was quite complex, but at the same time successful in alleviating the profound symptoms of pulmonary overcirculation that the patient was suffering from. Dr. Gross went on to continue his pioneering work in the development of cardiac surgery and made multiple important discoveries. In 1944, Crawford at the Karolinska Institute in Sweden published on their first experience with a repair of the coarctation of the aorta. Surgery was done on a 7-year-old child. He's also participated in the advancement of cardiac anesthesia with the use of volume control ventilation. You can see from their description of the operation that the technique was quite similar to what is done still nowadays for repair of a coarctation of the aorta by a resection and anti-anastomosis. The main differences was in the use of rather primitive instruments as well as very primitive sutures that made the operation more difficult. Dr. Taussig, who treated hundreds of infants and children qualified as blue babies, had observed that children with cyanotic heart defect and a patent ductus arteriosus lived longer than those without a PDA. It therefore seemed to her that a shunt, which mimicked the function of a PDA, might relieve the tetralogy's patient's poor oxygenation. In 1943, having broached the possibility of a surgical solution to Robert Gross of Boston without success, Taussig approached Blaylock and Thomas in their Johns Hopkins laboratory in 1943. In 1944, Dr. Blaylock and Taussig decided to proceed with the anastomosis by joining the subclavian artery to the pulmonary artery in a cyanotic child. In 1945, the first scientific paper describing the original 3 operations appeared in the Journal of the American Medical Association and had an immediate worldwide impact. Another operation that had a significant impact on the development of the early cardiac surgery was the Blaylock-Enlon atrial septectomy. You can here see on the picture how a clamp is placed at the base of the right atrium and at the base of the right pulmonary veins, allowing a right atriotomy without blood loss and a resection partially of the interatrial septum. This would then allow intracardiac mixing and allowed some patients to survive. In 1952, Muir and Damon introduced pulmonary artery bending to protect the pulmonary arterioles from developing pulmonary vascular obstructive lesions, consequence of increased intravascular pressure and shear stress. The more those indications were diagnosed, the more it became apparent that most congenital cardiac defects would need intracardiac repair. Clearly, surgeons needed to see how to carry out the repair inside the heart. Hacker in 1907, using normothermic superior and inferior vena cava occlusion, learned that dogs did not tolerate circulatory occlusion for more than 3 minutes. Beyond that time, dogs either died or exhibited central nervous system damage. Using this background information, surgeons started to experiment with ways to prolong the 3 minutes. The challenge during the late 40s and early 50s was how to gain access to the interior of the heart. Several ingenious half measures were proposed, including Gross's atrial well technique. Although useful in some patients, this and similar makeshift attempts proved too limiting and inadequate for the repair of most intracardiac defects. In 1952, Dr. John Lewis closed an atrial septal defect under direct visualization using inflow stasis and moderate total body hypothermia at 26 degrees Celsius. The patient was a 5-year-old girl who lived from the operation and became an adult. This was truly the beginning of open heart surgery. Various methods were used to allow access to the heart and the repair of intracardiac defects. You can see here Dr. John Lewis literally operating on a patient under hypothermia that was allowed by placing the patient in an ice bath. Cross circulation was used where the patient would be connected to his parent by connection of the femoral and venous arteries. So to allow the parent to act as a cardiopulmonary pump and to support the child while access was gained to the inside of the heart. There were then efforts to develop a pump which would be more stable, theoretically, in terms of its support. You can see here the Gibbon pump that was developed with the help of the IBM Corporation. These heroic efforts were very important, but not always met with positive outcomes. You can see here the early experience of various surgeons using heart-lung machines, which resulted in a mortality of 95%. In 1954, Lillihei performed the first surgical closure of a ventricular septal defect under controlled cross circulation. This technique was used in 45 patients between 1954 and 1955. As I mentioned, the use of a parent acting as a pump and as a respirator by connection of the femoral artery and femoral veins to the child's circulation allowed access within the heart and support while the intracardiac defect was closed. This technique was used to repair ventricular septal defects, tetralogy of Fallot's, and atrioventricular septal defect. You can see here this publication from the group of Dr. Lillihei, interestingly with the contribution from Dr. Paul Stanley, who then became the first congenital heart surgeon at St. Justine Hospital, describing their early experience. They compared the use of cross circulation with the use of a pump oxygenator, reporting mortalities between 26 and 29%. Techniques in the engineering of the heart-lung machines improved. With the advent of the bubble oxygenator, which was a simpler design, became widespread use of the heart-lung machine in North America and Europe. The bubble oxygenator was simpler in its design, as mentioned, was easy to use and led to less thrombotic complications. Mustard attempted his version of the arterial switch operation in 1954 on 3 infants at the Toronto Hospital for Sick Children. Mustard's attempt was performed on a 6-week-old infant and 2 19-day-old infants. There are 2 coronary arteries, the left and the right, and that are normally attached to the aorta. Mustard transferred the aorta and pulmonary artery, but chose to only transfer the left coronary artery. Mustard's attempts at the operation was unsuccessful, as all 3 children died in the operating room. The 6-week-old infant died from bleeding, where Mustard had connected the aorta. One of the 19-day-old infant died from ventricular fibrillation, and the other 19-day-old infant died from a blockage of the left coronary artery. This slowed down the progression of the operation because of the obvious poor outcomes. Dr. Mustard then devoted quite some time to the development of this revolutionizing operation called the atrial switch operation to treat detransposition of the great arteries. This was done with great results. Adib Jatine, a Brazilian surgeon of Lebanese origin, performed successfully for the first time the truly anatomical correction of transposition of the great arteries in the form of an arterial switch operation in 1975 at the University of Sao Paulo in Brazil. The first two patients were operated using profound hypothermia and total circulatory arrest. Coronary buttons were excised and the openings created were closed using a homologous dura mater. After completing the coronary artery transfer to the new site, the great vessels were transected, the ventricular septal defect was closed, and a Dacron patch was used to close the ventricular septal defect to a right ventricular oddment. The first patient, a 19-day-old female, was extubated 6 hours after surgery, but expired on the third postoperative day of renal failure. Necropsy showed, however, a good anatomical correction. The second patient, a 14-day-old male, was successfully discharged 3 weeks after surgery. Unfortunately, the next 5 patients expired within a few hours after surgery. Because of these results, there was a bit of loss of interest in the development of the arterial switch operation, and the atrial switch operation, the muscle procedure, was used widely throughout the world. In 1984, Castaneda and colleagues from the Children's Hospital of Boston introduced the concept of the neonatal arterial switch, describing their experience in 14 neonates. This emphasized the ability of the neonatal left ventricle to successfully handle the systemic circulation. Today, as you know, the arterial switch operation remains the treatment of choice for transposition of the great arteries with remarkably low mortality. Many other surgeons, such as Dr. Jan Quageber from the Leiden group and then from Columbia University in New York, have refined the knowledge about this pathology and allowed a global group of surgeons to safely perform the arterial switch operation in a reproducible way. You can here see his description of the variation in coronary anatomy that can be encountered in transposition of the great arteries. Obviously, a knowledge of the anatomy gives us an ability to plan the operation and to achieve optimal results. With the arterial switch operation for detransposition of the great arteries came 2 essential components in the development of neonatal cardiac surgery. The diagnosis that occurred with adequate frequency combined with a standardized, technically demanding operation that must be performed in the newborn period. This was truly the beginning of neonatal cardiac surgery. Neonatal surgery was then applied to apoplastic left heart syndrome, a more serious diagnosis with less certain long-term outcome. The Norwood operation was first presented in 1981. It quickly positioned itself as the procedure of choice for an otherwise lethal malformation. Multiple improvements, such as the sound modifications, have been proposed over the years to improve surgical outcomes following this operation. And improvements in surgical outcomes have been steady since. You can see that we've evolved quite significantly from the mortalities first reported in the mid-1950s, which were about 30% for rather simple operations, to nowadays mortality rates that are well below 5% for the globality of neonatal cardiac surgeries. Obviously, fetal diagnosis had a huge impact on the development of neonatal cardiac surgery. Fetal diagnosis is beneficial in counseling prospective parents in the immediate management of the newborn with congenital heart disease. In many countries, also fetal cardiac screening has had an effect on the prevalence and types of congenital heart disease seen at term because many of the affected pregnancies are terminated. Since this development of neonatal cardiac surgery, we've now been focusing on really perfecting the technique in order to reduce as much as possible the operative mortality, but also to reduce significant complications. During cardiopulmonary bypass, tissue trauma, contact with foreign surfaces, ischemia, reperfusion, reoxygenation injury, temperature changes, and release of endotoxins induce a complex inflammatory response. This response includes complement activation, cytokine release, leukocyte activation, expression of adhesion molecules, and platelet activation, leading to tissue injury and organ dysfunction. Leukocyte depletion, hemofiltration, minimizing prime volume, the use of asanguinous prime, and preoperative treatment with steroids have all been used to attenuate this inflammatory response. Cardioplegia is an integral and essential method of myocardial protection for patients of all ages requiring cardiac surgery in which the heart must be stopped. The immature newborn myocardium has a different response to ischemia than the adult myocardium due to structural, biochemical, and functional immaturity. Numerous cardioplegia solutions and delivery methods have been developed. Over the last decade, del nido cardioplegia, which is a unique 4 parts crystalloid to 1 part whole blood formulation that is usually used in a single dose fashion, has gained popularity, providing excellent myocardial protection for the immature neonatal myocardium. Surgical repair of complex congenital heart defects using deep hypothermia circulatory arrest, a practice commonly applied in the past, resulted in adverse neurological outcomes in some patients. Studies have demonstrated that this approach does not fully protect the brain and that there is significant decrease in intelligent quotients with increased arrest times. Cerebral pressure, flow autoregulation, and cerebral reperfusion are impaired after deep hypothermic circulatory arrest, and the abnormalities in cerebral metabolisms are directly proportional to the arrest time. Clinically, there is high risk of delayed motor development and neurological abnormalities if deep hypothermic circulatory arrest is used as the primary support strategy. For these reasons, continuous hypothermic low-flow bypass and selective cerebrointegrate perfusion are currently favored for the surgical management of complex congenital heart defects in the neonates. New perfusion techniques are also being developed. You can see here a publication describing star perfusion or sustained total all-region perfusion. This technique is used for surgery such as the Norwood operation, where perfusion to all organs, including the brain, the heart, and the lower body, is maintained during the surgical reconstruction. This technique, although interesting, has not been employed widely throughout the surgical world. Most, however, still currently perform surgery with constant perfusion of the brain in order to improve neurodevelopmental outcomes. We also know that the timing of the operation is important. You can here see a publication by a group of Dr. Emil Basha in New York City describing the outcomes after arterial switch operation based on timing and presentation. Their conclusion is that delay of neonatal arterial switch operation beyond 3 days is significantly associated with increased morbidity and healthcare costs. The group from Toronto and Philadelphia have also published on the neurodevelopmental outcomes following transposition of the great artery. Their conclusion: surgery beyond 2 weeks of age is associated with impaired brain growth and slower language development in infants with transposition of the great arteries cared for at our center. Although the mechanisms underlying dissociation are still unclear, extended periods of cyanosis and pulmonary overcirculation may adversely impact brain growth and subsequent neurodevelopment. This interesting publication describes how events at multiple stages in the early life of our patient may have an impact on their neural development. There are innate patient factors, but outside factors may happen before birth, at birth, after birth, between the first surgery, during the operation, and between stages between procedures. This paper focuses on patients with single ventricle who undergo the single ventricle palliation pathway, who will undergo a Norwood and then a Glenn and a Fontan operation. The primary focus of all congenital cardiac surgeons is to perform a safe, technically sound operation which will minimize the mortality and optimize surgical outcomes by minimizing complications. We're all very focused currently on improving the neurodevelopmental outcomes of our patient, knowing that this has a huge impact on their life in the long term. I firmly believe that this can only be achieved by working as a cohesive team, hand in hand, in order to provide the best care possible at every step of the way, from the fetal life to the neonatal period, intraoperatively and postoperatively, for the care of our patients. This can only be done through the use of a comprehensive pediatric cardiac program where everybody has a role, from surgery, neonatology, cardiology, pediatric ICU, anesthesia, perfusion, and nursing. Once again, thank you very much for the invitation. I'm not sure if I'll be able to be present at the Q&A session, but please do not hesitate to contact me if you have questions. My email is below.
Thank you very much, Perluc. That was a very interesting historical review on pediatric cardiac surgery. I love history. So our next presentation will be given by Dr. Nasiba Lahoussi. Dr. Nasiba Lahoussi is a pediatric cardiologist working at the Saint-Justine Hospital. She completed her training in pediatric cardiology at the University of Montreal, where she specialized in advanced heart failure and heart transplantation. Later at the Stollery Children's in Alberta and at Stanford during her fellowship. She also did a fellowship in cardiac function assessment by echocardiography at the Stollery Children's in Alberta. Now she's the program director of advanced heart failure and heart transplantation at the Saint-Justine Hospital, and today she will talk to us about neonatal cardiac failure and cardiomyopathy.
Ça me fait plaisir aujourd'hui de présenter sur l'insuffisance cardiaque néonatale et la cardiomyopathie. Je n'ai pas de conflit d'intérêt à déclarer. À la conclusion de la présentation, les participants devraient être capables de reconnaître les signes et symptômes de la défaillance cardiaque chez le nouveau-né. On devrait être également capable de nommer les principales causes de défaillance cardiaque et les types de cardiomyopathie. Et finalement, d'être capable d'initier un bilan d'investigation et comprendre le traitement de la défaillance cardiaque chez le jeune enfant. Les malformations cardiaques représentent encore la première cause de défaillance cardiaque, du moins dans les pays développés. Et l'incidence des cardiomyopathies primaires, qui, à elle, constitue la deuxième cause de défaillance cardiaque, est de 0,8 à 1,3 par 100 000 chez les moins de 18 ans. Toutefois, on estime que l'incidence est 10 fois supérieure chez les moins de 1 an. La défaillance cardiaque reste peu fréquente chez l'enfant et peut être difficile à reconnaître par les cliniciens de première ligne parce que justement, c'est pas rencontré fréquemment. Puis encore, malheureusement, jusqu'à 87% des nouveaux cas de défaillance sont diagnostiqués lors de décompensation sévère. La définition que j'ai retenue pour la défaillance cardiaque est celle qui est proposée par le CCS Heart Failure Guidelines. Je vous préviens, donc c'est une traduction libre. Mais essentiellement, c'est la capacité ou l'insuffisance du cœur à fournir un débit pulmonaire ou systémique suffisant, à un débit approprié ou à recevoir le retour veineux à une pression de remplissage appropriée qui va avoir comme conséquence des effets adverses sur le cœur, la circulation et le patient. C'est une belle définition parce qu'en gros, elle englobe vraiment les deux composantes de la dysfonction, donc soit la composante systolique et diastolique. Et en même temps, elle fait allusion vraiment au mécanisme de compensation qu'on retrouve en défaillance cardiaque qui peuvent éventuellement être délétères. Donc, les types de cardiomyopathie, il y en a plusieurs, mais j'ai décidé de nommer là, les 4 principales. Donc, il y a la cardiomyopathie dilatée qui est la plus fréquente, du moins chez l'enfant, qui constitue vraiment une dilatation du ventricule gauche avec une diminution de la fonction systolique qui va être évaluée à moins de 50%. Puis, on pourrait également avoir une composante de dysfonction diastolique, mais la composante systolique est en fait plus importante. La cardiomyopathie hypertrophique, elle, est l'hypertrophie du ventricule gauche ou l'épaississement des parois du ventricule. Il y a différents types. Donc, la forme concentrique, c'est celle qui touche vraiment les parois de manière égale ou diffuse. Puis, il y a des formes asymétriques, typiquement plutôt à prédominance septale ou encore apicale. Et c'est surtout de la dysfonction diastolique. Et de façon assez rare, ça peut évoluer vers également une dysfonction systolique. La cardiomyopathie restrictive, elle, c'est également un type de cardiopathie qui est surtout de dysfonction diastolique, avec un VG qui est d'aspect normal ou encore qui va être hypertrophié, donc avec de l'HVG. On va retrouver également une dilatation des oreillettes et on peut avoir une atteinte biventriculaire. C'est une cardiopathie qui a quand même un pronostic assez réservé. Donc, pour vous donner une idée, on estime que la mortalité est environ de 50% à 2 ans. D'où souvent, donc, dès que c'est diagnostiqué, on propose même une greffe pour ces patients. Puis ensuite, il y a aussi la non-compaction du ventricule gauche qui fait allusion vraiment à l'aspect des parois du ventricule gauche. Donc, la portion qu'on dit trabéculée ou non compactée va être beaucoup plus importante. Et quand on rapporte cette partie-là qui est comme non compactée sur la partie compactée, ça va être supérieur à 2 comme ratio à l'échographie ou à la résonance. Puis, c'est une atteinte qui peut évoluer vers une dysfonction systolique. Et typiquement, la présentation de défaillance cardiaque va se retrouver dans le tiers des cas. Dans les causes de cardiomyopathie dilatée, je dirais qu'il y a les causes primaires ou encore plutôt génétiques, puis il y a les causes secondaires. Donc, c'est ce type d'atteinte-là qu'on va retrouver, par exemple, après une ischémie. Puis chez l'enfant, ça va être typiquement des anomalies des coronaires, des anomalies d'implantation ou encore des infarctus sur des conditions thrombotiques, par exemple, chez la mère ou encore chez l'enfant lui-même. La myocardite infectieuse qui est quand même environ 35 à 48% des cas de cardiomyopathie dilatée, donc assez fréquente. Les tachyarrhythmies qu'on retrouve aussi beaucoup en période néonatale. Les causes toxiques qu'on voit un peu plus vieux, la thyrotoxicose, puis l'inflammation également. Dans les causes génétiques, donc tout ce qui est anomalie du sarcomère, c'est environ 35 à 40% des cardiomyopathies dilatées génétiques. Mais on peut retrouver aussi d'autres types de mutations ou d'anomalies génétiques qui vont toucher par exemple les protéines Z-bands, les protéines cytosquelettes, le nucléosquelette, les desmosomes, entre autres, les mutations du LMNA qui donnent des anomalies de conduction. On peut avoir des maladies mitochondriales, des maladies neuromusculaires, entre autres avec les gènes de la dystrophine et le sarcoglycan, puis des anomalies du métabolisme et des syndromes génétiques. Pour ce qui est des cardiomyopathies hypertrophiques, dans les mutations génétiques, encore, on a les atteintes sarcomériques. Puis chez l'enfant, surtout l'enfant de moins d'1 an, il y a aussi beaucoup d'erreurs innées du métabolisme qu'on va retrouver, notamment la maladie de pompe. Puis il y a les rassopathies comme le Noonan qui donnent chez les enfants qui sont atteints de cardiomyopathie hypertrophique des formes très sévères et rapidement progressives. Puis dans les causes secondaires, ça, on les voit aussi souvent, je dirais, c'est le diabète maternel lié à l'utilisation des stéroïdes et l'hypertension artérielle. Pour ce qui est de la période néonatale, en fait, ce qui est marqué, là, c'est sûr que c'est pas l'objectif de la présentation, mais un certain nombre de ces diagnostics-là peuvent être faits en période fétale. Donc, par exemple, quand on voit des cardiomyopathies dilatées en période fétale, je dirais, bon, il y a bien entendu les formes primaires ou génétiques, mais des fois, ça peut être aussi lié à des myocardites. On peut voir aussi les syndromes de Barth qui vont se présenter de façon précoce, qui est une anomalie liée à l'X, donc chez les garçons, et ça peut être associé aussi à des neutropénies. Puis on retrouve aussi des formes plutôt frustres, souvent en association avec des syndromes ou encore des malformations cardiaques, avec lesquelles on va retrouver de la non-compaction ou de la dysfonction. Selon une étude là, qui était parue en 2005, on estime que la survie d'une cardiomyopathie dilatée avec hydrops est d'environ 18 je dirais, surtout quand c'est pas une tachyarrhythmie. Et sans hydrops, on estime à 50 sinon, il y a d'autres types de particularités qu'on peut retrouver aussi chez le fœtus qui peuvent se présenter en cardiomyopathie, soit fétale ou néonatale. Donc, une fermeture prématurée du canal artériel qui va donc occasionner un obstacle de la voie de chasse droite. Donc, le ventricule droit va devenir hypertrophié et parfois atteindre une dysfonction VD importante. C'est des patients aussi qui vont faire de l'hypertension pulmonaire. Donc, typiquement, ça va être lié à l'exposition, par exemple, aux AINS là, pendant la grossesse. Si on voit que le canal devient restrictif, on arrête l'exposition, des fois, ça peut s'améliorer ou du moins pas se fermer complètement. Mais s'il y a une fermeture complète, il y a généralement indication de faire accoucher. Pour ce qui est des arythmies, donc un bon nombre des arythmies, en fait, peuvent être traitées par des antiarythmiques. On peut quand même avoir des fois certaines formes réfractaires ou précoces qui sont déjà associées avec la dysfonction ou les drops pour lesquels il faut prévoir comme une autre prise en charge. Ça peut être lié, par exemple, aux anémies aussi, au syndrome transfuseur-transfusé. Il y a des malformations artério-veineuses également qui vont contribuer à une défaillance là, par surcharge en volume. Puis, il y a les cardiomyopathies lupiques qui, comme vous savez, sont la présence d'anticorps chez certaines mamans, là, les anti-SSA et SSB, qui peuvent causer un bloc AV chez le nouveau-né. Et chez certains de ces nouveau-nés-là aussi, on peut avoir une atteinte plutôt inflammatoire, mais du myocarde, avec une atteinte type myocardite. Dans les formes, la présentation fétale, je dirais qu'il y a une morbidité de mortalité très élevée. Puis souvent, on va trouver une indication d'accoucher si le nombre si la gestation le permet, pour en fait limiter l'insulte, surtout quand on a des lésions à surcharge en volume qu'on peut adresser. Et encore aussi permettre un traitement parce que les traitements de défaillance, en fait, déjà, je dirais, chez l'enfant, plutôt limité, mais encore plus en période fétale. On peut avoir les stéroïdes qu'on peut offrir dans les cardiomyopathies lupiques, puis il y a les antiarythmiques, mais au-delà de ça, on n'a pas beaucoup d'options. Puis chez l'enfant, je dirais, surtout s'il y a de l'insuffisance tricuspidienne sévère, ça va être typiquement mal toléré là, chez le fœtus. Ça peut être associé aussi avec une certaine hydrops et ensuite mortalité. Puis c'est des enfants qui, en postnatal, vont typiquement aussi présenter de la chaleur. Donc, c'est quoi les symptômes de défaillance cardiaque là, chez l'enfant? Je dirais qu'il y a quand même une distinction importante à faire vraiment chez le jeune enfant, le nouveau-né et l'enfant plus vieux. Donc, les symptômes qui sont rencontrés fréquemment chez le jeune enfant, c'est plutôt la tachypnée, les difficultés à l'alimentation comme le reflux, les vomissements, les reflux de boire et la diaphorèse. Puis, dans des choses qui sont un petit peu moins communes, mais aussi plus typiques du jeune enfant, c'est la cyanose, les palpitations, la syncope. Et les œdèmes. Donc, les œdèmes vont être quand même assez apparents, donc notamment au niveau du visage, puis aussi dans les régions dépendantes là, ou déclives là, du nouveau-né. Par rapport, par exemple, à l'enfant plus vieux, ça va être plutôt des symptômes de fatigue, d'intolérance à l'effort. Puis je dirais aussi, l'orthopnie, par exemple, c'est typiquement chez les plus vieux. Puis chez l'enfant plus vieux, des fois, ce qui peut être manqué ou mal expliqué, c'est en fait la douleur abdominale, les nausées, vomissements, qui sont souvent pas reconnus comme des signes de défaillance. En défaillance cardiaque, on utilise des échelles en fait pour classifier la sévérité des symptômes de présentation. Donc, chaque patient qu'on évalue vraiment, on va le catégoriser selon soit la classe NYHA. Donc, ça, typiquement, c'est vraiment chez le plus vieux, parce que c'est une échelle qui est vraiment plutôt basée sur l'activité physique. Chez l'enfant, surtout quand ils sont en bas de 6 ans, on utilise plutôt la classification de Ross. Ça ressemble, je les ai mis une à côté de l'autre, mais essentiellement, par exemple, un classe 2, ça va être vraiment une tachypnée ou une diaphorèse légère à l'alimentation. Un classe 3, c'est une tachypnée ou une diaphorèse un peu plus marquée, mais aussi associée à un retard de croissance. Puis la classe 4, c'est vraiment la présence de symptômes même au repos. Pour ce qui est de l'examen clinique, je vous dirais que pour nous, il y a comme vraiment deux point central ou important à déterminer chez l'enfant. Déjà, souvent les gens comprennent bien les deux éléments, mais souvent on va traiter l'amalgame sans bien prendre le temps de faire la distinction entre les deux. Puis je dirais que c'est vraiment important parce que l'enfant, ou en tout cas même l'adulte, dépendamment dans quelle catégorie il se trouve, le traitement doit être majoré ou en tout cas fait en conséquence. Donc, c'est sûr qu'une des premières questions, c'est de savoir est-ce que la personne, l'enfant, est en surcharge ou s'il y a des signes de congestion veineuse, de congestion pulmonaire, hépatique. Puis ça, d'habitude, c'est vraiment les signes comme par exemple des pathomégalies, qui est quand même facile à reconnaître chez l'enfant, la tachypnée, l'orthopnée, les œdèmes, puis les ascites. Puis je mentionnerais que dans le fond, un B3, également l'auscultation ou la présence d'un galop va plutôt avec le tableau de surcharge. Dans les examens paracliniques, un des signes qui peut nous aider, c'est également l'hyponatrémie, par exemple, ou les NT-proBNP, là, quand ils sont élevés, ça peut aller aussi plutôt avec la surcharge. Puis ensuite, l'autre question, c'est de savoir est-ce que le patient il est un débit adéquat ou est-ce qu'il est plutôt mal perfusé. Donc, c'est là qu'on va voir la manifestation de l'hypotension. Par contre, je voudrais juste souligner que l'hypotension apparaît de façon plutôt tardive là, chez l'enfant. Il est capable quand même de bien compenser avec la tachycardie. Donc, si l'enfant est plutôt tachycarde et c'est de manière inappropriée, il est possiblement en état comme pré-choc. Donc, c'est quand même important de reconnaître, surtout s'il a les extrémités clampées, les extrémités froides. Puis également, un des signes, c'est l'irritabilité, un patient qui va avoir une altération de l'état de conscience. Puis dans les examens plus paracliniques qui vont aider, pour ça, ça va être plutôt les lactates, aussi voir l'oligurie, un patient qui urine moins, et la saturation veineuse mixte aussi. Pour ce qui est des investigations donc initiales, donc toujours la radiographie pulmonaire bien importante, on est capable de voir la cardiomégalie, aussi les signes de surcharge ou de revascularisation. Le CG 12 dérivations, c'est utile pour voir si on a de l'HVD, de l'HVG. On peut évaluer le PR, donc un PR court, par exemple, avec des hauts voltages, ça fait penser à une maladie de pompe. De la préexcitation avec l'hypertrophie encore, ça peut faire penser à Danon, par exemple. Les ondes Q, les ondes T, ça c'est important pour voir s'il y a des signes d'ischémie. Des fois, ça peut être non spécifique si on vraiment a une dysfonction qui est importante, globale. Mais par exemple, pour le L-kappa, qui est une anomalie d'insertion des coronaires, ça va être typiquement dans le territoire latéral. Donc, un AVL quand on a des ondes Q. Donc, les gaz sanguins, lactate, fonction rénale, fonction hépatique. La FSC aussi qui est importante, comme j'ai mentionné tantôt, là, le BART syndrome qui peut être associé avec une neutropénie. Les prélèvements critiques, c'est une hypoglycémie, le NT-proBNP, qui est important, mais je dirais, bon, peut-être au diagnostic, mais c'est surtout, je vous dirais, dans le suivi, une fois que le diagnostic est établi. Les recherches virales quand on a une suspicion de myocardite. L'échocardiographie qui est importante, donc, pour éliminer les malformations cardiaques, mais également pour bien évaluer la taille et la fonction des ventricules. Évaluer également s'il y a présence d'anomalies segmentaires qui irait avec plutôt des anomalies des coronaires ou ischémiques. L'évaluation des pressions pulmonaires et quantification ou évaluation des insuffisances valvulaires. Le Holter est pertinent si on a une suspicion d'arythmie. Comme vous savez, ça pourrait être une cause réversible de cardiomyopathie dilatée. Donc, c'est bien important de le faire si on suspecte ça. Et ça peut être également utilisé, par exemple, plutôt dans le dépistage d'arythmie dans les patients, par exemple, avec cardiomyopathie hypertrophique. La résonance magnétique peut avoir un rôle dans les myocardites, dans les dysplasies arythmogènes du VD pour bien caractériser le VD. Peut être aussi également utile dans certaines pathologies spécifiques, justement pour bien évaluer la fraction d'éjection quand l'échographie est limitée. Les cathétérismes cardiaques et la biopsie cardiaque, je dirais qu'ils ont de moins en moins un rôle, du moins dans la prise en charge initiale et dans le diagnostic. Dans les autres investigations importantes, je dirais, une des choses très importantes, c'est vraiment le dépistage chez les membres de la famille premier degré. Donc, typiquement, on va poser quand même la question, donc une bonne histoire va inclure à savoir si on a une histoire familiale de cardiomyopathie. Par contre, des fois, elle peut être sous-diagnostiquée, pas connue. Donc, vraiment, après avoir stabilisé le patient, amorcé le traitement, on va typiquement aussi recommander l'échographie chez tous les membres de la famille. Dans les bilans métaboliques, on va inclure la chromatographie des acides organiques, des acides aminés, le profil de l'acylcarnitine, lactate, pyruvate et les CK. Puis ensuite, il y a tous les tests génétiques, mais qui vont être vraiment en fonction du patient ou de la maladie qu'on a. Donc, par exemple, si on suspecte une maladie de pompe, on va faire un dosage enzymatique. Puis les tests génétiques, autrement, on a aussi des panels, en fait, pour les différents types de cardiomyopathie. Dans le fond, même pour la mort subite, par exemple, s'il y a eu un membre de la famille qui est décédé ou qui a eu une mort subite réanimée, les dilatés, les hypertrophiques. On a des panels aussi pour les racopathies, les maladies mitochondriales également. Et aussi, si on suspecte, bien entendu, une dystrophie musculaire. Puis il y a des examens plus invasifs comme la biopsie musculaire, par exemple, quand on suspecte certaines pathologies particulières. Qu'est-ce qu'il en est de la prise en charge? Donc, un patient qui se présente en défaillance cardiaque aiguë, typiquement, donc, comme je vous dis, en état de choc ou en état de choc compensé, il faut tout de suite penser à restreindre les apports liquidiens. Donc, on dit typiquement 75-80% des apports usuels. On essaie aussi de voir à diminuer les demandes. Donc, ça va inclure donc intuber un patient, mettre de l'oxygène, favoriser des gavages pour l'alimentation plutôt que de le faire boire ou la mise au sein. Traitement de la fièvre, traitement des infections concomitantes, on dit jusqu'à 30% des chocs cardiogéniques se présentent avec une infection concomitante. Puis, je dirais que la curarisation n'est pas indiquée, puis on fait ça vraiment presque plus là, chez les patients. Pour ce qui est des diurétiques, on utilise les diurétiques de lance, donc comme le furosémide avec une dose initiale de 0,5 à 1 mg kilodose. Donc, IV en général, surtout quand ils sont plutôt malades. Si on a un patient très fragile, on peut même envisager des perfusions. Puis, au-delà de 3 mg par kilo, il faut penser quand même au potassium, qui des fois peut baisser. Donc, soit de l'aldactone si le patient est assez stable ou du moins surveillé. Puis, assez souvent, surtout si on a des formes assez importantes de surcharge, on va associer à un thiazide. Donc, quand ils sont plus petits néonates, je dirais plutôt de l'hydrochlorothiazide, mais sinon, on utilise beaucoup le métolazone dès qu'ils sont un petit peu plus vieux. Pour ce qui est des amines, donc vous connaissez bien l'amylrinone, la dobutamine et l'épinéphrine. L'amylrinone, on peut commencer avec des plus petites doses chez l'enfant plus jeune ou si on a une atteinte de la fonction rénale, parce que ça va se passer éliminé vraiment par les reins. Puis si on a vraiment des tensions très, très basses, souvent on va commencer peut-être même avec un petit peu d'épinéphrine à basse dose pour permettre vraiment de stabiliser le patient, améliorer comme les organes. Mais on veut éviter que le patient soit trop clampé. Donc, éventuellement, on va débuter vraiment un vasodilatateur comme l'amylrinone ou la dobutamine. Pensez à utiliser le NO, surtout si on a une défaillance droite. Là, on a parlé quand même de quelques étiologies qui peuvent donner ça, ou si on a de l'hypertension pulmonaire. Les antiarythmiques, en fonction de... les antiarythmiques en fonction de s'il y a une arythmie ou pas. La carnitine IV également en attendant de recevoir les résultats du bilan métabolique. L'ECMO et l'assistance si les traitements ne fonctionnent pas. Donc ça, c'est un petit graphique que je trouve intéressant là, qui provient du CCS Heart Failure Guidelines là, de 2013. En fait, qui classifie vraiment les étapes de la prise en charge d'un patient en fonction de la classe fonctionnelle, là, comme tu disais, donc soit de la NYHA ou du ROS. Donc, vraiment, le patient, initialement, qui va se présenter, qui va être plutôt instable, ou surtout s'il a des symptômes, on va typiquement commencer avec des diurétiques pour essayer d'améliorer l'état de surcharge. Une fois que le patient est un petit peu mieux, ça, c'est bien entendu si on n'a pas des signes de bas débit. Si on a des signes de bas débit, on va être vraiment à commencer nos inotropes, même considérer des supports plus importants si le patient reste vraiment instable. Puis ensuite, donc, un patient qui a des anomalies à l'écho, par exemple, même sans symptômes, on va toujours commencer un ACE inhibitors. Puis, par la suite, si la dysfonction est comme plutôt modérée sévère, même sans symptômes, je dirais, on commence les bêta-bloqueurs. Puis, par la suite, on commence l'antagoniste de l'aldostérone. C'est un graphique qui est bien fait parce qu'en fait, il montre que, tu sais, quand on voit que ça devient plus pâle, c'est que, en fait, de moins en moins de patients les tolèrent ou du moins pas à aussi haute dose. Donc, ce que ça veut dire, c'est que si on a un patient vraiment qui est quand même très symptomatique, qu'on vient tout juste de sevrer les amines ou encore un patient chez qui on n'a pas vraiment sevré les amines, mais on sait qu'on ne pourra pas nécessairement monter aussi haut nos bêta-bloqueurs qu'on le ferait avec notre dossier, par exemple, chez un patient qui est beaucoup plus stable. Puis de la même façon, la pointe quand elle s'amenuise, c'est pour dire que il y a moins de patients en fait qui vont tolérer également. Donc, un patient qui est très instable, par exemple, on ne mettra pas de bêta-bloqueur. Mais on pourrait envisager, une fois qu'on diminue tranquillement les doses de milrinone, commencer un petit peu les ACE inhibitors. Ça pourrait être quand même toléré chez un certain nombre de patients. Puis, les antagonistes de l'aldostérone, même si typiquement on le commence en 3e ligne, si on a un patient, par exemple, qui est aux soins intensifs, il va assez bien, on a commencé les ACE inhibitors, le potassium nous le permet, on pourrait commencer une petite dose, par exemple, de spironolactone, par exemple. Donc, en détail, comme je vous dis, typiquement, quand on évolue vers une défaillance cardiaque chronique, nous, on fait un relais des inotropes vers les IECA, même si le patient est asymptomatique. Typiquement, chez le tout petit, c'est le captopril qu'on utilise qui se donne en 8 heures. La dose maximale, c'est 1,5 mg par kilo par jour. Dès que l'enfant est un petit peu plus vieux ou que les tensions sont un petit peu plus robustes, on va faire une transition vers l'énalapril. Nous, on donne jusqu'à 0,8 mg par kilo par jour. Il faut savoir que la fonction rénale est sensible chez le moins de 4 mois. Donc, typiquement, dès qu'on fait des changements ou avant même de commencer un traitement, on va monitorer la fonction rénale. Puis, il faut surveiller la tension, je dirais, jusqu'à 2 heures post-administration parce que la diminution de la tension pourrait être supérieure aux 5 à 10 attendu. Puis, il faut suspendre ou diminuer la dose si la créate augmente de plus de 50 Dans les bêta-bloqueurs qu'on utilise, donc dans les agents, nous, c'est les carvedilol et le métoprolol. Faut savoir que c'est les deux qui ont principalement été étudiés en défaillance cardiaque, que ce soit chez l'adulte ou chez l'enfant. Chez l'enfant, avec les méta-analyses, on n'a pas réussi à démontrer vraiment qu'il y avait un effet significatif sur la survie ou même les symptômes. Par contre, avec le carvedilol, dans une des analyses, on avait vu quand même qu'il y avait une amélioration de la fonction avec une amélioration de la fraction de raccourcissement. Les antagonistes de l'aldostérone, ça aussi, c'est indiqué surtout sur une base de littérature adulte. Puis la digoxine, je dirais qu'il avait comme perdu en popularité, revient un peu, basé un peu, je dirais, plutôt sur des études en adultes où la digoxine utilisée, par exemple, en 4e ligne, si le patient restait symptomatique malgré les traitements que j'ai mentionnés, va être débutée, mais plutôt avec des doses plutôt conservatrice. Donc, on vise des dosages plus bas là, vers 0,5 à 0,9 nanogrammes par millilitre. Il faut faire attention s'il y a de la dysfonction rénale, si on est sous amio ou avec les IECA. Pour ce qui est de l'anticoagulation, je dirais, bon, bien entendu, si on a un thrombus ou si on a une tachycardie supraventriculaire type flotteur FA et qu'il y a une dysfonction systolique, donc c'est indiqué. Donc, soit énoxaparine ou warfarine qu'on n'utilise pas ou peu, en fait, chez le nouveau-né. Puis, par contre, quand on n'a pas ni de thrombus ni d'arythmie, nous, on a quand même tendance à l'utiliser, je vous dirais, si on a une fraction d'éjection inférieure à 25 surtout si chez le patient hospitalisé, qui est alité, qui ne bouge pas beaucoup. Puis, on utilise l'énoxaparine chez le petit. La warfarine, on évite parce que souvent, on veut avoir une diète comme assez régulière, assez stricte. Là, puis c'est quand même compliqué là, chez le jeune enfant. Pour ce qui est de la défaillance cardiaque diastolique, donc les principes de traitement sont quand même différents. Donc, comme on le sait, dans le fond, quand on a, par exemple, une hypertrophie, une cardiomyopathie hypertrophique avec un gradient intravégé, on va viser quand même un remplissage liquidien. Ce que je veux dire par là, c'est si un patient qui arrive, par exemple, instable, en bas débit, la première ligne, ça va être vraiment d'installer une voie, de remplir, de bolusser. Pour justement assurer comme un certain débit cardiaque. Ensuite, l'autre traitement qui est important, ça va être les bêta-bloqueurs, que typiquement chez l'enfant jeune, on utilise, nous, c'est le propanolol. Là, vraiment, pour avoir un effet sur la fréquence cardiaque, permettre un remplissage et puis restaurer un débit cardiaque. Puis chez le patient qui est comme vraiment instable ou chez qui on veut vraiment être capable de bien titrer, on va débuter de l'esmolol IV. Les bloqueurs canaux-calciques, je dirais que c'est vraiment à éviter chez l'enfant, surtout en bas d'1 an. La disopyramide, on l'utilise, nous, en 2e ligne, quand il y a encore un gradient qui persiste, là, malgré des bonnes doses de bêta-bloqueurs. Puis chez les racopathies, on a eu des travaux, entre autres le fait par Dr. Andelfinger, puis maintenant, dans d'autres centres qu'on fait ça. On traite avec du trametinib, puis avec sirolimus également. Puis on voit avec ça comme vraiment une amélioration des gradients. Puis c'est des traitements qui ciblent là, la voie des MAP kinases. Si on a une surcharge importante, donc sur une dysfonction diastolique, donc les diurétiques, bien entendu, puis la VNI, Puis attention avec le NO, parce que c'est des patients, tu sais, des fois qu'on voit, parce que là, il y a un petit peu d'hashtag, là, on met du NO. Il faut comprendre qu'avec une grosse dysfonction diastolique, c'est vraiment des patients qu'on peut rendre plus malades, vu qu'ils ont déjà des pressions de remplissage élevées. Pour ce qui est de la cardiomyopathie restrictive, je l'ai mentionné rapidement un peu plus tôt, on a quand même peu d'options de traitement parce que c'est des patients qui sont quand même volume dépendants. Donc, ils ont un volume assez fixe parce que leur ventricule est quand même peu compliant. Donc, souvent, on va utiliser des diurétiques, mais il ne faut pas donner des trop grosses doses là encore parce que s'ils sont trop vides, ben, ils vont se mettre en bas débit. Puis les bêta-bloqueurs, mais aussi encore à petite dose. Puis c'est des patients qui sont vraiment à risque d'arythmie supraventriculaire, mais aussi de mort subite. D'où, comme je vous ai expliqué, de la mise sur liste de greffe assez rapide. Donc, c'est quoi leur pronostic ou l'évolution? Je dirais la cardiomyopathie dilatée, ce qu'il faut savoir, c'est par exemple, quand nous, on fait un diagnostic en période néonatale ou même chez le jeune enfant qui va être hospitalisé, parfois très malade à l'hôpital pendant des mois, il y a quand même un 20 de ces patients-là qui vont avoir une normalisation de fonction à 2 ans. Ce que ça veut dire, c'est qu'au bout d'un certain temps, donc on est passé à des traitements plutôt chroniques, puis la fonction s'est normalisée, on a sevré les médicaments, puis la fonction reste normale malgré le sevrage des médicaments. Ce qu'il faut savoir, c'est que certains patients peuvent ravoir de la dysfonction. Puis, il y a aussi des patients, en fait, qui ont un deuxième pic plutôt vers la préadolescence où là, la fonction va se redétériorer, puis des fois même nécessiter là, des soins quand même plus intenses. On estime le taux de décès ou de transplantation quand on a un diagnostic de cardiomyopathie dilatée, donc à 1 an de 31 et 46 à 5 ans. La cardiomyopathie dilatée, c'est quand même la cause principale de greffe cardiaque chez l'enfant et chez l'adulte. Pour ce qui est de la cardiomyopathie hypertrophique, là aussi, je dirais que chez l'enfant, surtout l'enfant très jeune, si on voit ici avec la courbe, là, donc les enfants de moins d'1 an, on a quand même une courbe de survie là, qui est moins bonne en fait que les autres groupes d'âge. Puis je dirais qu'en bonne partie, c'était sur la surreprésentation de d'autres types de diagnostics. Donc, oui, il y a des cardiomyopathies hypertrophiques là-dedans, idiopathiques là, ou sarcomériques, mais on retrouve aussi dans ce groupe d'âge-là, en fait, les patients qui ont des maladies métaboliques, notamment la maladie de pompe. Puis on retrouve aussi les patients qui ont des syndromes là, comme le Noonan. Puis on sait que les deux ont, surtout le Noonan, ils ont quand même un pronostic réservé. Par contre, ce qui est intéressant, c'est quand on a isolé vraiment, puis on a fait une sous-analyse, juste les patients qui ont une cardiomyopathie hypertrophique sarcomérique, on avait quand même une mortalité, en tout cas une survie à 76 ce qui est quand même plus élevé, encore plus faible en fait que quand on l'a plus vieux. Par contre, une fois qu'on a passé au survécu l'âge de 1 an, on a une survie qui est comme similaire, là, un taux de survie qui est similaire en fait par année par la suite. Ce qu'il faut savoir aussi, c'est que la cause principale de décès des cardiomyopathies hypertrophiques chez le jeune enfant sont principalement sur de la défaillance. Donc, un enfant, nous, qui se présente moins d'1 an, qui a déjà des signes de défaillance, besoin de support ventilatoire, on est assez pessimiste sur le devenir. Ça, c'est sans compter en plus qu'on n'a pas encore exploré l'étiologie. Tandis que chez l'enfant plus vieux ou l'adulte, ça va être plutôt des arythmies là, qui vont être la cause de décès. Donc, en conclusion, la défaillance cardiaque est une entité clinique importante à reconnaître. Puis en fait, si on y pense ou si ça fait partie de notre différentiel, c'est quand même quelque chose qu'on est capable de reconnaître assez facilement. Une approche systématique est nécessaire pour la prise en charge et le traitement de la défaillance cardiaque. Donc, c'est pas chacun sa recette. Là. Il y a vraiment stepwise approach de comment on traite puis comment on aborde ça. Puis, par contre, malgré la pluralité des étiologies, notamment chez l'enfant, on a quand même beaucoup de différentes causes. La défaillance, ça peut être traitée ou catégorisée, en fait, selon le type de cardiomyopathie et aussi le type de dysfonction, ce qui simplifie quand même la prise en charge. Puis, aussi, là, ça va de soi, mais un bilan génétique, un dépistage familial qui devrait être fait là, chez tous les patients qui se présentent avec cardiomyopathie. Merci. Je serais curieuse de prendre vos questions.
Oh, Dr. Santana, you are muted. And I think we have Dr. Alami on the line also. Thank you so much, Dr. Alami, for such a great presentation, very exhaustive talk. addressing many of the key aspects of one of the very, one element we're terrified in the NICUs is the neonatal severe cardiac failures. So that was extremely clear. And you addressed both acute and chronic. So that was great. We'll go on with a few questions that we got. One of the questions, I think, which is a controversy in the neonatal population, is myocarditis secondary to what is thought to be an infectious process. And, there's always the question about, should we give IVIG or not give IVIG, and what's the evidence between immunoglobulin and that particular entity. I wondered what would be your recommendation, your practice, knowing that sometimes, giving excessive fluids in some of these patients could also be detrimental.
Yeah, so that's not an easy question, I'd say, but my personal way of doing things and the way I saw it done is mainly we give it, I'd say, just as, especially if it really seems like it has to be like something infectious. If it's really a neonate that seems not that decompensated, then it seems probably like a more chronic process, because we have other signs also how we can tell, like typically they are not such in high state of failure for the severity of the dysfunction, for example. So we would probably be more cautious and not give them. So the alternative, I'd say, but if there's really a suspicion, we're not sure there was a history of infection, then we would still probably give it. But as you know, there's a lot of analysis and studies. None of them has been like randomly randomized and properly done. But from all the evidence we have, there's really no distinct, like no clear evidence that it's actually helping, let's say that way. But we've been using it. And I'd say like also sometimes for the lupus, cardiomyopathy as well, like for the fetal moms, I think also some of the immunologists will still also give it. So that's another indication where typically it's used. But I'd say, yeah, so we still use it. And what we do typically is also sometimes we split the dose, like we won't give it like on one day, for example, we split it over 48 hours or things like that. But again, with no strong evidence.
One other question that came up is that we do see some patients that have various degrees of heart failure that are responding to some of the medication that you mentioned, like milrinone, which is typically an IV infusion. And then you're stuck on the milrinone and, sending these families at home on some of these milrinone home program or keeping them hospitalized with milrinone to keep their cardiac function ongoing is sometimes, causing a lot of burden. So one of the questions that came up is where are we at in terms of oral medications and things such as maybe, medication that doesn't need to be given as frequently, such as levosimendan, and what's your experience with that?
So typically, I'd have to say, unfortunately, it's one of those diseases where you have to be patient. So, and it typically end up being a long stay, like hospital stay. Let's put it that way. In my experience, when we try, to be aggressive and wean fast, the support, typically if it's not like a clear myocarditis. So typically if it's something that you see after 3-5 days that the function is significantly improved, yes, you're comfortable and you can wean fastly. But if it's still that ejection fraction of 30%, let's be real, it's typically like several weeks, of being in the hospital. So levosimendan, I'd say for us, we typically use it, when we're at the verge maybe of having to add a second agent. Let's say you're on milrinone, the patient is not doing great, you're thinking about intubating the patient, so he's kind of not doing so well. So that's typically where we use it. It doesn't really help us to wean milrinone more fast, I'd say. Typically, it's more like you feel like your patient is getting more acute or on the verge of getting sicker. So that's typically when we use it. And I'd say in some patients, we see some success with that. But typically, it's the patient that will end up, on Berlin heart or things like that, where we end up using it. But it can be good as a rescue or help you like to stabilize your patient for some time by the time you order, like the Berlin heart and things like that. But yeah. And for the, go ahead.
No, go for it. Sorry, I cut you.
And for the oral medication, I'd say a lot of our patients won't tolerate them as well. So typically you'd have the patient, he's now on 0.3, 0.2 of milrinone. We start with a small dose of ACE and his blood pressure is not well. He starts vomiting. He's not tolerating well. So typically in a lot of settings, especially with the very small kid, it's not unusual that we will maybe barely able to start like a tiny dose, but it's not because you failed that first time. It's something typically you'd have to reassess and try also over the next few weeks. So classically, I'd say a lot of our kids, when they go home, they're not like on full treatment, or and we'll have to tailor that. So it's typical after 3-4 weeks, we'll still try again. They're not tolerating it, so we'll see them again in 3-4 weeks, we'll try again. So it's just a matter of, poking when it's the right time to poke, I'd say, but it can be like tedious to get there.
Could you provide us in the audience some guidance about, modalities to assess some of these patients, especially at the initial stage when, we come across some of these patients and on the heart echo, there's severe heart failure. Like, what is the place, for example, of MRI or cath in some of these babies, like for the etiology, for example? Do you do biopsies on all of them? Do you do MRIs? Do you base yourself on that for like diagnosis, for fibrosis?
So I'd say in the acute phase, sometimes, of course, we want to have the more answer as possible, but I'd say typically the patient is typically too unstable to go to the MRI. So of course, MRI has some good insight, especially for myocarditis. But then again, it depends also on your expertise on your local center, I'd say. But it can give you some insight. But in reality, I'd say the MRI can have a role, but typically more in the subclinic phase where it's more useful. We can do it. Also looking for scaring, if you're wondering if it's something a bit more chronic, it can give you some help. And I'd say the cath, it's typically reserved only if we still have questions about the anatomy of the coronaries. We never do biopsies, especially in the acute phase. They can be quite unstable as well. And again, it's the risk ratio benefits is very low. So in practice, people don't use that as much now. So it's not something we typically use nowadays.
Dr. Laroussi, thank you so much for your presentation and to answer the questions of the audience that we received. I think we're going to go on the break, and we have, our last speakers, which should be, again, a great panel around 3:20. We're going to start. We're going to start with a family, and then we have 2 other speakers that will conclude the day. Just a bit of housekeeping. Don't forget to file in all your evaluation forms. Donc, s'il vous plaît, remplir vos évaluations, vos formulaires sur le site web. Sur le site web, vous allez également retrouver la copie des PDF pour des présentations des conférenciers ainsi que certaines des vidéos enregistrées. So on the website, you will find the PDFs of the presentations as well as some of the recordings of today's talk. Dr. Santana, anything you want to add before we go on break?
No, I just want to thank Dr. Laroussi for this great presentation. I've learned a lot. Thank you.
Thank you.
So we'll see you all in exactly 13 minutes and restarting at 3:20.
Increasingly present in our lives, shortening distances, bringing faster solutions, and with more practical ways of living day by day. We believe that for all of this to make sense, every solution needs a reason to exist. So why not focus on using this technology to solve real problems in our society? At a time when neonatology had an important reduction in mortality, and today it has the challenge of preserving the quality of life of patients and their families. In a scenario where the number of children with disabling diseases is very large, representing a hard socioeconomic burden in Brazil and in the world. In a country of continental proportions where the heterogeneity of resources, protocols, and conducts represents a harsh reality. PBSF, Protecting Brains and Saving Futures, was born with the motto of bringing accessible technology and intelligence to prevent neurological sequelae, as with the objective of promoting initial and longitudinal education and training, and also facilitating the implementation of methodologies and tools for early diagnosis and neuroprotection on a large scale. And for this, we created the CSI, a central of surveillance and intelligence where we use an advanced telemedicine system to break borders and shorten distances. In this scenario, we've already monitored more than 4,000 children in more than 270,000 hours of monitoring, distributed in more than 30 hospitals located in all 5 regions of the country. In addition, we're extremely pleased to work with international partnerships with a focus on education, research, and technological development. But we want to go further, generating homogeneity of protocols and conducts between distance centers and with different resources. With intelligent monitoring, longitudinal education, and capacity building, we can better serve high-risk babies. Together, we can make a difference in the lives of each of these little patients. We believe in the fundamental importance of each of these children being able to read, learn, and believe in tomorrow. Only in this way can we build a country and a better future. PBSF. Learn more at pbsf.com.br. Technology is increasingly present in our lives, shortening distances, bringing faster solutions, and with more practical ways of living day by day. We believe that for all of this to make sense, every solution needs a reason to exist. So why not focus on using this technology to solve real problems in our society? At a time when neonatology had an important reduction in mortality, and today it has the challenge of preserving the quality of life of patients and their families. In a scenario where the number of children with disabling diseases is very large, representing a hard socioeconomic burden in Brazil and in the world. In a country of continental proportions where the heterogeneity of resources, protocols, and conducts represents a harsh reality. PBSF, Protecting Brains and Saving Futures, was born with the motto of bringing accessible technology and intelligence to prevent neurological sequelae, as with the objective of promoting initial and longitudinal education and training, and also facilitating the implementation of methodologies and tools for early diagnosis and neuroprotection on a large scale. And for this, we created the CSI, a central of surveillance and intelligence where we use an advanced telemedicine system to break borders and shorten distances. In this scenario, we've already monitored more than 4,000 children in more than 270,000 hours of monitoring, distributed in more than 30 hospitals located in all 5 regions of the country. In addition, we're extremely pleased to work with international partnerships with a focus on education, research, and technological development. But we want to go further, generating homogeneity of protocols and conducts between distant centers and with different resources. With intelligent monitoring, longitudinal education, and capacity building, we can better serve high-risk babies. Together, we can make a difference in the lives of each of these little patients. We believe in the fundamental importance of each of these children being able to read, learn, and believe in tomorrow. Only in this way can we build a country and a better future. PBSF. Learn more at pbsf.com.br.
Welcome back, everyone. Bienvenue à tous. So the last segment will be addressing, our neonates. We saw what is happening during the fetal life. We discussed a bit during the immediate postnatal transition, and then after that, the neonatal life. And now we'll be talking a bit more about what's happening later on after they graduate from the NICU. And, it's very important that we give a voice to the parents and to the parents of our patients to better understand what is important for them, what's about their journey and their story, and better understand their own perspective of how they view what's happening in our hospital, in our NICU, but also outside of the hospital. So it's really with an immense pleasure and privilege that we have one of the families with us, sharing her story, and she will be sharing the story on the behalf also of her son, Emmanuel, and of her spouse, Thierry. And really, I think it's going to be very important for us to listen from what's the perspective of these families. So on this notice, I will let Ms. Philippoulos share her journey.
Hi, everyone. This is Sandra. And? Emmanuel. So to tell you a little bit about my story in relationship to heart malformation, as a nurse of profession, I did work in cardiothoracic surgery. So heart diseases was something familiar within the adult population. Never did I work with in pediatrics. It was something that was too difficult for me. And so I had no experience with heart malformations at birth. And so when I got the diagnosis, when Emmanuel was diagnosed with transposition of the great arteries, I was pregnant of 6 months. And so it was obviously a huge shock. Obviously you think of the worst that could happen. So from the 6th to the day that I gave birth, obviously, it gave me that time to be able to read, ask questions, especially to Michelle, who was a huge support and help throughout those difficult times and even nowadays. It helped me prepare as much as I could. And it helped me give Emmanuel that strength that I needed to give him. I truly believe that the connection, obviously, that a mom has with their child is super important. And so for me, it was crucial to not only be at peace with the situation, so to accept the situation, to be prepared. It's something that is out of my control. And so I wanted to be the most calm as possible, because I knew that if I would be too stressed, I would, I guess I would give him that stress as well. Needless to say that in my case, I didn't tell anybody, even my mom. And for the first 2 years, she even took it very, very personal, which I understand her. But for me, it was very important to keep it low key, so people wouldn't, one, feel bad for myself, two, tell me to stop working, stop training. I really, truly wanted to just focus on him, providing him the best positive energy, eat well, sleep, train, do everything that I wanted to do. So continue working and be prepared for giving birth. 3rd of September 2013, Emmanuel was born at the old at the Royal Vic, at the old place. And he was transferred that same day to the old children's. Dr. Dancia took the best of care of him as of the first day. Another example that I have to tell you that it has always been in my mind and in my heart, there's two actually. One, when throughout Emmanuel's surgery, Michelle called me a couple of times to tell me where they were at with the surgery, if, obviously if he was still alive, and just reassuring me, because it's very long and very stressful. So I think that aspect is so important. Maybe not for all the parents, but certainly for me, it helped me. The other thing that I will always cherish is when Emmanuel had, again, I believe he had 3 pneumothorax, and Dr. Samara was there. She was on call that day, and she just, when I pushed myself, she just came to see me afterwards and reassured me and explained to me that it was normal for me to feel like that, but that it was something normal also that was happening when chests were open, obviously after heart surgery. So all these little elements are crucial for the time that you're at the hospital. Again, it's all about the knowledge. It's all about the communication between the staff and the parents. It's all about the understanding of the situation. And even if it's negative, obviously, it's very important to really understand on that specific time and on that day what's going on with your child. Oh. So, as mentioned in the beginning, there's not many, everything was just, in my case, it was just perfect. But if there are elements that I would discuss in order for the situation to be better, for me personally, when the diagnosis was given, so at 6 months pregnant, the way it was said and explained to me, I found that hard. Not in the sense because of the situation, but of the way it was explained. I find that it was very impersonal. I also understand the side of the doctor that does not want to show emotions or cannot. And again, I understand that part. But as a parent, that moment is something that I'll never forget because obviously it changes your life forever. And so the fact that it was very impersonal, for me, I think that there's ways to improve when something like this is being announced to the parents. And then second of all, as you all know, I'm part of the PICU, I was part of the PICU meetings in advancement. And I know that you guys now have a whiteboard. Back then, obviously at the old children's, there was no whiteboard for the parents. And I truly think that that's something that would have helped me understand the situation even more, maybe even enabled me to not bother the staff so much or so often with all my 10,000 questions. So those are the only 2 things really. Other than that, I found, I couldn't have asked for a better situation with all the healthcare professionals. Everything was just down-packed, professional. The caring towards my child, the respect, everything just was perfect. So I congratulate everybody for the great work that you guys do. So my experience living with a child who had a heart malformation. So there's different episodes throughout my life since I've had Emmanuel. So when we brought back Emmanuel at home for the first year, I was super overprotective. I still am, but not at that level. I was scared of feeding him. I was asking people. I was limiting whomever was entering my home, so only the grandparents were allowed because I was scared of, bringing in any virus or infections or whatnot. And I would ask them to wear a gown. We weren't even COVID time, but that's how overly protective and scared, without even realizing that I was scared of him being sick or of losing him. It's extremely weird to say, but I think of these moments, they're even more clearer for me in my mind and in my heart, even 8 years afterwards than the first year. I guess it's maybe it's a normal process. Michelle has told me that other parents have said the same. But I think in seeing it in a positive way, the fact of having a very sick child And the fact that Emmanuel could have died, it enables me to, I believe, to be a better mom, to be there more than maybe I would have been, because I acknowledge what he's been through, and the fact that he needs special care. Emmanuel is a healthy 8-year-old, but he has his deficits with language and fine motor skills, and so he needs a lot of private speech therapist, physio, all these particular private classes that he has. And so for me, it's my duty as a mom, especially that he went through so much, right? The other thing is, maybe I overly protected him, where I was scared of him going for a bike ride, or I'll give you a perfect example. At school is the first time last week that I allowed him taking the bus for a school outing. There's always that scare of losing your child. Even if I try not to, it's stronger than me. The other thing is that I'm so thankful that every morning and every night, I thank, the universe and life for giving me Emmanuel, for giving me the chance to live with him and to see him grow, to be able to be that mom that I am now. It actually allowed me to start my own company, to have a philanthropic mission and to give back to the children's, mostly. There's other foundations, but mostly to the children's, mostly to the PQ. You all have a very special place in my heart, and that will be forever, no matter what. There's, so many people that took care of him, but certain people that have been they will always have that special place in my heart and in my mind, are obviously Dr. Dancia, Michelle, Dr. Trevenkov, Dr. Samara, Sarah Claude, who was one of the nurses there, many of the other nurses back then as well. And, it also allows Emmanuel to understand and to be more thankful. I always remind him, not only, with all these things that I have in our room and in his room, but I also have, like a little booklet of, him with his surgery, like this. So it's important for me that he understands how sick he was and how lucky he is. So when he comes back from school and tells me, I'm in pain, or I don't want to do this, or I'm not good, or whatnot, I always remind him what he went through. Because if he was able to go through, open heart surgery and everything, he was very, very sick. He was 4 pounds at term. His kidneys, everything was just shutting down. The pneumothorax that he had, all these things made it that if he was able to go through that, I want him to see, how he can do anything afterwards. And even myself, it enabled me to be stronger. And whenever I'm scared of something, or whenever there's something that goes wrong or is negative, I have that image of my son in the ICU, in his bed, fighting for his life. And so I think for me, it actually, like they say in French, un mal pour un bien. So it was a negative situation, but because he made it through, he is my inspiration. He is my why. He is the why of, our company, Philo Import. And because of all of you and your amazing care and knowledge and technology, all those aspects that you guys offer. So hi, parents. My name is Sandra, and I'd like to give you a message of comfort. I went through what you're going through, or what you will be going through soon. My son, Emmanuel, had the transposition of the great arteries, 37.5 weeks, so term baby, 4 pounds only, very, very sick. He had his surgery, open heart surgery at the Children's at 1 week old. So I know how hard it is. I know the fear. I know all those mixed emotions that you're probably feeling right now. But if I can give you a couple of advices, one, trust in the team. The Montreal Children's Hospital has this amazing team, not only caring, but also so knowledgeable. The medical equipment, the technology, everything is just down packed. And so, one, you need to stay calm. Try not to be stressed, or at least keep it inside, because your child needs to feel reassured by their parent. Also, you need to eat well and take care of yourself. You need to drink water so you can not lose your patience, because it's extremely important to just be grounded, to visualize that your child will go through this, and you have to look at this in a holistic way, and not only just those little negative or bad moments that your child is going through. You have to ask questions to the team. You have to understand the situation, because that way, the more you understand, whether it's positive or negative, the more you'll be able to be in charge of the situation and be there for your child. Even if you can't hold your child, they feel you. They know how if the parents are, how they're feeling. And so you don't want to cause more stress on them. So all in all, please have faith in the medical team, have faith in the universe, and have faith in life. I was given the most beautiful thing ever, my son Emmanuel, who went through rough times 8 years ago, and now he's a healthy 8-year-old. So from the bottom of my heart, I want you to know that every morning I think of all you. I always light up a little candle in order for me to just send out some positive vibes. And so I wish you all the best and stay positive, okay?
Thank you so much, Mrs. Philopoulos, for sharing all these thoughts and comments. This was a beautiful message for both the healthcare professionals as well as the families. And this recording will be made available online for future families if they want to listen in. And we'll have you at the Q&A session to answer some of the great questions from the participants. Our next speaker will be Dr. Anne-Monique Nuy. Dr. Nuy is a neonatologist and senior clinician scientist at CHUS Sainte-Justine. She's a professor at the University of Montreal. She is currently the chief of the Department of Pediatrics there. She has a very large, world-renowned translational research program that looks at the entire span of the life of premature babies, but she has a focus on the health of adults that are born preterm. She has been publishing a lot on the subject of what is the cardiovascular outcomes of our babies that are born prematurely and that we care for in the NICU, and how these infants grow into adults and they may have impact on their cardiac health once they're born preterm and they arrive at adulthood. So Dr. Nuy, thank you so much for taking the time to share with us your expertise, your thoughts. This is very much appreciated. And I know that this presentation will provide a lot of thoughts for our participants.
Thank you very much, Gabrielle. Do you hear me first?
Yes, I hear you very well.
Okay, and then do you see my slides?
I don't see the slides yet, personally. If we do have floor support, maybe to help. And now I see your slides.
Okay, great. So I will go ahead. Initially, it was announced that I was going to speak in French, but knowing that a good majority of the audience or a proportion of the audience understands better English, I will go on with English. And in the program I saw, it was honored to be from McGill University, but in fact, I'm from Université de Montréal. So it's really my pleasure today to talk to you about adult cardiac outcomes of premature infants. So the objectives are to describe the influence of preterm birth on the heart and cardiovascular health in adults and explore pathophysiological mechanisms that might be underlying cardiac changes we see after preterm birth. And I have no disclosure. So I'm a neonatologist and I'm a clinician scientist, and I will be presenting you some of the work from my lab, but from many other labs as well. As you all know in the audience, survival of our very preterm infants has dramatically increased since the mid-20th century. So these numbers here, 15%, 30% in 27-week babies, are from the first new intensive care unit in Chicago back in the 1950s and 1940s. And now you all know that survival of our very preterm infants is becoming closer to that of term infants. So that the challenge now that we're facing is not so much survival, but we want them to have as much as possible disease-free survival. And there's an interesting paper out of Nature in 2020 that indeed talked about this growing knowledge that we have about the health of the littlest, that we have contributed to make sure they go on in life. Why is this important? Well, the third trimester is a critical period of development, and this is exactly when preterm birth occurs. We all know that this is important for lung development, brain development. We hear about that, we care about that every day, but it's also very important for heart development, vessel development. And while the cardiomyocytes are still in active proliferation and organizing themselves and optimizing their use of energy for the whole life, boom, birth occurs, and then they're faced with our NICU obligation, I must say, which implies working with the lungs, therefore causing lung injury. There might be brain injury. Nutrition might not be optimal. We have to dramatically increase the level of oxygen in the blood of these little infants. And therefore, the myocardium has to continue to grow in a what we call normoxic environment, which is relatively so a very much hyperoxic environment for these infants who were, as we all know, relatively hypoxic in utero. So therefore, let's jump already to adulthood. There's a lot of data that has been coming out from Sweden on population-based data because they, as you know, they have high-quality data in Sweden. One of the first questions, population-based high-quality data, one of the first questions that has been looked at is what about hypertension? Because we knew that small for gestational age infants, growth-restricted infants, would be at higher risk of having hypertension later in life. What about preterm infants? Well, indeed, this is also what we see. So in red, these are the adjusted risk for hypertension in infants who were born less than 34 weeks. And the reference value is the black line here at 1 in the term infants. And as we increase prematurity, the risk of being diagnosed with hypertension goes up to 1.4 times higher. In fact, it's 1.2 if we take all the preterm infants, and 1.8 times higher in the ones who were born at less than 28 weeks. And as I mentioned, it's not been long that very preterm infants survive to adulthood and to mid-adulthood. So therefore, follow-up here is only until 43, 45 years of age. So what about the heart? As I mentioned, the heart is in active development during the third trimester. So what happens to the left ventricle function as these children go and grow out of our NICU and grow out to adulthood? Well, during the neonatal period, we can see that left ventricular ejection fraction is better in term, or worse, I would say, in term than in preterm. In infants, we still see a difference. This is a patient-level meta-analysis of nearly 1,500 preterm children compared to term individuals. And we see that the left ventricular ejection fraction is decreased in preterm, but as they grow, the difference is no longer significant in children and is also absent in young adults. So ejection fraction seems to be fine. However, diastolic function is altered in the preterm infants. It's remaining decreased in the so the neonates, the infants, in the children, and in the young adults. So even though we have okay ejection fraction, we do see differences in the adults who were born preterm in their diastolic function. However, these are minor changes that don't necessarily translate into clinical symptoms, fortunately so. When preterm individuals are challenged with a exercise test, we can see here, they are in red, that their ejection fraction in fact goes up very well when they start the exercise, but as the intensity of the exercise is maintained and even increases, their ejection fraction is not able to be maintained as high as well as the term infants. So therefore, preterm born young adults, they have impaired left ventricular response to physiological stress when subjected to physical exercise, which suggests a reduced myocardial functional reserves. This is a study out of Oxford. The same group in Oxford has examined not only function, but also the shape, the geometry of the left ventricle using MRI studies. These were born, so these studies here, I'll be presenting the preterm will always be in blue and the term in light green. This is from the Oxford cohort again. They were born on average at 30 weeks with a birth weight of 1,300 grams. And you can see here that the left ventricle is somewhat shorter and thicker than the left ventricle of the term-born individuals. So on average, they're about 23, 25 years of age. What is also important to realize is that they've adjusted these changes to the blood pressure, because I've just showed you that their blood pressure has a tendency to be higher, and we know high blood pressure will lead to increased to left ventricular hypertrophy. So even with control for blood pressure, the hypertrophy of the left ventricle remains significantly so in the individual born preterm. What about the right ventricle? In fact, the right ventricle seems to be affected a little more than the left ventricle in the individuals born preterm. Here again, same cohort from Oxford who were born at 30 weeks and examined when they were adults here in green, and they've even recruited for this study another group of adults who were born term, but who were 10 years older, so in their 30s to early 40s. This is the right ventricular mass. So this is the term group, and the same age individuals who were born at 32, 36 weeks in light blue, at 28 to 31 weeks in dark blue, and here in black at less than 28 weeks. So right ventricular mass increases proportionally to the lower gestational age at which these young adults were born. And the ejection fraction also is slightly but significantly reduced for the right ventricle in these young adults. So the left ventricle ejection fraction seems maintained up to the young adulthood, but the right ventricle fraction might be a little bit decreased. This is a study that Karagos did with catheterization. So it's a very impressive study in young adults who were born preterm compared to term. This is the mean pulmonary artery pressure, which was significantly higher in those who were born preterm compared to term, as well as the total pulmonary vascular resistance. Earlier today, we also heard about TAPSE, which is a reflection of right ventricular systemic function. And this is a study that we have realized here in Saint-Justin in collaboration with Gabriel Altit on a group of about, overall, there were between 80 and 100, depending on the analysis we did, young adults who were born on average at 27 weeks with a weight of 790 grams compared to the same number of young adults, average age 23 years of age, who were born term. Here I'm presenting you only the data of the preterm who did not have bronchopulmonary dysplasia, compared to the individuals who were born preterm but did have a diagnosis of bronchopulmonary dysplasia, which was oxygen at 36 weeks in this case. And you see that 36% of individual young adults who were born preterm with BPD had a TAPC lower than 16, which is a threshold for beginning to be abnormal here, whereas the preterm who did not have BPD had values very similar to the term group that we had. So as said, the preterm that we see in all these studies are not sick. They're performing, they're doing well. They don't have any symptoms of anything. But when you look at the population level, and here again, we're back to Sweden, there was a very interesting study by Hannah Carr, published in JACC in 2017, where she examined the risk of having a diagnosis of heart failure in childhood and adulthood, and they excluded children with congenital anomalies. As you know, heart failure in pediatrics is very most often related to viral myocarditis, for example. But what they did see, and this was very interesting, that there was a disproportionate overrepresentation of individuals born preterm, and especially at less than 28 weeks, among all children who had a diagnosis of heart failure up to young adulthood. So 17 times higher than expected. There were less than 28 weeks, and there's a decrescendo up to term here. Similarly, if you look at the population of Sweden all the way to 45 years of age, it's the same observation. Children and young adults born preterm are at increased risk of developing heart failure, and the more premature they were born, here you have the extremely preterm, born between 22 and 27 weeks with the orange line, their hazard ratio is 8 to 10 times higher than the one of the full term. Here, the reference line at the bottom. Ischemic heart disease also are seen more often in the individuals born preterm. Here again, data for Sweden, where this population is followed until the age of 43, and over 1.5 times higher risk of ischemic heart disease. And interestingly here, preterm women have a higher hazard ratio than preterm men here. This is not the case for hypertension, but it seems to be the case for ischemic heart disease. So overall, not only because of cardiovascular diseases, but all-cause mortality is influenced, I should say. In all-cause mortality, there's for each additional gestational week, mortality between the age of 18 and 36 years will decrease by 4%. So there is a correlation between all-cause mortality and being born preterm. Is it only related to cardiovascular diseases or their condition? It is unclear. I wanted to share with you some studies specifically regarding women's health. So what about women who were themselves born preterm when they become pregnant? We'll know that pregnancy complications such as gestational diabetes, hypertension, and preeclampsia, when a woman has that, she's certainly at higher risk of showing cardiovascular and metabolic diseases later in her life. And knowing that preterm birth might be associated with higher blood pressure, a question that we ask is it also associated with a greater risk of these pregnancy complications? So this is a study we did on the population of Quebec with RAMQ data of all women born preterm between 1976 and 1995 who had had at least one live delivery up to 2008. And this is the overall result of this study. What you can see is that for gestational diabetes, gestational hypertension, preeclampsia, and at least one complication at least once, here, the women who were born preterm and those who were born less than 32 weeks here in dark blue, nearly 20% of them will have at least one complication at least once during their pregnancies. The women born 32 to 36 weeks also have a significantly higher risk of showing a pregnancy complication compared to the reference group was born at term, and their percentage is not null here. We have to realize it's nearly 12% of all women born term who will at one point have a pregnancy complications, but it's significantly higher for those who were born preterm. Interestingly, women who were themselves born preterm are at high risk of delivering preterm independently from the complications I just showed you. So if they were born at less than 32 weeks, here in dark blue, their risk, 14% of them will deliver preterm at less than 37 weeks, compared to 9.7% of the women who were born term. Why am I bringing this into this conversation? This is because there's been another study by Krump et al. Out again of the Swedish population data published in 2020, showing that women who've delivered preterm, we don't know if these women were born themselves preterm or not, but women who delivered preterm have a higher risk of ischemic heart disease as they age. And this is time after delivery. They follow them up to 40 years after delivery. And the more prematurely they have delivered, the higher their risk of having ischemic heart failure, and a similar pattern of risk was seen for death for a woman who had delivered preterm. As if, in fact, preterm labor, complications of pregnancy, cardiovascular diseases are a little bit all in the same pathophysiological path, and that we should consider this when an adult patient comes in our adult physician colleague's office. I want to share with you some mechanisms that I think are interesting to think about, because why is this happening? Is the cardiac disease that are seen in individuals born preterm following the same pathophysiological pathways as what we see in the general population? One element, for example, that is important to realize is that in the study that we have carried here in Saint-Justine, the cohort of young adults born preterm, we have been very surprised to see that, in fact, for example, obesity does not necessarily correlate with higher blood pressure in this group, whereas it does for the term-born young individuals, as it is known, it's a common knowledge. But if in preterm individuals, it's not necessary that you have a correlation between, for example, obesity and hypertension, this might indicate to us that there's a pathophysiological pathway behind our cardiovascular disease that might differ. So these are studies that my lab has undertaken, and I'm just going to share with you rapidly data indicating that there might be activation of the renin-angiotensin system from the neonatal period, as well as reprogramming of the mitochondria function. For these studies, we're going to jump in the lab for a few minutes here. We have used an animal model that is well known for most of us, because this is the same animal model that is being used to study bronchopulmonary dysplasia and retinopathy of prematurity. In brief, newborn pups are exposed to 80% of oxygen from day 3 to day 10 of life while remaining with their mother. Even though term baby rats are term, their level of development for many organs, including the heart, the lungs, the eyes, is very similar to a 27-weeker, for example. So by exposing them to hyperoxia, we're reproducing the relative hyperoxia that our preterm babies are facing when they're born prematurely. So these animals, what we've seen is that by 4 weeks, so right after weaning, they're still in their rat childhood. What we see is that we have cardiomyocyte hypertrophy as well as fibrosis. By 7 weeks, we start to have dilated left ventricle and left ventricle systolic and diastolic dysfunction. So this is a bit different from what we see in humans. And by adulthood, 16 weeks, we have dilated cardiomyopathy. What is interesting is that these data were published many years ago. And recently, Adam Lewandowski, again on the Oxford cohort, using a special technique with MRI showed that there was diffuse myocardial fibrosis, in fact, in the myocardium of the adults that they had scanned. And this was correlated with the diastolic function. So this indicates that our animal model and what we see is probably of relevance to understand what is going on with our preterm infants. So you all remember from med school, the renin-angiotensin system, and the angiotensin 2, if stimulating the AT1 receptor, will cause cardiac hypertrophy, cardiomyocyte hypertrophy, and fibrosis. And as my colleague just explained you in heart failure, for example, this is something that is considered to block this system, to limit the hypertrophy and the dysfunction of the left ventricle. So in our animal, what we saw is that there was an overexpression of this pro-fibrotic and pro-hypertrophy receptor called AT1 to the expense of the AT2, which is kind of the good guy receptor for angiotensin 2, which is anti-fibrotic, anti-hypertrophic. So in our animals, this is what we saw. I'll come back to this a little later. Another element I wanted to share with you is that myocardial dysfunction might be something related to mitochondria dysfunction. And why did we examine this? We know that in adults, whether they're in general born term, myocardial remodeling, cardiomyocyte hypertrophy, growth and fibrosis, heart failure are related to energy failure, and energy we know is mitochondria. What is interesting to think is that during early and late fetal life, the heart mitochondria especially functions with, mostly function with glycolysis to produce energy. But when the infant is born, all of a sudden there's a rise in PO2, there's a rise in vascular peripheral resistance because the placenta is cut off, left ventricular starts to do most of the work and needs to be facing all this. Therefore, cardiac energetic needs are markedly increased. So rapidly, the newborn has to be able to shift its capacity to produce energy in the myocardium from glycolysis to more efficient oxidative phosphorylation. And for this, the machinery needs to be ready. But when a baby is born preterm, what happens to this? So obviously we don't know the answer in human infants, but we did examine this question in our animal model. So again, they're exposed to this NICU stay, if you may, between day 3 and day 10 of life, and we've examined them at 4 weeks, so right after weaning, so in childhood, let's say. What we saw was that the mitochondria, which are indicated by the arrows here under electron microscopy, are a little bigger, they're disorganized, and their internal structure is also a bit disrupted. The mitochondrial content is also reduced in the animals who were exposed to oxygen. There's less mitochondrial DNA. What we also see is that they have a reduced oxidative phosphorylation capacity, and they still rely on glycolysis to produce energy. And this leads to increased intracardiac lipid deposition, as we see in other conditions related to metabolic syndrome, for example. So there seems to be, in the animal model, some dysfunction at the level of the energetic metabolism that might be contributing to the cardiac dysfunction. If we come back to the humans, obviously we do not have myocardial biopsies, and we do not have ways of measuring mitochondrial function and bioenergetics in the heart of individuals who were born preterm. However, what we did is that we measured humanin. Humanin is a mitochondria-derived peptide which can be found in circulation and is known to be mitoprotective. In our cohort of young adults who were born preterm, we did measure serum humanin, and we found that it was significantly decreased in the individuals born preterm compared to the individuals born term. When we correlated left ventricular ejection fraction to concentration level, the tertiles of serum humanin concentration. So here we have low, medium, and high tertiles for the preterm, again in blue, and the term in green. So left ventricular ejection fraction was indeed correlated. And the higher the tertile of humanin in the circulation, the higher the ejection fraction was, both for preterm and term. We didn't see any difference between the groups here. But again, these individuals are just healthy right now, even though we find subtle differences. If we measure left ventricular function by P global longitudinal strain, and this, thank you very much to Gabriel for his contribution. Again, there's a correlation between this marker of left ventricular function and the human tertiles, indicating there might be something to support the role of mitochondria and mitochondria reprogramming in the cardiac changes that we see in individuals born preterm. So what can you do? What can we do to change outcomes? And I think that now I've talked to you about adults, but I'm a neonatologist, so I want to know, and I'm sure most of you as well want to know, what can we do while these infants are just born and or are growing out of our NICU, but is still young children. So obviously, if we could reduce preterm birth, that would help, but that's another story. I think everything we do while the infants are in the NICU is really to think that these organs are still in development, and we should really, really try to avoid organ injury as much as we can. And as they go out of the NICU or even during NICU, avoid secondary hits or accelerated decline. For example, how can we support healthy organ development? Obviously, avoid inflammation and oxidative stress, such as sepsis or persistent hyperoxia. Avoid nephrotoxic exposure for our little kidneys that I didn't talk about. Optimal nutrition. Obviously, there might be future therapies that are being prepared now, the stem cells, to help for the lung growth and bronchopulmonary dysplasia. But could this be helpful for other organs that are important in the long course of a life? Long term, obviously, these children really, we need to avoid over as well as under nutrition, avoid respiratory infections if possible, immunization, prevention, promote healthy lifestyle habits. I was very surprised to see that 20 to 25% of our young adults born preterm, as well as our young adults born term, were in fact smoking. So this is really terrible, and this is a population that we should really target for effective smoking prevention, and we should be monitoring and treating their hypertension. So coming back to what can we do and what are future therapies that might be coming? I'm not telling you to do this, but back in the lab, we have treated with losartan, which is an AT1 blocker, our little rats, at the end of the oxygen exposure. And at 4 weeks, what we saw is that we had prevented the hypertrophy and the fibrosis we had seen in the animals that had been exposed to oxygen but not treated with losartan. So is losartan and blockade of the renin-angiotensin system will be something that as they grow, those children might benefit from? This is a question that needs to be examined. Also, we collaborated with Bernard Thébault. You probably know that he's developing treatment with progenitor cells to treat the lungs. And this is the heart of rats that had been treated with endothelial progenitor cells intratracheally and intravenously. And here are the data for the intravenous treated animals. And the lungs were improved. But what we saw as well is that the treatment with the progenitor cells prevented the left ventricle and the right ventricle cardiomyocyte hypertrophy, as well as the fibrosis, which is not shown on this slide. I don't know about the function. Was the function also improved or maintained? I don't know, but these will certainly be very important study to carry as these therapies are approaching our real babies. Another thing that is very important to preserve heart development is very simply human milk. In fact, in London, there had been a study of babies, preterm babies, whose mother could not or would not breastfeed, and the infants were randomized to formula or banked human milk. This is a while ago, and 25 years later, they were recontacted, and these are the MRI of the left ventricle of here. This is average image of MRI of 30 individual born at 30 weeks who had been randomized to banked human milk versus 16 born also nearly at 30 weeks who had been randomized to formula. And in fact, the shape of the left ventricle of the individual had been randomized to banked human milk was much closer to the shape of the left ventricle of the young adults who had been born term. Interestingly, as well as teens, the blood pressure of these individuals were 4 millimeters lower than the blood pressure of those who had been randomized to formula. So this is something very simple, but very important that we can do in our NICUs. Babies should get human milk. And this is another study out of the group in Oxford showing that even during the first months of life, there's a nice improvement of right ventricle and left ventricle ejection function with every additional week that the babies, premature babies, are getting mother's own milk. There's a significant improvement in their cardiac function. So in conclusion, because most individuals born preterm transition to adulthood without any specific health monitoring currently, and because for example, annual health examination is no longer recommended by the College of Family Physicians of Canada, and these individuals are not yet recognized officially as at risk for chronic conditions, could we integrate preterm delivery as well as preterm birth in the screening for risk of chronic diseases, like integrate this as a Framingham Plus targeted at our patient? Could we include preterm delivery and preterm birth in the risk conditions for regular health follow-up? We have other ongoing studies where we test how they respond to exercise. Can we improve their cardiac function, their blood pressure, their exercise capacity with exercise, and what is going on with their kidney function, which I didn't show today, but it would be a pleasure to talk to you about these studies later. I would like to thank the participants of our cohort. Some of them are pictured here holding their own baby picture, and they're such a fantastic group to work with because they tell us how they feel and how happy they are to be there. Their parents have told them so much how lucky they are. They recognize they're lucky. They want to make sure they continue to be healthy adults as themselves in turn are starting to have families. And I would like to acknowledge my co-PI, Dr. Trimai Lu here, and all the team that I do research with. And the funding organization, obviously. I'll now be happy to take questions or be present for the question session.
Thank you so much, Dr. Nuy. That was absolutely an outstanding talk. We've learned a lot, and I know that we will continue to learn a lot from all your work in the future, addressing this growing population of premature babies that are coming into the pediatric and adult clinics and changing constantly. We will keep the discussion for the Q&A session. Our next speaker is Dr. Ariane Morelli. She's a professor of medicine at McGill University, and she leads the cardiovascular health across the lifespan program at the Research Institute of the McGill University Health Center. She's the director of research and the associate director of the academic affairs for cardiology at the MUHC. She is also the founding member of the McGill Adult Unit for Congenital Heart Disease, also known as the MODE Unit, in honor of Maud Abbott. So Dr. Morelli is world-renowned for her expertise on adult outcomes of congenital heart defects, and she will provide us perspective on how some of these babies that come to our care evolve into adulthood. Thank you so much, Dr. Morelli, for being available today to share your expertise.
Gabrielle, thank you so much for the invitation. I've learned a lot, and my mind is full of new ideas for potential collaborations, which I think is really ultimately the goal of these conferences. I just want to ask, can you see my screen? Is everything okay there?
Not yet.
You cannot see my screen?
Wait, the support, Joanna, are you able to confirm? Dr. Morelli, can you try again to share your screen?
Okay, I see my screen on your I see my screen on your screen. So I'm surprised you can't see my screen.
Just you can have you clicked on the share button with the plus?
Yeah, and I can see my screen on the choose what to share. Let me just try this. Let me see entire screen share. Is that better?
Just messaged our floor support for this.
Here, share screen, share screen, share.
Joanna, are you able? Okay, so for now, we're not able to obtain the shared screen, it seems. Would you want us to?
Let me just try this again. It doesn't make any sense. Here, entire screen, I've clicked on it, share.
If not, what we can do is send me your slides and then I share my screen.
Sure.
If you want to do that.
Are you sure you can't see my screen? Because I can see mine.
I don't see it. Joanna is also on the line. Joanna, are you able to see the screen of Dr. Morelli?
Joanna said she needed to leave and come back.
Okay, you want to try to re-log in, Dr. Morelli? Maybe that's one of the issues. I will give you the link and then you can log in again. Okay. So in the meantime, I'll do a few just housekeeping. De se rappeler de remplir tous les formulaires d'évaluation que vous allez retrouver sur le site internet officiel de la conférence. Vous allez également retrouver sur le site internet officiel de la conférence les présentations en format PDF pour la plupart de nos conférenciers, ainsi que les enregistrements qui vont être disponibles. Vous allez également retrouver le témoignage de Madame Philopoulos en lien avec son histoire et la famille, et de Emmanuel. So just a few housekeeping while we're waiting for Dr. Morelli to log back in. We will have all the evaluation forms available on the actual website of the conference. And so please make sure to fill them in. And after that, you will find also the PDFs of all the presentations, as well as some of the recordings that our speakers agreed to share with us.
Can you see my screen now?
Joanna, can you see now if it's working? Not yet.
All right, I'm going to just send you my presentation.
Yeah, maybe, and I'll move the slides. Perfect. I invite everyone to send your questions that we will be using for the last Q&A session. So please do not hesitate to post your different questions in the chat, either in French and English. Si vous avez des questions, s'il vous plaît, les partagez dans la boîte de discussion et ça nous fera plaisir de les poser à nos panélistes dans un instant. Donc, I did receive your presentation and I will share the presentation. So let me hopefully share screen. Can you see the screen? Dr. Morelli?
No.
Let me just check. Just a second. I think there's a security problem. Let me just clear it. Let me try again.
Okay.
Yeah, I'm having also security issues. Share screen, Chrome tab. Are you able to see?
Yes.
Perfect. So let me
Okay.
just open it under the presenter mode for you. Just a second. Share screen, Windows, Chrome tab. And this should be working and you should see it now. So just let me know when you want me to switch slides.
Okay, fantastic. So we're in business. Yes, thank you. We all have to be technically nimble to survive in this day and age. So it was a great pleasure to hear the fantastic groupings of talks that we had today. And actually, Dr. Newitt's last talk is a perfect backdrop to what I want to talk about, because I really want to share with you some ideas about congenital heart disease across the lifespan and the notion that congenital heart disease across the lifespan is really the long arm of disease in the womb. If we go to the next slide, I have no disclosures. My work is funded by peer-reviewed public organizations. Next slide, please. I'm going to start with this slide, which is a really fascinating slide, which is from Mary Donofrio's work, where on panel A, you can see the flow to the brain in a fetus. And you can see the altered pulsatility compared to the umbilical flow that is in a normal fetus. And so what we see here is in a baby, in a fetus with a hypoplastic left heart syndrome, which this fetus has, you can see the altered blood flow pattern to the brain. On the next slide, what is really interesting is to note that this altered pulsatility is in fact what we see in patients who develop hypertension as the stiffness of their aorta changes when they are young to when they are old, over the age of 70. And it is in fact this altered pattern of pulsatility that promotes abnormal myelination in the brain and causes, or not causes, but it is associated with an acceleration of the kinds of changes we see in dementia. So it's very telling that we, go ahead, thank you, Gabriel. It's very telling that we have these very impressive changes that we see in the fetus and that we understand have long-term effects. Notwithstanding, if we could go back for a second, notwithstanding, you know what, I'll just raise my finger to you, maybe Gabriel, or I'll just tell you when we can switch the slides if that's okay. Notwithstanding the great success that we heard about in Dr. Bernier's talk on surgical successes and everything that we know has occurred in the latter half of the 20th century, and notwithstanding the tremendous pride that we feel in seeing our patients thrive, and they really do thrive. This is a patient of this is a picture of a patient of one of our patients who was featured in an article in the National Post. Next slide, please. There is no question that the disease that we see throughout adulthood, and that's what I'm going to try to show you, actually starts in the womb. So since this picture was originally published on the cover of Time magazine in 1965, and through the decades of progress, what we see here is that we really have the long arm of disease in the womb. And we can just imagine, based on the talk that we've just heard, which I thought was really fascinating, that we now have additional congenital heart anomalies superimposed on the burden that the premature newborn has with other organ damage. And I'm going to come back to that idea because I think it's just such a great bridging idea. Next slide, please. So against this backdrop, what I'd like to do is demonstrate that congenital heart disease is a lifespan condition, highlight the notion of exposure to risk and expression of risk, and the fact that exposure to risk starts in utero and is expressed across the duration of life. And thirdly, share with you some future, current, early, and future research directions to help us understand how, and again, here, the last talk was really such a perfect segue, how we can actually transform the lifespan to health span. And the reason that that becomes important is because we know that our patients do not just want to live longer, they really want to live better. And so the question then is, when does intervention start, and how do we measure the impact of interventions throughout life? How do we actually measure them? Next slide, please. So we've been able to show, we were very fortunate to be able to create the Quebec Congenital Heart Disease Database, and we were able to show the prevalence of congenital heart disease throughout the lifespan in infants, in children, in adults, and even in the geriatric population. And so we know that in infants, the prevalence of congenital heart disease is about 6 in 1,000. In children, it's about 11 in 1,000. And in adults, it hovers between 4 and 6 in 1,000. And of course, because of the distribution of age in our population, next slide, please, there are an increasing number of adults with congenital heart disease. This is taken from the Quebec Congenital Heart Disease Database, and you see here that by 2010, the absolute number of children, of adults with severe congenital heart disease in Quebec had surpassed the number of adults. And when we, next slide, please, we look at all forms of congenital heart disease, you can see here that in fact, 2/3 of the entire congenital heart disease population are now adults. Next slide, please. This is data taken from the United States, where we used some of our Canadian population health data and worked with the CDC to generate the numbers in the US. You can see here that severe congenital heart disease is only a small portion of overall congenital heart disease, but you can see here the numbers of adults with congenital heart disease in the United States is also in excess of the number of children, with an overall population of about 2.5 million. Next slide, please. And this is very interesting data from Sweden, which has been alluded to. And this is data that shows that the survivorship in children with congenital heart disease in Sweden has improved when you look at cohorts of patients born between 1970, 1979, 1980, and 1990, that we've seen over the course of time with the more recent cohorts, we've seen a decrease in an improvement in survivorship with a decrease in mortality. And this is not surprising, as the prevalence is always related to mortality. Next slide, please. But what's really interesting about this data is when you examine it further and more closely, what you actually see is that even though enormous progress has been made in childhood, once we start looking at adults, the progress in survivorship has not changed. So the question is the glass half empty or is the glass half full? Next slide, please. So in summary, for this first set of observations, we've demonstrated with population data in Canada, in the US, and in Europe that congenital heart disease is now a lifespan condition which can be documented and measured across the lifespan. It is no longer a condition that affects just newborns and children, but it is really a condition that persists across the lifespan in the form of a chronic disease. What are the biological implications of these epidemiologic observations? Next slide, please. So we have looked at a series of outcomes of congenital heart disease outcomes and their impact on morbidity and mortality in the last 10 or so years, looking at arrhythmias and looking at a high prevalence of arrhythmias, and I'm going to come back to that in a moment. Heart failure, showing that heart failure starts early and goes on with multiple readmissions and multiple reasons for recurrent hospitalizations. Coronary disease, which interestingly is not necessarily associated with a congenital condition, but is associated with the lack of proper surveillance, because we're so focused on the congenital disease that we actually forget to look after our patients' high blood pressure and other risk factors. Valvular interventions, which occur repeatedly. We're doing some nice work with Dr. Frédéric Dallaire, who's gathered some really fantastic clinical data looking at pulmonary valvular interventions in TOF patients. Stroke and neurocognition, showing the impact of stroke and neurocognition later in life. Cancer, particularly interesting data showing the cumulative burden of LDIR exposure. And finally, systemic diseases associated with conditions such as the Fontan operation. Next slide, please. So if we think about this idea of the cumulative burden of injury across the duration of life. This is a cartoon which we created with Michelle Kier, where we looked at this notion of cumulative burden of injury, which starts in the fetus and then impacts the infant, impacts the child, the adult, and carries over into adulthood. And really the idea here is to show that the burden of injury accumulates over time. And so what is the impact of that and how do we measure it? Next slide, please. So how do we actually know that this is true? How do we actually know that we have patients who may be actually aging prematurely? Because what we're seeing now is, and this is, something that we started thinking about in atherosclerosis, the difference between biological age and chronological age. And in our patients, that disconnect, that delta between their biological age and their chronological age is becoming more and more apparent and quite fascinating. Next slide, please. So in this study, which Judith Bouchardy did with us when she was here as a fellow from Switzerland, we can see that we have young patients with old hearts. We see here that the cumulative prevalence of atrial arrhythmias in a 20-year-old with congenital heart disease is similar to the cumulative prevalence of arrhythmia in a 55-year-old who does not have congenital heart disease. As you can see there, you have the orange line, which represents the patients with congenital heart disease and the risk of the cumulative risk of arrhythmias. And what you see in blue are males and females from the Rotterdam study. So this is an illustration of the fact that we in fact have young patients with old hearts. Next slide, please. This is work that was done by one of our medical students, Lee Sterling, who looked at the question of whether we had young patients with old brains. And what you can see here is that the younger the age of intervention, the higher the rate of neurocognitive abnormalities expressed over long periods of time. Next slide, please. This is work we did with Sarah Cohn when she was a PhD student with us, and we studied cancer. We've done a series of fascinating studies on cancer, looking at risk of cancer, thresholds for LDIR exposure, and most recently we've started to look at hematological cancers. But what we see here is we have young patients with more cancer rates that are similar and exceed that of normal populations in much older age groups. Next slide, please. Finally, do we have young patients with aging bodies? This is newer work that we're doing in Fontan cohorts. This is Carlos Guerrero, who was one of our fellows who's now gone back to Colombia. And what you can see here is the prevalence of Fontan-associated liver disease compared to a similar a cohort of patients with VSDs within the same database, and you can see the cumulative incidence of liver disease. We heard about kidney disease. I'm not going to show you that data, but there is now ample evidence, next slide please, that patients are in fact getting more and more disease. So this was a study that arose from a clinical observation. Jessica, we met Germain, was one of our fellows, and we were doing congenital clinic, CAF clinic, together with the TAVI clinic. And we had our young patients who were sitting there next to our TAVI patients who were over 80 years old. And so we asked ourselves, gee, wouldn't it be interesting to actually look at sarcopenia and frailty in these patients and to see if they resemble more their normal age-matched controls, or do they resemble more the patients that they're actually sitting next to in clinic? And interestingly, our Fontan patients actually have psoas muscle area and sarcopenia that actually resembles more the TAVI patients who are 85 years old, more so than their 30-year-old counter cohort. So this is early work where we're starting to actually look at markers of aging, biological markers of aging. Next slide, please. So if we want to change outcomes, as we understand that we start with the heart, we go to the liver and other organs, we go to the brain, and we wrap that all up with premature cancers. How do we actually do that? Next slide, please. It really is a question of understanding not just that we have a population of adults with congenital heart disease who are reaching geriatric age. Next slide, please. But it is a question of understanding that we have patients who are potentially aging prematurely, and we may have created like other diseases, an iatrogenic model of premature aging. And in this article, we put these ideas together, looking in fact at examining papers that have looked at telomere lengths in our patients and showing that we actually have biological markers of premature aging. So this is an idea that we're trying to understand, and we're trying to determine how best to measure. Next slide, please. So in summary, for these second sets of observations, we've learned from longitudinal follow-up studies that CHD can be repaired, but it can't be cured, and that we have persistent, lifelong circulatory anomalies that target organs at a distance from the heart, where we superimpose the burden of acquired atherosclerotic heart disease. What then are the key emerging concepts that will help us capture that, and how do we measure outcomes in patients with lifespan conditions? Next slide, please. I come back to this notion of exposure to risk versus expression of risk. And you can see in this cartoon that is very simplified, next slide, please, that what we're actually doing is we're looking at this exposure to risk, which gets magnified from early life to middle life to late life, and the expression of risk, which changes over time, and we're actually looking at clusters of risk factors over time, to actually map out trajectories. Next slide, please. And so if we want to model trajectories from a statistical point of view, it's quite a complex task, because what we have is we have congenital heart disease, of course, which is an effect modifier throughout life, but we have the impact of disease in the womb on disease in childhood on the disease in adulthood on disease in old age, and each one of these contributing to what we're calling a trajectory that we are trying to model. Next slide, please. So here we have done standard statistical models, for example, for heart failure in CHD. And this is a PhD student who came to work with us from China. And Faye was, diligently looked at standard statistical models, looking at patients who were born with congenital heart disease, who had subclinical heart failure, to the first hospitalization, to predictors of readmission, to predictors of death, to predictors of hospitalization, to predictors of death. And in each one of these segments, we did excellent modeling to really try to stitch together what might look like a trajectory of heart failure in congenital heart disease. But of course, stitching together time-dependent exposure variables is not really the way that we want to look at this. Next slide, please. So really what we want to do is, and this is a theoretical model of a trajectory, and you have function on the y-axis and age on the x-axis. And what we want to do is we don't just want to delay death as a time to event variable. What we want to do is we want to change the entire trajectory to show an improvement. Next slide, please. And so this would be an example of a trajectory, for example, in patients with TOF repair, where we want to delay death, but we want to also know at which point along this trajectory, when we do an intervention like a pulmonary valve replacement, are we going to be able to change the shape of that trajectory and the course of that patient's life. Next slide, please. And so this is very early work where we're using deep learning approaches, neural network approaches, and now some attention modeling, which are very interesting models to model heart failure trajectories over 25 years. You can maybe see it better than I can, but what you have on the x-axis are 6-month blocks for up to 50 years, for up to 50 times. So what we're able to do, and if you look at the actual versus the predicted versus the projected, we're actually able to start thinking about modeling these trajectories. And this is work done that was done conjointly with some colleagues in computer science, and which we're pursuing to make it, of course, more attractive to look at, but we're still in the early stages. Next slide, please. So in summary, for this last set of observations, we need to create new ways to measure outcomes along the life course. We're increasingly interested in shifting our paradigm from lifespan to health span. And the health span, as we've heard today, all day long, from different perspectives, really starts with fetal life. Next slide, please. So why is this important? This is important because we need to develop a life course epidemiology framework, which looks at transition points between the infant, the child, the adolescent, and the adult. We need to integrate our delivery of health services, not just vertically from primary care to secondary care to tertiary care, or from pediatric cardiology to from pediatricians to pediatric cardiologists. We need to integrate over the horizontal lifespan. That is what we need to be doing for a growing number of diseases where we are interested in understanding how the disease evolves over long periods of time. And this has tremendous policy implications in terms of how we deliver care. Next slide, please. So I leave you with some emerging concepts and methods, going from CHD outcomes in pediatric and adult patients to CHD trajectories across the lifespan, from chronological age to biological age, from episodes of illness to periods of wellness, from lifespan to health span, from quality of care to relative to standardized clinical practice, to quality of care related to personalized clinical practice, and from risk prediction to benefit prediction. This is a really important concept that we're working on. Why wait until we are actually preventing risk? Why not intervene when we can maximize benefit? And the research tools and methods that we're exploring to do that include a life course health development framework, include not just knowledge translation, but implementation science. We're starting to think less about just hypothesis-driven prediction models to machine learning generated prediction algorithms, which are less biased in terms of the data, from randomized clinical trials to comparative effectiveness trials, and from digital health tool implementation to digital health tool testing. And then we've had a lot of experience in Quebec using claims data, and we need to start to create, as was said, type of Framingham cohorts where we merge claims data with clinical data and DNA data, so that we can actually start to have a complete three-dimensional picture of not just the genetics and the superimposed disease, but also the impact of the epigenetics and the science, the translational science. Next slide, please. So I want to just acknowledge the patients who really inspire us, and we heard from a mother earlier this afternoon, the students and trainees who really are the vectors of new ideas, and I have students who really have some tremendously rich and original ideas that I'm extremely happy to work with. Our colleagues in life science and computer science to help us model new ways of thinking, and the funding agencies, of course, that keep setting the bar very, very high and thereby promoting the quality of our work. Liming, Iowa, and Chow, for anybody who's worked with me, they've been with me for a great many years. Chow is the most recent addition to our group, and he is an AI analyst. And we're very, very fortunate to have been well funded enough to keep a core group of people who have been working with our data and on some of these ideas. Next slide, please. And with that, I thank you for a wonderful day.
Thank you so much, Dr. Morelli. So we will bring everyone from the panel. Dr. Morelli, that was an outstanding presentation that brings us insight about the population we care for that are so vulnerable in our NICU and eventually in our pediatric ICU and pediatric clinic. And to see how they're doing in the adult world and get a better sense is so important for us. And getting that feedback also helps translates into what we do in the NICU and giving, I guess, us tools to provide information to the parents because they're looking always forward to what's happening later on in the life of their kids. We're going to bring in Dr. Nui and Mrs. Philopoulos on the line. I don't know if yes, perfect. Thank you so much all. Great panel, great speakers all throughout the day, but this panel is wonderful to conclude the day. We had a few questions, and I will start with Ms. Philopoulos. Sharing your journey and your story was really, really touching, and it gives us tools to be better doctors. So we had questions from the audience. One of them was asking, would you be able to explain a bit more on the whiteboard? They don't have one in the NICU. And relative to the whiteboard, what did you find, or what do you think would be helpful when it's being used as a tool of communication?
Okay, so hi everyone. So first of all, thank you very much for giving me the opportunity to share my experience. I apologize for doing the video outside. I'm not I was using my cell. So long story short, the whiteboard, as I mentioned, it's not something that was used when Emmanuel was at the hospital, but I did see it at the Montreal Children's in the PICU. And what it is essentially, it is like a whiteboard in each room, because now the PICU has individual rooms, is that they will write not only the treatment, but it's like a plan match, that you could see not only for the parent, but for the whole healthcare team. They have an idea of, the big lines of what's happening. So I think for certain parents that are maybe shy of asking questions, that will give them a visual explanation of the situation, right? And I'll just give you a perfect example, right? Like in my case, being a nurse, I'm not scared of hospitals. It's not something that intimidates me, right? But if I would compare myself with my spouse, it's something that is not familiar, and it's difficult for somebody who's not used to having all these machines and the syringes and whatnot all around. So it's very scary, right? So when you have on the whiteboard saying, this medication is off, and then you remove it, I think it just gives that reassurance of where you're heading. That's what I think. What was the second part? Sorry, Dr. Altet, for the
you can
question.
call me Gabriel. The question was related to what did you find, or what do you think would be useful in these whiteboards?
Well, I think everything from one, to clarify what the diagnosis. I'm pretty sure that many parents don't even understand what's going on or what the diagnosis was. So the surgery, the time frame, type of medication, maybe not the name per se. Obviously for the healthcare team, it's important, but for family members, I think it's more, okay, well, this medication, what is it for? Anti-inflammatory or pain medication, or, just globally. I think those, the small positive things that happen in a day, I think that's something that you should emphasize on, because from everything that happens in one day, you have so many ups and downs. And if you focus only, or not only, but if you mainly focus on something positive, like, oh yes, they removed the first chest tube. Yes, it's like a win. So just bringing that parent to the end of that tunnel, right? Because it's long days, especially women. I mean, you give birth, you're in pain, whether you had a C-section, your hormonals are all imbalanced, you can't breastfeed. You know, earlier you were talking about breastfeeding. Even if I had my pumps, I wasn't able to, and it was hurting. And then all these things are happening. So I think that if the parent focuses on that win, it will just alleviate that level of stress. And personally, I remember that certain parents, they were not able to handle stress very well. We're all different, right? So for me, I was focusing on Emmanuel and trying to like remove all the noises from the intensive care unit that was all open space. But some parents, they would start fighting, and it's not healthy, right? But at the same time, I understand them. Are they tired? Are they hungry? And you know, they start fighting with their spouse, and I'm sure that it's not because they mean it. It's just there's a lot going on. So I think that little win will just, you know, like put things in a better place.
It's a great advice, and something that probably should be applicable to many of the patient populations we care for in the hospital in general, not just NICU, PICU, but in the peds wards, in the adult wards, possibly even. Dr. Nuit, there's a few questions I received. One of them is, do we know what kind of side effect human administration has or would have on humans? And one other questions I got was, now that we have more and more 22, 23, 24 weekers that are at the extreme of the prematurity, what to expect for them? Do we think that the results are similar, and are they even more at risk of earlier cardiac disease?
So regarding the first question, well, thank you very much for the questions. Regarding the first question, to my knowledge, this has not been done. We have begun studies in our animal model, and we do see very interesting results, but studies are not completed, and we did not see side effects. But obviously, side effects in the pup or in the growing rat is not the same as in the real human. But I have not seen studies using human in even adults. No, that's for that. And for your second question, there is already 24 weekers in our cohorts, and in the currently published results of young adults born preterm, there are young adults who were born themselves at 24 weeks. I don't remember if we have 23 weeks. I think very logically, if you think physiology, it should be in the same direction with a same inverse correlation between changes we see and the gestational age at which the subjects were born, the young adults were born. So it should not be different. One thing that we did see is that for some data that I did not show, but there are some protective factors from antenatal steroids. Postnatal steroids is difficult to assess because you have to do a dose also relationship, because antenatal is a yes and no, but postnatal can go from milligrams to many milligrams, let's say. So these elements might change something that I don't know.
Thank you. We'll go back with other questions that are being texted as we go. Dr. Morelli, one of the questions that came up is, you discussed about the aspects of, you know, it's one thing to push the lifespan and it's one thing to try to promote a long lifespan, but it's much more important, or a big focus should also be there about quality of the lifespan and how to address this. And, you know, there's a lot of questions coming in about how do we define the quality, and how do we get to have, like, is it that we involve families early on? Is it that you involve patients? Is it through surveys? Do you have patient partners, parent partners? How are you able to assess, and how do they actually rate their quality once they get to your clinic?
So that's a beautiful question. Thank you for that. And we have a parent on the panel. You know, what is fascinating to me is that the child who grows up with heart disease doesn't know his or her life in any other way. They don't have an idea that, in fact, their life is not normal. And we get them, of course, when they're 18. And, you know, on that first visit, and I was listening to you, Sandra, talk about how overprotective you were. And, you know, it's a real weaning process, right? Because imagine when Emmanuel is going to be 18 and you're going to come to the mod unit and you're going to be sitting there and I'm going to say, well, you know, this is now about Emmanuel. And it is quite remarkable how we, and I have two children who are 23 and 25 at this point, and who my daughter has had health issues. And so I understand the difference between how I perceive it and how she perceives it. And so the quality of life cannot really be judged by anyone else. And I am very privileged to work with people like Philip Moons in Belgium, who we wrote that article together on Born to Age and where congenital heart disease meets geroscience, where he's doing a lot of work with patient-reported outcomes and really trying to capture that with those kinds of measures. It's not my area of expertise, that's for sure. But the where it falls into my jurisdiction is when families or patients say, well, and it's often the parents who ask, well, how long is he or she going to be living? How long are, you know, they come in and they've had, we're now getting all of the hypoplastic left hearts that are starting to be in their 20s. And of course, we have no idea, right? And they want to know that. But the kids themselves, that's not what they're asking. They just want to know, you know, and we have kids, like my kids are in their early 20s, to get them to think about 10 years down the line is very hard, right? They're thinking about, can I join soccer next year? Am I going to be able to go away to school? And that's what they're thinking about. And so I think part of the challenge when we look at improving the health span is actually putting ourselves in the place of the patients, not looking at them with a lens that belongs to us. And that has been, in fact, really the most rewarding part of this journey for me. Because I started becoming interested in congenital heart disease. I mean, the patients were my age at the time, and we kind of all aged together. So it's a very important question, but it's a very important perspective to remember that the patients don't see it the same way as the families and as the peers do.
It's super interesting. And you addressed a bit, you know, there's a lot of question that comes in about, yes, congenital heart disease is one thing, but then within congenital heart disease, it's like a huge spectrum. And now we're seeing kids with, or babies with hypoplastic left heart and sometimes extremely severe. And what really happens to these patients later on. So there's a bit of a distress also that happens around healthcare professionals that don't really know what to tell the parents and the families about, well, what to expect later. And so, you know, having insight from what you do is going to be super important, but even more so, I think having insight from actually these adults and these kids that are growing and giving us the information about, well, this is how I am and this is how I feel my quality of life is and what is important for me is going to be super important for us to be able to help the future families. And I want to, Dr.
One thing that I would say is that, you know, when we get the kids and they come with their families, very often, you know, like in the pediatric environment, of course, they want to get to the point where they graduate the kids at 18. They come to us, we need another like 40 years, 60 years from them, right? And just leaving it open a little bit, not really kind of finding that balance between saying, you know, you're fine, you're cured. And we found, we looked at, rates of dropout during transition. It actually starts at age 12, because at age 12, the kids are doing really well. So they actually stop going to the doctor, and then they come back 5 years later, and then, maybe they show up in our emergency room and they're pregnant at age 20 and they happen to have a Fontan operation. So just to give us a little bit of leeway in those confidence intervals, where we can actually, modulate expectations a little bit, to say, when you come in with an AV canal repair and you have a lot of mitral regurgitation, you've got to give us a little bit of leeway to say, I know you're not feeling very symptomatic, but we need to intervene on this mitral valve before it gets really bad. So that's a big part of our work.
Can I add something that you made me
Absolutely.
think? So obviously, Dr. Dancia, who's he's been just amazing up to now. And he's the type of doctor that gives you all the facts, right? And he explains everything very clearly. And that's the part that is extremely important. I'm giving that message to all of you, because we take that and it stays, and we try to follow those, what you guys ask us to do, or what the situation is all about. So being a cardiac baby, so even if he's stable and he had his surgery, he had his repair, he has no medications and whatnot, at school, obviously, every year you have to write down, and even for camps and whatnot, medical past history and medications. And so every time that I write, TGA repair, but stable, like I always put it in big, no worries, he can do everything. I was always getting a call from school. He's running a lot and he doesn't want to stop, but he loves to run. He just loves to run, and even if he gets red, I always tell the school, he knows when to stop. Emmanuel will tell you if he's in pain, but he's not in pain. He's good. So you brought a really good point, Dr. Mariali, is that it's very important that the family is aware of, what's the limit, or what could happen, what are the signs and symptoms, to be clear on the situation. So we as parents can give that information to the schools and whatnot, because you don't want that child to think at a certain point, oh, well, if everybody thinks that I'm sick, maybe I am sick, right? Because now Emmanuel is at an age where he loves to run. He doesn't see that like you said it very well. The only time he remembers that he had a heart surgery is when we take the bath. And so he sees his incision, or if another kid sees his incision, that's where, it becomes touchy and he thinks about it. But other than that, he's a normal kid. So you brought that point where I think comes an age in his life, probably in his teenager, right? Where he's going to be more reluctant to listening to what other people may think, or may put him in that box that he's a cardiac kid. Mm-hmm. So you brought that point.
And I'm wondering, Ms. Filippo, just to take you on that, you mentioned during your talk that one of the very hard moments during your journey was the actual disclosure of the diagnosis. And hopefully we're getting better, because we're trying to get better as doctors to disclose and be there for families during these very challenging moments. But I was just listening to you, and I'm wondering, should there be parents more involved with new diagnosis? Should there be there as mentors? Should they be providing also support to say, I've been through that, this is what I lived? Yeah. Like, what's your perspective on that? Do you think it would have been helpful, or at that point you were so overwhelmed that you're like, you know what, I don't want to see anyone? Like, what's your take?
Yeah, so that's a very, very good idea. So I think it goes with the personality of the parents. So each case is probably different, because I'm the type of person that likes to know everything and more than enough, so I can prepare myself mentally, because that's how I work, right? So I can vision and I can do, everything. So I can give everything that I can. But certain parents, they don't want to listen. For them, it's finished. And the perfect example is, I'm surprised that a lot of parents, I've been told that once the kid leaves the hospital, they're not in touch. They don't want to know anything about it, because for them, it's a bad memory. And I respect that. So to bring to your point, I personally would have preferred having that big, announcement, right? Because it changes your life. I mean, forget it completely, right? On that day, I think that maybe no matter what type of personality is, there should be the cardiologist, but there should be maybe the nurse there, or like a team, because everybody were different, right? So the cardiologist who's giving the information, he's also, or her, you guys are all humans as well, on that day, are you tired, or have you been on call, and was something happen in your family as well, and maybe you're not like on your best that day, and that could happen also, and it's okay. But that moment, I think if there's somebody else in the team, then maybe you can balance it out and feel more comfortable, let that person feel more comfortable.
Thank you so much for sharing that. Dr. Nui, I want to ask you a question, because we're piggybacking on parental and perspective of the actual individuals. And you've been through these studies where you've been in touch with so many of these adults born preterm. And right now, at least locally, and many of the centers will follow some of these kids until 3 years of age, maybe 5 years of age. And we talk about, this was their Bailey score and things like that. And really the perspective of these adults born preterm is sometimes like completely unknown to when we counsel families, or when we take care of these children. And I'm wondering, what's your own experience and perspective on that? Like, you've seen so many of them. So what kind of feedback can you give us?
Well, interestingly, the story about their preterm birth and their stay in the NICU is the story of their parents. It's not theirs. They've heard about it, but obviously they don't remember. They remember coming to the follow-up clinic, and it was really funny because when they would come to the visits, they would remember, the same, oh yeah, I also have that silly toy in the waiting room. So that they remembered and they shared between them. But their perception of health is very good. And we've published 2 papers on that, health perception of young adults born preterm, and others have as well. So, but they do feel that some little things might be different. Their exercise capacity, they feel that is not as they would hope it is. And they're really looking for answers, because they find their family physicians or their parents were not told what to check or what to expect. And in fact, because we didn't know. So they're very much eager to get information. And the way they told us they want to get that information, they want their family physician to be aware of what to check, which is quite a task. It's for us to tell them. And probably also families. We should be teaching families about longer term outcomes, so that in turn they can teach their adolescents and then young adults as they grow. That's what I would say. They very often tell us that their parents have been overprotective. They have
probably
learned to live
for all the population we care for. Sorry, I cut you.
That's okay. They do also feel that sometimes they have scars for PDA ligation, neck, but they explain us how as they have become adults, they have accepted these, and it's part of who they are now. And many of them say, well, now I'm proud of it. This is part of who I am. It's my journey. I'm a survivor. They're very proud of being a survivor. That's what I can share. See the papers that we've published on that by Camille, and she's a student in doing a PhD with us, and she herself was more preterm, so she has an amazing perspective.
Mrs. Philopoulos, Dr. Nui, Dr. Morelli, thank you so much for sharing your perspective, providing insight, and really enlightening us about how these babies that we care for eventually become. And from a familial perspective, a doctor perspective, this is extremely valuable. And I'm sure we'll provide the audience with tools to better have a sense of what's happening later on, because we care for them in the NICU, but then after that, we don't really see them sometimes. And it's important we know what's happening after that. So on this note, we'll close this panel discussion, and we'll have Dr. Gosselin join back for the word of conclusion of the day. Thank you so much.
Thank you.
Merci Gabriel. Ben, quelle belle finale pour la journée d'entendre les parents et ces discussions sur l'évolution de nos patients. Excellente journée, plein de belles idées, plein d'informations. Je voudrais remercier d'abord les participants qui ont été avec nous aujourd'hui, tous les conférenciers, nos commanditaires, le comité organisateur, dont Dr Santana et Dr Alti. Je voudrais remercier PBSF qui nous a permis d'avoir cette conférence-là en mode virtuel, notre personnel secrétarial en néonatologie au CUSUM qui nous ont donné beaucoup de soutien comme à chaque année. J'aimerais demander aux participants d'aller sur notre page web pour remplir les formulaires d'évaluation et je vous invite à nous joindre l'année prochaine, en mai ou en juin 2023, où on pourra sûrement, on l'espère, tenir notre conférence en personne. Alors, merci beaucoup et bonne fin de journée.
Technology is increasingly present in our lives, shortening distances, bringing faster solutions, and with more practical ways of living day by day. We believe that for all of this to make sense, every solution needs a reason to exist. So, why not focus on using this technology to solve real problems in our society? At a time when neonatology had an important reduction in mortality, and today it has the challenge of preserving the quality of life of patients and their families, in a scenario where the number of children with disabling diseases is very large, representing a hard socioeconomic burden in Brazil and in the world. In a country of continental proportions where the heterogeneity of resources, protocols, and conducts represents a harsh reality. PBSF, Protecting Brains and Saving Futures, was born with the motto of bringing accessible technology and intelligence to prevent neurological sequelae, as with the objective of promoting initial and longitudinal education and training, and also facilitating the implementation of methodologies and tools for early diagnosis and neuroprotection on a large scale. And for this, we created the CSI, a central of surveillance and intelligence where we use an advanced telemedicine system to break borders and shorten distances. In this scenario, we've already monitored more than 4,000 children in more than 270,000 hours of monitoring, distributed in more than 30 hospitals located in all 5 regions of the country. In addition, we're extremely pleased to work with international partnerships with a focus on education, research, and technological development. But we want to go further, generating homogeneity of protocols and conducts between distant centers and with different resources. With intelligent monitoring, longitudinal education, and capacity building, we can better serve high-risk babies. Together, we can make a difference in the lives of each of these little patients. We believe in the fundamental importance of each of these children being able to read, learn, and believe in tomorrow. Only in this way can we build a country and a better future. PBSF. Learn more at pbsf.com.br.